Professor Priyankar Pal sir and Dr. Pilania from Chandigarh, and also many thanks to Jigna and Dr. Archon and Dr. Prabhal for arranging this fantastic seminar. And so welcome you all today, and we'll be starting with the workshop right away. I'm Dr. Devdatta, this is me. I'll give a very short presentation on how to see the coronaries, a focused view of the coronaries in the Kawasaki disease. We'll have the talk here and then we'll shift to 2 rooms down the hall for the hands-on demonstration. Okay, so thank you. How do I swipe? Actor, there was this, and the pointer, please. Pointer, please. এটা এখানে হচ্ছে ওখানে হচ্ছে না. Yeah. So this is the holy grail of examining the coronaries in KD or in general. So this is, you can see in the middle, if you take the parasternal short axis view, you can see in the middle there is this aorta en face view of the aortic valve. On the right hand side is the right coronary artery. This is the main left coronary artery, the left anterior descending and circumflex. So we do have other views for demonstration of the arteries also, which we will be showing, but this is the basic of it all. And again, when we start, we take the short axis view with the probe pointer pointing towards the patient's left shoulder. And what is the nomology of it? That is, for more resolution, we use a higher frequency probe, such as the 6S probe for children, the 12S probe for even smaller children like infants and the newborns. And we do not increase the depth much. So that would give us a higher resolution. Also, we reduce the grain, reduce the frame, increase the frame rate. That these are various points in the machine you will find when we demonstrate. We increase the frame rate, we reduce the sector depth, and also zoom in. For all the measurements of the coronary arteries, we zoom in to increase the picture and take the measurements from inner edge to inner edge. So going to the next slide. So this you can see, the probe is over here with the probe pointer towards the patient's left shoulder, and this is somewhere in the upper chest, it's somewhere in the second or third intercostal spaces parasternally. Sometimes it may be higher up, also may need some slight tweaks of the hand to get this view. The aorta, the right coronary artery, the left main artery, left anterior descending. And these are the other ways where we can get the views also. And these are the basic views, because when we check the echo, we check for the structure, the function, the anatomy, and also the focused view of the coronaries. Important is that since KD is involving both the coronaries, the myocardium, as well as the pericardium, as well as the endocardium. So there may be some valvulitis, there may be myocarditis leading to decreased cardiac function that we see mostly in KD shock syndrome, and also pericardial effusion. So these are the basic views of the heart. Putting the probe at the apex, right at the apex, pointer towards the left, we'll get the apical 4-chamber view. Putting it just below the xiphisternum, we get the subcostal view. And then parasternal long axis view high up, this one, where the pointer is towards the patient right shoulder. And this view is very important for checking the function in children. This is the en-face view of the LV. You just rotate this probe 90 degrees with the pointer towards the patient's left shoulder, and we get this view. And if we put it tilt it slightly higher up, we get the view for the coronaries. So, and here we are again with the views of the coronaries in details. One thing to remember that the angle of the beam should be parallel to the angle of the to the direction of flow of the coronaries. For example, this is the coronaries and this is the angle of the beam. So it shouldn't be right bang at right angles. In that case, we will not get the color flow. So we have to be aware of that. And of course, we must put it at very low scale with a Nyquist limit of about 30 or 40s. Basically 20s or 30s would be better. So remember the 4-chamber view, and if we tilt it slightly upwards, we get the 5-chamber view over here with the aorta opening, and we can see the LMCA, the beginning of the LMCA over here, and this is the right coronary artery over here. Also, if it go behind, if we just tilt the probe behind, just close to the coronary sinus, we can see the shadow of the left circumflex artery also. And this is just to give you a visual impression of a very dilated left main coronary artery. There is huge dilatation at the bifurcation also. And these are the giant, this is the aorta, this is the giant aneurysm of LMCA, LAD, as well as a fusiform aneurysm in the RCA. And this was another child who had, it was a small infant who had developed these kind of thrombus in the left anterior descending and the left main coronary arteries. So required a lot of other antithrombotics and anticoagulants. And this is another huge dilated giant aneurysms in the LMCA as well as the LAD. So, and here we see we have the unconventional views. See, we have taken the 4-chamber view, but if we tilt it slightly anteriorly, we will again get towards the apex, we can see the LAD. So this is the normal left anterior descending artery which is going down along the septum. But here you have a giant aneurysm of the LAD. See, this is the aorta and this is the LAD that is coming out, and it is huge, almost as big as the aorta. So some caveats that we need to remember. Sometimes there are pericardial sinuses that just mimic like the coronary. So we must put color. Like I said, the color direction should be parallel to the beam in which we are putting the probe. So if there is no color, then it is not a coronary. So the pericardial sinuses can be mistaken very commonly as coronary arteries, and sometimes coronary veins, they are also dilated and they're maybe picked up as dilated arteries. But remember that the direction of the coronary veins are different. If LAD is here, say, and it is red in color, usually over here, if it is a vein, it will be blue in color. And of course, here you can see some anomalous origin of the coronary arteries. See, this is the intermural course of the left main artery between the aorta and the pulmonary artery. In the coronary is arising and having a course in between the two arteries. So these arteries are very prone to ischemia, spasm, and others. And of course, sometimes myocardial bridges may be also mistaken as aneurysms. So CT scan is always a very, very big help to delineate the coronaries, thrombus, stenosis, especially the left circumflex and all. And this is a child who had come with sepsis and pericardial effusion, you can see over here. And you can see the elevation of the ST segments due to the pericardial effusion. It was a staphylococcal sepsis, and see the dilated, sinuous coronary, LMCA and the LAD. Up here we have a uniformly dilated ectatic LAD, and this child in a convalescent period had a huge thrombus in the RV. So this is, I think, the last case, and you see There is a lot of regurgitation over here. This is the mitral valve, severe dysfunction in the LV with a lot of regurgitation. Why? Because probably because of ischemia, one of the chordae was torn, partially torn, leading to severe mitral regurgitation. The boy was an infant presenting with shock, severe dysfunction, and later we found that there was some RCA stenosis also. This is the RCA, and this turbulence over here and subsequent Doppler pattern shows that there was definitely stenosis, and there are STT segment changes also over here in leads 2, 3 and AVF. So I'll just end my talk over here. We'll go over to the practical demonstration, two rooms down, where we can show you how to see the basic views of the coronaries and how to check the function also. Thank you. Then the resolution comes down. Resolution means how clearly it is given. Okay? So the resolution comes down. So then over here I can see the 4 chambers, right atrium, right ventricle, a little bit of tricuspid valve, left atrium, mitral valve and the LV. And I will just go directly to the short axis. We hold the probe again in the same way, pen-holding position in the upper and we will pull this up down, turn this upside down. We pull up down. There are some, I have just gone straight to the coronary view. See, the marker is on the left side of the child, left shoulder. And see, this is the aorta, the 3 cusps of the aorta. And you can see how the left main artery and the left, if I press order, it will have its nice resolution. You can see something coming out of this. See, this is the left main coronary artery. Okay. And you have the left anterior descending over here and the circumflex over here. Circumflex somewhere over here and the LAD over here. Let's put some color. Whenever we check for coronaries, we always must check for put the color. If we don't find the color, then we are just coming down on the velocities on the scale. See, 35 or 30, okay, that, or even 20. See, the coronaries are having little bit of is away from towards the room. So if the room is like this, that is why it is because if it was like this body, left. Everybody do away, went towards right. flow in the cardiac from the this is the
as distally as possible. This child basically has a dilated left main also, and the whole system is dilated. Also one more important thing is we try to put color in it, because sometimes we have pericardial folds which mimic the coronary. So color may or may not be seen a lot of times because of the angle of inclination. So we try to decrease the scale as much as possible. This is the 9th one.
But then you can always ask her to use the neck properly. You can always ask her to oh wow. Oh wow. Thank you so much. See, that's the neck vein, and you can see the left ventricle descending and a bit of the circumference.
It's not much visible. These are the locations of the coronary. Now, same coronaries we have to see in other ways also to confirm whether they are actually dilated or not. By this, we'll again turn the upside down. And in this view, we find the LCS.
If I want to trace the whole of the
क्या कन्वर्ट है all the study हो गया
That's what's next. Can we have a smaller, Anindita, can we have a smaller kid here?
Yeah.
Because this board is actually for a very elder relation.
6 years yet.
6 years.
entire length of the image as much as you can. See the entire length of the image.
6 years when ideally the thing is that for big kids we have to use, but still for this big kid you have to see the
not
body
have it in the
6
same
years
place.
a small, a larger frequency. 2 minutes. और इसके अलावा
Yes, this is the right quadrant. Also over here, which is and you have a fusiform aneurysm with the mid and distal artery. So that is about 5 millimeters. That's like this and like fusiform. Over here, we have in the picture.
this is the right quadrant. Mid portion of the right quadrant. This is not the original. You have to go. This has a mid RCM as well as the proximal, and along with it, moving the probe towards the right. So in many conventional things, it is before going demonstrating the LED. Once you get the left main, you should go a little up, maybe one space up, you find at some point of time, and the division. And all the measurements are supposed to be taken either just a little above before the starting or a little distant to the starting, because these are the sinuses which will already be dilated. Now, after seeing the coronary, what is important is we'll just see if we can see these similar coronary in our groups.
View of the heart. Right ears to right ventricle, left picture, left ventricle.
This is also dilated here. Scope is small, we have to be B is pointer. Where is the pointer? Left. This is the pointer. Upside down also. Left pointer, left. When we go to the right, this will be right and pointer. Pointer is always towards the left. And up down for the short axis, long axis view, upside down. And for the subpostal and the vital chamber, this
Mummy is very expert. Just now she has given the Aspirin. Papa is a bit shaky.
Over here you can see the
So similarly, just touch the twice aperture first of all basic structure, and second one if there are any dilatations, now we just go upside down. Now this is a huge aneurysm. Just increase the blood as much as size of the So this is multiple saccular as well as fusiform aneurysms everywhere. This is a starting of the whole LED. It's just like the diameter is as much as the diameter of any of the great vessels. This is the aorta, this is the pulmonary, this is the LED, this is the RCA. Everything possible is dilated. This is the left main. So we can see the color. Because pulmonary we always see color, whatsoever may happen. So, but in LED, color is like practically, we have to decrease the scale as much as possible. If I decrease the scale only, then I will be able to see. So there are all the colors. So pulmonary and because color helps in treatment.
we should not use sharp.
And if we go little towards the right, we'll be able to visualize the right side more and tilt. If we tilt, we'll be able to see the right system more better. We are able to see all of the proximal, mid, distal, everything is dilated. Important is how do we measure. Inner border measurement is very important because these days only the Z-scores are important. No FPCRs, no perivascular mapping. These are not included in the diagnostic criteria. Whatever is important is the sizes. Sometimes, and the important thing is if we optimize our machines, they'll come in 2 digits, 4.31, 4.56, so we get better visualization. So similar thing we'll try to see in our 4-chamber view. Whatever we have put it in the long axis and short axis, we'll try to find the same things in our 4-chamber. Able to see the left. Here you can see left. This syndrome, we had already seen in our short X's, and now we confirm this in the long X. First, when school are the both are not well defined, but sometimes in the intermediate, just see the
and we can always measure by inner edge to inner edge. This appears to be the edge. I think this is the
sometimes we also see rods and thrombus in that.
more clinical also has its own this one.
Why is it important is to see the decalculation? Because in 10% of the cases, there can be a possibility of getting the
Let's check with the always check with the other. Long you put the scale down for this velocity. We should always put the scale down and check with the other. Then sometimes there are a lot of bradycardial folds over there, so they are mistaken to be RCs, especially in the six. Sometimes
So left pointing towards the left shoulder.
Towards the probe, so
Right shoulder is long and just pointing towards the right shoulder. And 1 o'clock position. 11 o'clock position gives you the long axis, and 1 o'clock position gives you the short axis, where you can see actual traditional coronary. Long axis. Long axis is the easiest move. Whenever you get the long axis,
sometimes when we have a
whatever comes out in the
this is sometimes when you have a dilated delivery around the whole course, see here you can find the non-seeds. This is the fourth chamber view, we tilted upwards and this level here
and then it will deal with this whole system is dilated to the whole system and left main
because it's dilated is
the C-spose enhances to for the non-conditions we just hydrate and C-spose is non-conditions. And the whole system is what we regulated system
না আমি দেখাই না
এই ব্লকটা খুবই কিন্তু এখন নিচের উপর করলে ক্লিয়ার করবো হয়ে যাবে তো কাজ তখন ব্লকটা ক্লিয়ার করবো ওইদিকে সব এই দেখ এইখানটা ফাঁকা জায়গাটা ওদিকে সব তোর ডান দিকে সব ডান দিকে সব ফাঁকা ছিল ওখান থেকে ওই ভিডিও খুলে দিয়ে
मेरे घर में जैसे मेरे पापा का भी चाय
A very good morning to one and all. First of all, we thank all our guests because yesterday it was a very overwhelming response. We had most of our guests who were here till the very end. Even the medical ethics session was quite full and very interactive. So let us start off day 2. We had a very active eco workshop right now. As many as 45 delegates had attended the workshop, and we sincerely thank Dr. Devdatta Mukhopadhyay and Dr. Rishika Mehta for helping us conduct this workshop. Hopefully it was a learning experience and people have gained something from it, although it is not as easy as it looks. So without much ado, we'll start off with the sessions today. For the first session, I'd like to call upon Dr. Joydev Rai, he's the principal at Institute of Child Health, and Dr. Minal Kanti Dash, he's the HOD of Pediatrics at SSKM.
Good morning, everybody. At the beginning, I like to thank the organizers for inviting me in this session. Today, it is the beginning of the Kawasaki session, though workshop was there. I think the disease is for pediatrician, it is not for rheumatologist. So this awareness, which has increased too much during this session, I think it will go to the peak, and the people who are here will be benefited much by the speech of our beloved speaker, Dr. Moumita.
Moumita is the professor and H2 in charge in pediatric medicine at the Medical College, Kolkata. And I am fully agree with Minal because awareness is increased. Because you can see, you can have a look at the hall. It is the first session, but in the hall you can see the so many pediatricians is eager to hear this. And really, now every day we are getting the Kawasaki disease. It is due to definitely awareness is increased. For that, I will give the credit to the rheumatology team, and also not only the awareness. I think from the Western data, it is also evident that the incidence is also increased. With this, I am telling Moumita to deliver your speech.
Thank you, sir, so much. A very warm good morning to everybody. I am here to discuss the diagnosis and management of a typical Kawasaki disease. So starting off the brief history, it was in 1967, Dr. Tomisaku Kawasaki had reported 50 cases in children, described it as acute mucocutaneous syndrome, a combination of fever, rash, conjunctivitis, lymphadenopathy, and what he described so many decades ago still holds good today, as the diagnostic criteria remains almost the same and not much has been added to it. Now, by that time, Dr. Maria Melish from Hawaii also independently reported similar findings from the United States. It was in 1970, a group of doctors led by Dr. Hirohisa Kato conducted autopsy finding in these children and found coronary artery aneurysm as a complication of this disease. A decade later, KD was recognized as a leading cause of acquired heart disease in children. By 1984, IVIG becomes standard of care to reduce coronary artery aneurysm, and by 1990 to 2000, Kawasaki Disease Foundation was established to support research and the families. So, it is a commonest childhood vasculitis and a commonest cause of acquired heart disease in children across many countries. It is common in children under 5 years of age, peak age at 9 to 11 months. Mortality rate is almost 1 to 2%, and the peak mortality usually occurs between 15 to 45 days when the vasculitis is at its peak and aneurysms are at its peak. If untreated, 25% children develop aneurysms. A family history is seen in 1%, recurrence risk of 2.5 to 3%. Now, the pathogenesis is basically a genetically predisposed person is exposed to some kind of an infective trigger. The exact etiology is still not known till date. Some say it is a non-typable RNA virus, some say an environmental factor, resulting in a cytokine storm, neutrophilic leukocytosis, resulting in pan-necrotizing vasculitis of the medium vessel, especially the coronary arteries. This results in aneurysm, and even if the aneurysm subsides, there might be permanent loss of coronary vasomotor reactivity, predisposing to early myocardial infarctions. So AHA 2017 laid the criteria, and AHA by 2024 had also updated it. What does AHA 2017 say? Fever for at least 5 days with 4 of the following. There will be changes in the eyes, oral mucosa, peripheral changes, skin changes, along with unilateral cervical lymphadenopathy. By 2024, the criteria gets modified slightly as fever for at least 4 days with any 4 of the 5 principal clinical features at any point during the illness. The symptoms need not be concurrent, need not be present at the same time. Mainly, we will have bulbar conjunctival injection without exudate, polymorphous rash, oral changes in the form of erythema, cracking of the lips, strawberry tongue, erythema of the oral and pharyngeal mucosa, peripheral changes in the form of palmar and plantar erythema with swelling, and in subacute stage, periangual desquamation, cervical lymph nodes unilateral occurring in clusters, and the illness should not be described by or explained by alternative disease process. So the common illness, before we diagnose KD, we should not forget infections by adeno, atypical measles, staphylococcal scalded syndrome, toxic shock syndrome, PAN, and Shogia. They can mimic KD. Clinical course spans over 12 weeks. Acute phase, the child is having high-grade remittent fever, not responding to antipyretics, not associated with the usual viral catarrh. It's like a dry fever. Disproportionately irritable, changes in the eye, skin, oral mucosa, lymph nodes, and peripheral changes may be seen. In the subacute phase spanning 3 weeks, he develops peripheral desquamation, thrombocytosis, and coronary artery aneurysms. Convalescent phase spans for 6 to 8 weeks, where the inflammatory markers normalizes. So the clinical features are bilateral non-exudative conjunctivitis with limbal sparing. That is very important. 1 to 2 mm of the limbal region is spared. Anterior uveitis may be seen in some, helps to differentiate from viral illness. Subconjunctival bleed may be present. Strawberry trunk and redness of the lips, vertical fissuring of the lips is very important to diagnose a case of KD. Now, skin changes are seen in 90%. In Indian children, we also see desquamation at the urethral meatal redness. And the last picture, this one, it is pretty common in Indian children. We see this is perianal desquamation. This occurs, in fact, before the periungual desquamation sets in. So we have to examine the child that way. Lymphadenopathy, as I have described previously, multiple unilateral. Changes in the periphery are seen in 80%. Redness of the palms and soles with indurative edema, chromonychia, second week periangual desquamation, and in the second month, we can see Bue's lines, onychomadarosis, pincer nails. Now, dactylitis. Dactylitis is also pretty common. Recently, we had this child, 4 years, 6 months old, with fever, not responding to antipyretics for 10 days, and features of typical KD. He had bilateral conjunctival non-exudative conjunctivitis, erythema of the oral mucosa, cracking of the lips, anterior cervical lymph nodes, and very painful swelling of the fingers and toes for 4 days. So he had dactylitis. Others are BCG scar reactivation, pathognomonic of KD, appears in the acute stage. Now, the other clinical features can be multi-system. There can be CSF pleocytosis, transaminitis, GI manifestations, and others. I would like to share this case. This child was 1 year, 2 months old. At the periphery, he presented with fever for 10 days with convulsions, CSF pleocytosis, protein sugar was more or less normal. So they thought it was a viral meningitis. Managed symptomatically, child develops respiratory distress, transferred to medical college. We put the patient in HDU. What we found was child was having typical rash. He had oral mucosal changes, eye changes, typical of KD. Now, we saw that he was having transaminitis, almost at the range of 580. SGOT was almost 580, and his NT-proBNP was 14,000. He was having myocarditis as well. So that was the cause of his respiratory distress. It was a typical KD. We did echo, and it showed small aneurysms too. Cardiovascular manifestations, besides this, there can be pericardial effusion. It is common, but tamponade is rare. Myocarditis is universal, but clinical discernible myocarditis is seen in only few. Only few patients go in KD shock, which is a difficult shock. Along with this, there can be valvular regurgitations. Now, guidelines of echo, and if clinically you have diagnosed KD, do not wait for an echo to initiate therapy. And in a typical case, if we do an echo, we do at the onset, then we do at 2 weeks, we do at 6 to 8 weeks. But if at 6 weeks also there is no aneurysm, usually we don't need to do a follow-up echo. But if there is a ectasia or an aneurysm, we have to do more frequent more frequent echoes in the acute stage, almost every 3 days. No single lab test is diagnostic. Lab test combined together is suggestive. So there can be anemia, normocytic, normochromic. Child can get hemolysis after giving IVIG, especially if in an obese child, we do not calculate IVIG based on the his lean body weight. There's leukocytosis neutrophilic, leukopenia such as MAS. If you see lymphocyte predominance, think of other diagnoses. Thrombocytosis is common, second week and third week. But if thrombocytopenia is present, it can be KD with MAS, it can be a KD shock, it can be KD with DIC. Hyponatremia, hypoalbuminemia, raised transaminitis, they have poor prognosis. Sterile pyuria and USG abdomen can reveal hydrops. ESR, CRP should be monitored, but after giving IVIG, we have to monitor CRP because the ESR can be elevated. So when it is not KD, if child is having exudative conjunctivitis, exudative pharyngitis, oral ulcer, vesiculous lesion, splenomegaly, bilateral cervical lymphadenopathy, think of something else. A low WBC count, a lymphocyte predominance, and a normal inflammatory markers. Now, just to touch upon, an incomplete KD should be diagnosed in any child with prolonged fever and less than 4 of the principal clinical finding with a compatible lab or a compatible echocardiographic finding. The therapy is the same, but we need to identify it because if we fail to identify, the chance of coronary artery aneurysms are much higher. Who is a high risk? An infant less than 6 months, a coronary artery dilatation of more than 2.5 Z-score at admission is a high-risk patient. Now, just briefly, what is suggestive lab? 3 or more of the following: anemia, there is thrombocytosis, hypoalbuminemia, elevated ALT, elevated WBC count, sterile pyuria, or a suggestive echo. Now, we all know suggestive echo, you have gone through the workshop, there are aneurysm, dilatation, but what if the dilatation is around 2 to 2.5? Then we have to look at other finding, a minor dilatation with myocardial dysfunction or pericardial effusion or valvular dysfunction still holds good for a KD. Now, coming on to the evaluation, just 5 more minutes. Okay, briefly, the management remains same. It's IVIG or aspirin. There are multiple A of IVIGs, but the AHA says just give 2 gram per kg over 8 to 12 hours. But practically, if child is having myocardial dysfunction, we have to give it slowly. And just a brief note, aspirin also there are multiple studies, high dose, medium dose, but AHA says give 30 to 50 milligram per kg per day in divided dose for 5 days or till the child is afebrile for 72 hours, then taper down to the antiplatelet dose. But what if child is, aspirin is contraindicated, a G6PD deficient child, then we have to go for clopidogrel. And if the Z-score are more than 5, we have to go for dual antiplatelet drugs. Now, what I want to say, IVIG, as the coronary vasculitis peaks at 7 to 10 days, we have to give IVIG ideally within 10 days. When to give it? Beyond 10 days. Child continues to have fever or child is afebrile, but inflammatory markers are high and so are, coronary abnormalities are seen, we have to give IVIG. Now, as I said, high risk. If child is high risk, we have to do primary intensification with corticosteroids, infliximab. Steroids reduce the subsequent occurrence of coronary artery abnormalities, reduces the duration of fever, brings down the inflammatory markers, and there are no adverse side effects. We can start with methylpred at 2 milligram per kg, and then we can switch after 5 days, we can switch over to oral prednisolone. Infliximab for intensification of primary therapy has also been studied in high-risk patients and in certain units in our country also. Infliximab is given along with IVIG in high-risk patients, and it has shown to be significantly reduce the coronary artery progression within 2 months. So points to remember: infants less than 6 months, fever more than 7 days, think of KD, even and take a detailed history, look at the clinical features. There's no specific pattern of symptom. Symptoms may wax and wane. Child may present with only one clinical symptom. So even without the therapy, fever may subside by 12 to 14 days, but inflammatory markers remain high. So that's the urgency. We have to treat the disease. Don't wait for echo for starting IVIG in a typical KD. And last but not the least, be KD minded. Do not miss KD. Thank you.
Thank you, Dr. Moumita. I think the time is very short for this large subject, and particularly the diagnosis and management of Kawasaki disease. But she has tried to finish it within short time. I think the audience will participate in putting questions so that we can progress this management part, which was a bit hurried.
Anybody from the audience want to know any questions? There is one, Rupa is one to answer.
Avoid aspirin. Usually we don't know. Usually we don't do.
Oh, usually we don't do.
But if there is a history of G6PD, then better to avoid aspirin. And if child comes with an influenza report as well, then also we should avoid aspirin. It can cause Ray's syndrome. So these are some cases where we can go for clopidogrel as well. Yes, ma'am.
If you give one mic to the who are asking the question.
Is there any indication of giving infliximab upfront without even before?
Yes, ma'am. Actually, all we know is in IVIG resistant case when fever comes back after
So that is
36
IVIG
hours.
resistance.
Yes, but in primary intensification in high risk children, also infliximab is indicated in high risk. If the infant is less than 6 months or the Z-score is more than 2.5, then there are certain centers, especially like in PGI Chandigarh, I think they start infliximab along with IVIG. Recently, we had a case with a difficult KD shock. We gave in sequence. We gave IVIG 36 hours, myocardial dysfunction doesn't improve. We gave infliximab, it responded wonderfully. Yes, sir. Sir,
Genotype or why it doesn't occur above children above 5 years?
So actually in India, children above 5 years or a considerable amount of children above 5 years are also affected. That is slightly different.
Incidence reduces after the age of 5.
So beyond adolescent it reduces, but in our country even 7-8 years children also present quite commonly with KD.
No genetic susceptibility.
So Asians are predisposed. Yeah.
There is no monogenic defect associated with Kawasaki disease, but few genes have been described which have more vulnerability towards development of coronary artery aneurysm and IVIG resistance, like ORAI1, ITPKC, CD40, and some more. Professor Onuchi had landmark publications regarding these genes which are associated with increased chance of development of coronary artery aneurysms and IVIG resistance, and some polymorphisms also.
Thank you.
Okay, I like to say a few points. Particularly the Kawasaki disease intensification of treatment, this part is very new. It was not earlier. In 2024, it has been added. And this intensification means infliximab is definitely has tremendous role, and it should be started at first and then start IVIG. And along with that, prednisolone or methyl prednisolone is important part, because previously we used to say steroid will increase the mortality in Kawasaki disease. But that was the study with high dose, that means pulse methyl prednisolone. But it is proved that low dose, I should not say low dose, actually it is high dose 2 milligram per kg, but still not pulse dose. So this dose of prednisolone is beneficial. And I think in future, it may be said that not only in high-risk cases, this dose of prednisolone may be beneficial to other cases also. So we should wait for that. But till now, it is the high-risk cases and particularly the patients who are coming below 6 months. The intensification of treatment with infliximab, with steroid, and the usual IVIG will give a very good result. And we have experienced that very recently in a small child of 2 months age, where there was moderate dilatation, aneurysm, but that was within 6 weeks. When we saw the coronary status, we observed that it was normal. So this is very important, I think.
This is just a comment I will say that I am actually finding in day-to-day practice that I am sure most of the specialists here are also getting it. A number of times we are actually getting a pure viral infection like adenovirus, which has been proven by BioFire and also by clinical spectrum. And when I asked my pediatric cardiologist colleague, Dr. Devdatta, to come and do an echo on that, a number of those cases are actually having a borderline kind of coronary artery dilatation. Now, how to go about management of these cases for the specialist and Dr. Moumita?
So it can be KD associated with viral infection. It can be associated KD, but to stamp it as a KD, the diagnostic criteria we should match. Otherwise, we will call it as a part of coronary vasculitis secondary to viral infection, and which may be due to MISC as a part of multisystem inflammatory syndrome as well. So, in that case, steroids take a upper hand.
I think, this is actually very important. I want the
Suparna want
specialist to
say
comment on that.
Suparna want to say something.
Thing is that, sir, sir, it is absolutely true. In many viral illnesses, we get toxic dilatation of the coronaries. But the thing is that if you are getting a Z-score more than 5, more than 3, you cannot ignore it. You cannot ignore. You've got to treat. Okay, but less than that, if you get 2.5, 2 to 2.5, that you can, yes, that you can just wait and see. That is a transient dilatation. We get in many viral illnesses. Yes, sir. No, sir, 2 to 2.5, I think we can wait if the child is not high risk, less than 6 months, coming with very low platelet count, all these things, then it's better to treat. Because it is always better to treat than to burn your fingers later. But the problem is that if it is more than 2.5, 3, 3.5, better go for it. Less than 2.5, I will wait. If there are no risk factors. Yes, yes, sir. Yes.
If it is actually borderline kind of dilatation or pediatric cardiologist will say, sir, I'm repeating it in a couple of days' time. If you think of KD,
no, I think if
so our speaker in the last word, he has told you should be KD minded. Then you cannot be missed it. One thing, again, before ending this session, for the postgraduate, 2 things I want to say. One thing, if the fever subside, because some fever is subside, still you see the inflammatory marker. This is one of the important things. Another thing, generally the coronary manifestation occur 1 week after. With that, I want to end this session. If they want to any questionnaires, later on you can question. Thank you, Momita, for your nice presentation and very good interaction. Thank you, everybody.
Let's move on to our next session. I would like to call Suparna ma'am to chair the panel discussion on the topic follow-up in a child with KD.
It is slide short of slide. Shall I start? So it gives me great pleasure to... Which session is going on now? Panel. Panel. So it... Panel. So hello everyone, and it gives me a great pleasure to introduce Professor Taposh Shabui, basically the founder of Pediatric Rheumatology in West Bengal. Sir has been very dynamic all throughout, and he's currently attached as a professor in Shantiniketan Medical College, and he's currently the president of Indian Society of Kawasaki Disease. So we'll have an interesting panel discussion, how to follow up KD and what to do, whether it is a domain of the rheumatologist or the cardiologist or the pediatrician, or is it a combined effort. Let's hear Dr. Taposh Shabui conducting the panel. Over to you, sir.
Good morning, everybody. Thank you, Suparna, for kind introduction. And today, I have the panelist, very strong panelist today. Dr. Devasis Patra. Please, Dr. Devasis Patra from Odisha, Bhubaneswar. He is assistant professor some medical college in Bhubaneswar. Then Dr. Rakesh Pilania, associate professor pediatrics, PGI Chandigarh. He is currently the secretary of Indian Society of Kawasaki Disease. He is currently taking, in future, will take the position of Dr. Professor Surjit Singh. And Dr. Dhritobroto Das, and the consultant pediatric cardiologist. You know him well, almost attached to many hospitals in Kolkata. Expert cardiologist. And where is Dr. Devdatta Mukhopadhyay? And you all know her. She is associate professor pediatrics, BC Rai Hospital, and also the treasurer of Indian Society of Kawasaki Disease. So you will find the president, secretary, and the treasurer all are in the same, sharing the same platform at the same time. My question to the audience, because the chairperson told me yesterday there should be interaction. And so let's start with the interaction. How many of you believe that the patients of Kawasaki disease needs to be followed up? Everybody is telling me. Now the next question is how long to be followed up? One person said lifelong. Another is lifelong. So let's, lifelong? The reason why, whether it is a lifelong or not lifelong, it will be discussed and the experts will give the opinion. And this is the latest publication in April 2025, and it was a publication from PGI Chandigarh, and the chief author is Dr. Rakesh Pilania is sitting there, and Dr. Manful Singhal and Dr. Surjit Singh team. It was published recently. I'm talking of the case series. A 43-year-old male with no previous comorbidities presented with chest pain, reduced exercise tolerance. He had no obvious clinical risk factors for coronary artery disease. Cardiac assessment by 2D echography was non-contributory. Laboratory investigations are within normal limit. However, when CTCA down on 120 slice dual source platform showed fusiform aneurysm in the proximal and distal right coronary artery with normal intervention coronary segment and proximal mid-left anterior descending artery. And there was no evidence of atherosclerotic plaque and mural calcification in the coronary artery. Patient could recall a history of acute febrile illness along with mucopapillary rash in the early childhood, and given the absence of conventional KD risk factors, the imaging finding possible remote history of KD is considered. So this is his CTCA is showing right coronary artery and the left anterior descending artery. There is aneurysm and also the peripheral aneurysm. This highlighting 2 points. The patient had any history of Kawasaki disease. Once someone was telling me, if we miss the diagnosis, what will happen in future? He was asking in the tea time. So if you miss, they present in the long run with acute coronary syndrome or acute myocardial infarction and die. Sudden death. One of the important causes if you do not follow knowingly. Unknowingly, we are not following up many. And they come with these things. And the second thing is that the echo was normal, but CTCA is found abnormal. So in this background, we want to say that already discussed that we have already have the opinion that all should be KD patient should be followed up. There is no doubt that the panelists agree or disagree.
No, actually, the knowledge about Kawasaki disease is still evolving. So if we look at the guidelines from AHA in 2017 and 2024, the current guidelines has not asked for a long-term follow-up for those patients who has normal coronary.
I'm not like how duration I have not asked. This should be followed up or not to be followed up.
That's what I'm saying. For the long-term follow-up I am discussing. Short-term follow-up definitely for 6 weeks to 8 weeks is required for everyone. Because even those who don't have a coronary artery dilatation or aneurysm at the initial stage may develop aneurysm within first 6 weeks. That is the commonest time. That's the reason we, the short-term follow-up for 6 to 8 weeks is universal for every patient, and we stop aspirin after this follow-up.
Okay, I will come to this point later. So basically the information I want to give that the all should be followed up. The next question is, so that it is fill the patient initially with the IVIG and forget the patient. It's not that all patients with KD needs to be followed up. So that's the point thing. Then the next thing is that how to be followed up. Anyone, Devasis, you want to take?
So basically what this disease highlights is that the follow-up include basically clinical follow-up as well as a cardiovascular follow-ups. So we should not confuse the things with just a cardiovascular or cardiology follow-up, because this disease is a systemic vasculitis, and when we are talking about the systemic vasculitis, we just not say that heart is the just everything, because these patients need a follow-up, and follow-up in the form of clinical follow-up also, because once the Kawasaki disease has happened, possibly even if there is no coronary artery abnormalities, these patients are at a risk of further development of coronary artery disease in the life, because there is a one risk factor, because there is some systemic vasculitis. So we should prevent the other risk factors for coronary artery disease in this patient, like something like obesity, and lipid abnormalities has been seen in almost many patients during the acute phase, which has to be followed during the follow-up. So we should not confuse with that these patients will not require the follow-up. So follow-up is essential. We have to stratify the follow-up, which like a clinical follow-up, laboratory investigation, like we do inflammatory markers during the acute phase, and we will do at 6 weeks to 8 weeks, and then lipid abnormalities which can persist for longer duration in these patients sometimes. So that should be every 6 monthly or annual lipid follow-ups. And if those patients who have a lipid abnormality, they will require a long-term follow-up for the lipid abnormality. And then comes to the cardiovascular follow-ups. So if there is a 6 to 8 weeks echo is normal, possibly those patients are not having a long-term risk factors for development of coronary artery sequelae. So these patients may be an annual echo during first, and then they can be. So cardiovascular follow-up, I think, will come to that.
Dr. Devas, you want to add anything?
Sir has completed almost everything, and
okay. Devdatta and Dr.
Well, till now we were very happy with the echo. If echo is normal, then everything is normal. But I think the recent guidelines really have highlighted a fact is the importance of the CT angio. The pitfalls of the echo is that we cannot see the peripheries of the arteries. The left circumflex is not well visible, especially if the child is a little healthy and chunky. And also stenosis, development of stenosis and multiple aneurysms and all, thrombus, those may be missed in an echo. So for that, nowadays, if there is any coronary abnormalities, they are asking for a routine CT scan at 1 year on follow-up. And even earlier, if it is a large aneurysm, giant aneurysm, maybe at 2 to 6 months. So this is a major change in the our follow-up regime.
Suparna may add anything, because as a chairperson, has not getting the opportunity to talk.
So absolutely, like Devdatta has said, any dilatation more than 2.5 has to undergo a CTCA according to the recent criteria. You may not have 5, 6 Z scores, but anything 2.5 down the line, you have got to do a CTCA, as she has said. And yes, as Rakesh has said, it is not the domain only of the cardiologist, the treating pediatrician, the rheumatologist, all have to have a joint effort, because it is not only the coronaries. the other vasculature, the lipid abnormalities. We have seen children developing abnormal lipid profile down the line. So annually, of course, you should have a lipid profile done, if not 6 monthly. That is very essential.
So that's a thing is that not only the echo, CT, whatever may be, the patient as such should be looked at, because there are risk factors which can lead on to the damage to the cardiac function. That is lipid, one thing, important thing is obesity. Another important thing is a burning problem nowadays, obesity and the lipid profile. Other things, other than the inflammatory marker needs to be followed up. They are essential, and we always concentrate more on the radiological tests, all this, but we forget all these things, but they should not be forgotten and they should be followed. That's the point we want to stress here. So, as I say, Dr. Dityapada will take the echo. In long-term follow-up, what is the role, actually advantage and disadvantage of echo?
The most advantage is that it is a non-invasive and it does not expose the child to radiation with its potential hazard that we all know. And proximal coronary arteries are quite well imaged in most of the kids. But in older children, adolescent, it may be difficult, and transesophageal echo is recommended in those cases as an alternative to CT or radiation exposure.
Dr. Dityapada want to add anything?
In echo? Yes, sir, we get to see the function, we get to see the thrombus, we get to see the kind of flow also, but then again, echo has its limitations, but it's a good one, like sir said.
As a basic test.
It's a basic.
Dr. Rakesh?
So basically, I want to highlight, and I completely agree with that echocardiography is the standard imaging of choice in Kawasaki disease. We should not forget that, that is the whole and soul of the cardiovascular assessment in an initial phase and during the follow-up of children with Kawasaki disease, because it's something which you can do on daily basis, whenever you want to do, without any radiation exposure, without any invasive things. So that is the echo remains the standard imaging of testing. What comes CTCA and all these things we will discuss, I think, later. So, and echo should be performed during the acute phase very frequently, and where now we are talking about the follow-up. So in follow-up also there is a guidelines, and I'm sure that Prabal will be talking about the recent guidelines regarding how to do echo follow-up. One more such you have written regarding the electrocardiogram, ECG. So ECG changes has been recorded during the acute phase of Kawasaki disease also, even without absence of coronary artery abnormalities. And these ECG changes can be non-specific ECG changes or something like the ST segment changes. So which has been, there are studies during the acute phase ECG changes, and possibly there is a merit in looking for the ECG changes during the follow-up also. I'm not discussing CTC, I think you are coming to that.
You want to add anything?
Yeah, recently we had a wonderful conference of GIAN in PGI Chandigarh in the month of March under the guidance of Professor Surjit Singh sir, and of course Dr. Pilania arranged it. So there we came to know from the deliverance of Dr. Sudha and her researchers and all that in echo we are also looking at the endocardium. It is not only the coronaries and the myocardium that is affected that can lead to some dysfunction, but also the endocardium. She had highlighted many cases of valvular regurgitation which were under follow-up, and it had persisted even at long term. So that was an important thing, I think.
Dr. Dityapada, is the role of stress test in...
Now, problem is getting the stress test done. That is the most difficult part, because I remember the initial days when we asked for a coronary artery CT scan of a child. We had to refer the patient to PGI Chandigarh because no center in Kolkata were able to do that with confidence. There are many technical aspects which I am also not aware of. Similarly, if you call about the stress test, there are two types of stress tests. One is a pharmacological, that is a dobutamine stress test. Another is physiological, that is exercise stress test. Now, exercise stress is ideally there is no exposure to any medicine, it is completely non-invasive, so it is a better one. But for exercise stress test, you need to, the child needs to be at least 7-8 years old so that they can run on a treadmill or can pedal the bicycle. Younger children, you have to do a dobutamine stress test. And this stress test is mostly done in adult patient to assess the coronary artery abnormalities if there is a inducible myocardial ischemia when the patient is under stress. Now, in children, the experience is very limited. At least in Kolkata, what I can say, in most of the center, it is not done. So, if we want to get a stress test done in an older child, that is possible, but for a younger child, it's still not possible in Kolkata. I think.
So it's a problem all over. Doing stress test in a younger child, especially infant on high risk, is almost impossible in our country. Yes, the experience is not that.
What about the 6-minute walk test? Does it hold good for children,
So
older children?
No.
Not standardized.
It is almost.
You have to stress the myocardium enough by increasing the
for
heart
all
rate
practical
by
purpose, it is
or by
almost
exercise.
impossible here. And I do not know anyone has the experience of doing that in the young, small children or not. It's only grown-up children it is possible. So that's the point. The guideline has come with the stress. The problem is it's difficult to get it done in our country.
Just wanted to share one thing. There was this publication from abroad which stated that even after 14 years, 13 years of the initial disease, they did a stress test and then had some mild or moderate coronary aneurysm. They did a stress test and they found to be positive, and that child had to undergo some form of invasive treatments. So that can happen even after 14 years and 13 years. This is a known
I am not
publication.
discussing in detail with the CTCA because it will be followed by a talk by Dr. Rakesh Pilani on CTCA, coronary angio, because it is a major development in the recently on the following up the patient with coronary angio, coronary aneurysm. The reason is the distal part of the coronary. If there is aneurysm, it is very difficult to detect with echo, especially if it is in the circumflex branch. And so there CT is very important, and CT is very difficult. Many things can be learned from CT, which is not possible with only with echo. So I am skipping that point because it will be discussed later. Now the next questioning, how long to be followed? How long to be followed? That's the question, and that is the most important part. You can spend a whole day on it, but we have limited time, only 13 minutes to be discussed on the how long to be followed. Dr. Devasis.
Sir, as all the general pediatricians are also out here, we are discussing on echo. The basic thing is if a child is less than 3 to 4 years of age, the most important is when we are doing an echo, we should always sedate the child with either pedicloral or any mild sedative before doing an echo. And if the child is not sedated, the reports may be wrong. So that is a strong message which should be going.
That part we are skipping purposefully. With the technical ifs and buts, that will be, if you discuss this, then it will not be able to complete the follow-up part. So when taken as granted, it will be done. It will be done by a specialist who can do it. I will know that periphery, it is very difficult to get echo in a month. Forget the daily. So that part is taken, skipping for the sake of discussion. But the question is, how long to be followed? The question is this, that depends on the nature of the coronary artery lesion. If it is small, it will be followed in a different way. That was Dr. Dita both said it will be 6 weeks, then 1 year. And sometimes it will become said it is lifelong. Let's have the discussion, have the opinion of the experts and different situation what I can do. With that, there are possibilities. If a patient has developed in acute stage, then the KD with no coronary artery changes, KD with the G-score less than 2.5, G-score 2.55, 5 or 10, then more than 10. These are the situations you can have. So follow-up will vary according to the involvement of the coronary artery. So let's have, it is in the immediate acute stage. one I will discuss one at or immediate after discharge. What will do, Dr. Devasis?
At the acute stage, as we do, we have to do at the baseline, and after, as sir told, we have to see the clinical as well as the lab parameters, and follow up the echo after 1 week or to 2 weeks of the treatment, if the Z score, based on the Z score.
That's the thing. Actually, one patient should have an echo at least at the acute stage, if possible daily, and at the time of discharge one should have an echo. And the subsequently depending on the severity of this. Dr. Rakesh, you want?
So basically what you are asking is that how should we do cardiovascular assessment using echocardiography during the acute phase and during the acute phase when child is admitted, specifically if we should do an echocardiography at presentation, and then during the hospital course also will require. And if there are coronary artery abnormalities, we have to do a frequent echocardiography definitely. And if there is a persistent inflammation or fever is persistent or inflammatory markers are not coming down, possibly we have to do more frequent echocardiography. And then at discharge, and after discharge, we usually call them at 2 weeks, and then at 6 to 8 weeks for all the children. So that is almost a universal echocardiography assessment for coronary artery abnormalities. So that possibly will cover most of the things. So, but if there is a medium size or giant aneurysms, then these patients require a weekly follow-up till 6 to 8 weeks. That is important because these patients can have an enlargement in the coronary artery aneurysms, and these patients require a more frequent echocardiography during the initial follow-up also, because they can increase in size, and if there is an increasing size, then possibly we have to act on that, and so that 2 weeks and 6 to 8 weeks is not blanket, because that is for universal. But if there is a medium size or giant aneurysms, then these patients should be followed very frequently during the follow-up.
Actually, look at the coronary artery. What Dr. Rakesh said is based on the science is that if there is a coronary artery size increase at acute stage, they usually keep on increasing, or there is a change, and that is completed by 2 to 3 weeks, majority of the situations. And then that's why it should be done more frequently and during that period. Then that it is 2 months, majority it stops growing by 2 months. And very small percentage thereafter it grows. So that's a major reason why the echo should be done more frequently. That should be kept in mind. There are the 1 day depending on the facility, 1 week, 1 day, because depends on the size of the coronary artery. But that should be kept in mind. We have to do it more frequently in the early stage, and till it regresses or stabilizes. That's the reason patients with coronary dilated G-score after 2 months, if it is persist, that means consider they have a long-term arterial damage. That's the thing. And there are guidelines. It's very difficult to keep in mind at which interval we should always do, but keep in mind that in the initial stage, we have to do it more frequently because the size increases. And if the size increases, you'll have to do more frequently. But if it regresses or it stops growing, then you can increase the interval. Acute phase more frequent in patients with coronary involvement until dimensions stabilize or before discharge in those with high-risk clinical features. We have discussed repeatedly, so that point has taken care of. And why we want to do long-term goal of follow-up? What is the main purpose? Why we are following up? Anyone wants to?
Definitely what we know that initial stages, as you discussed, there is a dilatation and aneurysm formation which can grow at the initial stages and then stabilize and becomes normal. That is the usual course. In some patients, this coronary aneurysm may persist, and they may persist for lifelong. In the long term, there will be stenosis. So there is a scarring in the coronary arteries. So because of the scarring and the continuous progression of that scarring, there will be stenosis at some time. We don't know exactly when it will happen, and there will be some coronary artery stenosis there may be thrombus formation within the aneurysm, and that can lead to myocardial ischemia. So what we are looking at is to prevent that early onset of myocardial ischemia and acute myocardial infarction.
So main purpose is to prevention of thrombosis and development of myocardial infarction, which is more common during the first 1 year of the illness and probably in the very initial stage. So that's the thing, main thing, purpose of following up. And we have, because shortage of time, I'm taking say medium-sized coronary, 100%, 94% male participant, 100% they recovers. In 10-year follow-up, we have small size of. Now, if the situation is the G-score is less than 2, anyone quickly, because we have very small time.
So if G-score is less than 2, that means it's normal. At you are talking about the 6 to 8 week echo, sir.
Hi.
So at 6 to 8 week echo, if is this persistently less than 2, possibly we are dealing with the normal coronary arteries in a child with Kawasaki disease, and these patients are possibly can be discharged from the cardiology site, not from the clinical follow-up. So clinical follow-up is required in these patients, which I highlighted already. And we can stop aspirin at 6 to 8 weeks.
And if G-score is between 2 and 2.5.
Usually it's very important to do the echo 1 week after discharge, and then again about 6 to 8 weeks after that. So that 1 month follow-up is very, very, very important for them, following which they can be followed up at 6 months and then subsequently at 1 year. However, all of them should have, like I said, one CT scan.
At 1 year is normal or abnormal. If normal, what we do? If it is abnormal, what we do?
So either ways we should follow it up. Either ways we should follow it up every yearly. If abnormal, then definitely
we have taken
yearly.
it granted all patients to be followed up. That is no, even if it becomes normal. So if now it's abnormal, then what we'll do?
Abnormal, then we have to keep on repeating it, continue the anticoagulants, and definitely do a CT scan. And if the child is above 7 years of age, we should go for a stress test.
So that is practically is not we are doing stress test.
No.
So forget that
I am
point.
doing it, but
the one thing is that if it is found abnormal at 1 year, aspirin should
be continued.
That point to be stressed that the aspirin needs to be continued in this. G-score is 2.5 and less than 5.
So basically small aneurysm, sir. Now at discharge, if there is a persistent small aneurysm or if there is a regressed, again if these coronary artery abnormalities has regressed, possibly we can stop aspirin, but we have to follow these patients annually with echocardiogram. And if there is a persistent small aneurysms, they will be continued on the aspirin, and again the follow-up with the coronary CT angiography every 1 to 5 years, depending on the size of the persistence, and also these should be done the stress imaging in follow-up. But nowadays, if children is more than 6 years, possibly we can do the physical stress.
We can do it in 5 years also. Actually, it's written 7 years in the guidelines, but
we
if
have
the child can understand and is capable, and the cardiologist has to be with the child all the time. We can just ask the technician to do it.
No. There is no question of technician. Cardiologist is there, but still in practical purpose, all practice, we are not doing it. But technical is granted.
The main reason I think is the time you need to spend for that test. It will take at least 1 hour minimum. Forget about the preparation and the post follow-up. So you have to spend at least 1 hour on the side of the child at the echo room, getting the machine for that time, getting the logistics, support, and that.
So they think that this patient needs to have a CTCA at 1 year. That points to be kept apart from echo. If the moderate side, this is the biggest problem, between 5 and 10, then what will?
The most important thing is we have to continue the medications of both aspirin as well as dual antiplatelet, and we have to follow up the child. This is at 6 to 8 weeks. Then we have to follow up the child whether, as sir told, whether it is progressing further or it is stabilizing or it is regressing. So if it is if it is progressing, then the management will be different. If it is stabilizing or regressing, the management will be different.
So that's the one thing point is that the echo frequency will be increased. it is usually to 6 months, 12 months, it will be within 3 months, one extra. The size increases, the echo frequency will increase. Then it will be every 3 months, if it is a large. So any point follow-up regress or abnormal, if regress small size protocol, if it is regressed, then we will follow the protocol of the previous one, the smaller size protocol. If remain static, CTCA at test in 1 year. So it's all patient going to have a CTCA, keep it in mind, which is not freely available in all centers in the country. If the score is more than 10.
So basically,
actually this is now it's the cardiologist.
Yeah. It's a domain of cardiologist in definitely for echocardiography. So when we are talking about the large aneurysm, sir. So large aneurysm, the definition is more than 10 G scores or more than 8 mm diameter. But the recent observation is that if the aneurysm size is 6 mm also, that also be dealt like a large aneurysm, because those patients who are having more than 6 mm, they also behave like a large aneurysm or giant aneurysm. So I'm deliberately using the terminology large aneurysm. I'm not using that giant aneurysm, because giant aneurysm is typically classified as that. So large aneurysm should be followed, and possibly these aneurysm never regresses actually. So there is a difference between the G-score based giant aneurysms and the absolute dimension. If aneurysm size is more than 6 mm, almost there is a no regression. If the in infant, when the diameter is 4 mm and the aneurysm size, by G-scores it would come around plus 10. But Z-score based aneurysms can still regress actually, even if there is a more than 10 G-scores. So these patients require almost a lifelong follow-up, both with cardiology and the primary clinician, be a pediatrician or rheumatologist. And these patients, in initial part, will be requiring aspirin and anticoagulation. So anticoagulation.
We're coming to the point.
So that will be another we can have one full hour session on anticoagulation. So yeah.
So that the message is that they should be followed more frequently. It should be more frequently in comparison to small, medium size. That's if it's a large. Dr. I agree fully with the Dr. Rakesh that if it is large, more than 5 or 6, actually never disappears. If they remain in the body and they will give the pain. So any point of regress is normal if regress is there, and this group of patient, once the stabilized, they should have a CTCA. It's not that for the 1 year. They should have a CTCA once stabilized, maybe 6 months. So they should be, at that point has to be, if it is giant aneurysm, they should have a CTCA as early as possible. Even if it is more than 5, again we can have CTCA once stabilized. Maybe it can consider stabilized means 6 months. So you should have. We should now discussing briefly, we have already crossed the time limit. Use of antithrombolytic agent at follow-up. Dr. Devashish.
We usually follow the low molecular weight heparin. If the, as I told,
all patients low molecular heparin.
If the Z-score are more than 10, invariably, and if it is
because shortage of time, I cannot.
Absolute dimension more than 6, as I told.
So I think sir is asking regarding the whether you can use oral anticoagulant. So that is almost a touchy thing actually. So during the acute phase, we almost all agree that we should start with a low molecular weight heparin, and because that is easy to monitor, and there is some role in coronary artery remodeling by low molecular weight heparin, which is almost it's a hypothetical and based on some studies. So but more important is that we can monitor easily on low molecular weight heparin, and maintaining young children on warfarin is like something which is a nightmare. So we all agree that during the acute phase and till the 5 years of phase in our in our institute we do not start on oral anticoagulant. So till 5 years of phase, it is difficult to monitor their diet, it is difficult to monitor their schedule. You can't even ask to child to sit and behave like this, that they will do whatever they want to do. So during the that part, low molecular weight heparin and along with aspirin, and in these patients, there is a role of atorvastatins also. So they will, there is a, because that is a, we are giving atorvastatin for anti-inflammatory activity, not as anti-lipidemic drug in these patients. So these patients require, so anticoagulation is a very important issue, and as sir has highlighted that first 2 years of the follow-up is a very important follow-up, because during that part development of thrombosis or and coronary artery rupture or coronary artery aneurysm size increasing is a very highest chance. So once you have passed first 2 years, possibly the disastrous thing will not happen in most of the patients. Then you have to follow these patients. So and we have to maintain a therapeutic level of anticoagulation. So it is the only vascular thing where you are not having a thrombosis and you are maintaining a therapeutic anticoagulation. So wherever we are talking that prophylactic anticoagulation or therapeutic, in this we have to maintain a therapeutic anticoagulation, that we should give a twice a day subcutaneous low molecular weight heparin. And I'm sure that people are thinking about that why we are not talking about the direct oral anticoagulants DOACs. So which is also coming into the big way. It's almost all adults have started using, and there are pediatric study also, and there is a one study in Kawasaki disease also by Dr. Jane Burns group, but still it's
Still
not
it is an experimental stage.
It's
an
an experimental stage. So for all practical purpose, possibly anticoagulation means in our setup is low molecular weight heparin to start with, and once the children are older, then possibly we can maintain on them oral warfarin.
So last point, we had if anyone can take up, there is a chance we are repeatedly talking about the MI, patient may come with MI or thrombosis. When you will suspect an emergency, it will come. How you will suspect the patient is having MI?
If it is a small child, sir, it is very difficult because the child will be crying excessively, might be hemodynamically unstable, having a lot of diaphoresis, may have crying spells, respiratory distress. So unless we see the ECG, if there is ST segment elevated myocardial infarction, in which case the ST segments will be more than 1 in the limb leads and more than 2 in the chest leads, elevated above the baseline. And other than that, it's very, very difficult to even think about it unless we do an echo and find there is gross dysfunction. And another thing is that, yes, sir. Of course, we were discussing it in the Jian workshop, and a very good suggestion came up is these children with Kawasaki disease, like those with adrenal deficiency, should be given a card, especially those with aneurysms. They should be given a card. The parents should be made aware that if these kind of incidences appear, please tell the treating doctor that the child had Kawasaki and may be having an episode of MI. Of course, we have to send the cardiac enzymes, also the highly sensitive troponins and all, and that would help us in reaching the diagnosis.
So any patient with history of Kawasaki disease coming to emergency with excessive cry, restlessness, sweating, sudden illness, collapse, and respiratory distress, think of the possibility shock, they think of the possibility of acute MI and proceed accordingly. Because most of the time we do not consider this, and the patient may die. And they come usually within 1 to 2 years after the onset of this. That should be kept in mind. That's the message we want to give. We have already crossed the time limit. We cannot more. All IKD patients need to be followed up. Think of myocardial infarction coming with chest pain, irritability, excessive cry, shock and sweating. That should be kept in mind. Not only that, feeling the then following due echo and all these things, patient may come with this thing, and think of it. All patients, parents of patients with coronary artery aneurysm should be taught of CPR, how to give CPR at home. That is the important message that has to be given to them. And duration of follow-up depends on the severity of coronary artery damage. Maybe it is lifetime. We have not time to discuss. I have shown the first case why it should be followed up. And echo is not enough. CTCA is a new modality. Dr. Rakesh Pilan will discuss it in the next session. So with that, we like to end the session. Thank you for the panelists for participation, active participation, and also the audience for active participation. And I have sorry that we have crossed the time limit.
So thank you. Thank you, sir, and thank you all the learned panelists for the enlightening discussion. So we can, for the sake of the time frame, we can allow at least 2 questions from the audience.
They can come. That's an emergency. That's exactly what I am trying to say. If they come with that, you'll have to think of. When you think of all these things.
So if there one more question, sir.
And my years of experience of working with children with KD as a generalist, both in the UK and here, where I have seen the rheumatologist and cardiologist workings in a single clinic and monitoring all children with KD. First important learning lesson for me that it's still a nascent disease. We are still learning about KD, and we cannot let any child say that you are completely recovered, nothing is going to happen to you even in adult life, and you can go home and lead a normal life. All these children needs to be followed up, even when their anatomical lesions actually totally disappeared. Physiologically, those coronary arteries will behave differently, and that's the area of research nowadays in different journals and everything. And that's what I really would like you to touch, because all these children, when they grow up as adults, if they're not really following a good lifestyle and taking precautions about various things like obesity, hypertension, dyslipidemia and everything, they are possibly going to be much more prone to develop coronary artery related disease in future. Your comments, please.
Sir, just one. I just had to make this comment. Thank you, sir. Thank you. The thing is that we are seeing the outside in echo and all. We are seeing the outside of the coronaries. We are not going inside and seeing the inside of the coronaries. How much damage to the endothelium has been made. CT, angio, and MRI can pick up at some level something, but that is also not written in gold. The only thing that can actually directly see inside is optical coherence topography, but that skill is very, very limited everywhere in the world. They have actually seen people with KD and people with atherosclerotic aneurysms also. When they are adults, they are having that size probe to go inside the coronaries and see the level of destruction that the disease has caused inside. It can be, it is a different world, I would say. But that size probes, we don't have. The expertise is very limited, and it is completely, again, a different, at a different level. So,
ma'am, Suparna ma'am has done a debate last year, I think, last year, and ma'am will highlight that what is the role of endothelial dysfunction and long-term follow-up.
So, absolutely right, like Dr. Rakesh has seen, that the endothelial dysfunction actually continues lifelong. That we cannot see, that neither no echo, nothing will pick up that, and that continues. So we can conclude the session now. KD is still an enigmatic disease. We have got to learn more research has to be done. And now I would like to close the session. Thank you the panelists, and thank you, sir.
I would request everyone to please be on time and end the sessions in time. Now I would like to call on stage Dr. Dibyendu Roy Chaudhary, Associate Professor in Pediatrics in Medical College, Kolkata, and Vice President, West Bengal Academy of Pediatrics, to chair the session on what is known and what is new in AHA KD 2024.
Good morning, everybody. Our next speaker is Dr. Probal Mormon, and the topic is what is known and what is new in American Heart Association KD guidelines in 2024. And Dr. Probal Mormon is Assistant Professor in Department of Pediatrics and Department of Clinical Immunology and Rheumatology, Guwahati Medical College and Hospital. Dr. Probal, please.
Thank you, sir, for the kind introduction. I'd like to specifically thank the organizers for giving me this opportunity to talk today. And fortunately, most of the, what should I say, the topics have already been discussed in the previous two sessions. So to save time, I'll shorten it as much as possible. I'll also try to make it as interactive as possible. So I think we already know the basics of what exactly the disease is, so I won't go in detail. So let's talk about a historical perspective of what we know about Kawasaki disease. So it was in January 26, 1961, when Dr. Tomisaku Kawasaki first reported his eponymous disease. So it was in the year 1961, which he saw, but his first publication was in an obscure journal in Japan in 1967, and this is what was his observation, and this is some of the original pictures from the first manuscript that he published in 1967. So in 1974, this was what he wrote in English. The first paper was in Japanese, and in 1974 he published in English. So the observations which he first saw in 1967 are almost the same that is in the recent AHA 2024 guidelines, except for probably the last three, because at that time he was not aware of the devastating cardiac sequelae. So over the years, there have been multiple revisions of this disease, both by the Japanese as well as by the Americans. So today's talk, I'll be focusing mainly on the 2017 and the 2024, the diagnostic criteria of Kawasaki disease. So before I go there, I'll also like to briefly highlight the Japanese guidelines. So Dr. Samantha has already discussed the various diagnostic criteria. So the only difference between the American criteria and the Japanese criteria is that they have removed the duration of fever. So for them, fever for 1 day is sufficient to call it a diagnosis of Kawasaki disease. Not only that, in the column for rash, they've also included the BCG reactivation, which is not present in the American guidelines. So we already know the various the principal criteria. So the major difference is that in the 2017, the duration of fever was reported to be 5 days. In the recent ones, they have reduced it to 4 days. There are some fine prints as well. In the 2017 criteria, they have mentioned that in the presence of more than or equal to 4 principal criteria, specifically if there is presence of redness and swelling of hands and feet, the diagnosis may be made within 4 days of fever. In the recent one, they have removed this sentence altogether. So if any of the principal criteria is present, an expert can diagnose KD even before 4 days of illness. In addition, in the 2017, these were the differential diagnosis of Kawasaki disease, including various viral infections, some drug hypersensitivity, Stevens-Johnson, etc. In the recent one, they've also added MISC, which was because of the COVID-19 pandemic. So this is, in brief, the difference between KD and MISC. So KD is basically a disease of early childhood, less than 5 years, whereas MISC was seen more in older children. And some peculiar findings in MISC, particularly the prominent GI symptoms, thrombocytopenia, lymphopenia, which are rarely seen in Kawasaki disease. The major point of change in the AHA 2024 is the stratification of high-risk patients, which was not in the previous criteria, both in the Japanese as well as in the American guidelines. So in 2017, the AHA guidelines had alluded to the various Japanese risk scores, including the Kobayashi, Egami, and the Sano score. However, they also mentioned that these are not validated in non-Japanese population. So in 2024, they have alluded to a recent study by Son et al. Published in 2019. So this is a criteria which the North Americans use to identify their cohort of patients who may be at high risk. However, this was a small kind of study, so cannot be generalized across the globe. So after comparing the various classification scores, so in the recent one, they focused mainly on 2 points. One is the Z score more than or equal to 2.5 in the right coronary artery and the left-handed descending artery, and age less than 6 months. So these are the 2 points which they have specifically mentioned for what we call as primary intensification of therapy, which has also been reported for the first time in the 2024 guidelines. So we have already had a very interesting discussion on the various imaging modalities. So some salient features of the latest classification is that, latest guidelines is that initiation of treatment should not be delayed to the echo, and centers should be using the same Z-score for comparison over time. Should not be used different Z-scores. And the last line is a bit important. The Z-score alone cannot determine the nature of injury to the CS. As Madam has already highlighted, we can only see the coronary arteries. We don't exactly know what's happening inside the endothelium. So this is the management algorithm, which has already been discussed. So if there is evidence of any aneurysm, the important point is that the initiation of additional anti-inflammatory therapy, which was not in the previous guidelines. And not only that, although in the previous guidelines they have spoken about sedation, this is the first time they have mentioned that if the patient is less than 3 years, sedation should be considered in these patients. Another point which they have highlighted, and I don't particularly agree, for some reason they have only focused to involve the cardiologist. I love my pediatric cardiologist, but the thing is, do involve us as well, because KD is the bread and butter of rheumatologist, so hame bhi involve karo. So these are what are the adjunctive therapies which were discussed in 2017. So here they have not spoken about the intensification therapy. So only in case of resistance, like patients have not responded to the conventional therapy, then we can use these drugs. So there is no evidence of saying that which drug is better than the other, but institutions across the globe have used IVIG, steroids, and infliximab in these doses. And they've spoken of some alternative therapies such as cyclosporin, anakinra, etc. So this was in 2017. The KAIKA trial had not been published at that time. So in 2024, they specifically focused on these 4 drugs. So I will not go into detail because of shortage of time. So prednisolone and methylprednisolone to be used. The dose of infliximab has been increased from 5 mg per kg to 10 mg per kg. This is on the basis of certain pharmacokinetic studies where they have shown that a higher dose is required if a patient has already received IVIG. And they have also mentioned about etanercept, although I am not aware of any institute in India who are using this. This is probably because of an RCT published in 2019 where they used etanercept, but I don't think it's used anywhere else other than in some centers in US. So these are some of the additional therapies for IVIG resistance, cyclosporin, anakinra, and the second dose of IVIG has come down in the list. This is following the KID CARE trial from US, where they showed that infliximab is better than a second dose of IVIG. So again, for some reason, they have only said that consult a rheumatologist when you want to give cyclophosphamide. We actually rarely use cyclophosphamide. So once again, I'd request that in addition to calling your cardiology colleagues, do involve us as well. In this particular slide, I have to phone my cardiology colleagues. So this is beyond my scope. At best, I can put a cannula for this child and refer to you. So in a case of STEMI, we have to involve our cardiology colleagues. So these are the caveats of cardiac imaging. I will not be going into detail. So just want to highlight the major point is that as compared to the previous guidelines, CTCA has been made almost mandatory in all patients who have had some involvement of the coronary arteries, especially at 1 year as a baseline. So if there is a giant aneurysm, then CTCA should be done as early as possible, even at 2 months following the illness. So as far as the long-term prophylaxis is considered, so the major change is that in the previous one, they had mentioned that dual antiplatelets may be considered. In the recent ones, they've advocated that dual antiplatelets should be indicated in all patients who have medium aneurysms. And the major change is that in the previous one, warfarin, LMWH were indicated only in patients who had giant aneurysms, current or persistent. In the recent one, they have said that even if the aneurysms have regressed to medium or small, so just the last few slides. So we have to initiate warfarin and LMWH. They've also talked about, for the first time, about the directly oral anticoagulants. However, they've also mentioned that right now there are no head-to-head trials, no randomized controlled trials. These are the two trials that they have alluded to, the Enobel and the saxophone, the edoxaban and apixaban. These have been used in small children for other reasons, not Kawasaki per se. And they have noted lower clinical rates of bleeding, thrombosis, the dosing, the infrequent need for monitoring, and other advantages. However, further studies are required. So in conclusion, the latest guidelines emphasize on the risk stratification for primary intensification. There's a refined dosing schedule based on risk assessment, need for CTCA in the long-term management, and probably in the next few years, we'll be having these directly acting anticoagulants. Thank you for listening in. I'll be happy to take any questions.
Thank you, Dr. Borman, for nicely highlighting the recent changes in the guidelines in 2024. We can take two questions.
It is not recommended in the latest ones. So the latest guidelines say if you are planning for augmentation, if there is IVIG resistance, go for steroids, infliximab, or cyclosporin. Which one to use, they haven't specified because there are no head-to-head trials. So for example, the Europeans prefer using steroids. The North Americans prefer using infliximab. And certain Japanese centers prefer using cyclosporin. PGI Chandigarh, for example, which we'll be discussing in we have session on primary intensification all, they use all three in certain situations. So right now, second dose of IVIG is more of a theoretical concept. We prefer to use the other drugs.
So my question is, classical KD we all more or less are accustomed to, but as a general pediatricians, what we come across very often is incomplete KD. So recently I had a 5-year-old child with suspected measles, but I didn't think the rash was like measles, so we immediately did a echo after sending all the inflammatory markers. On day 5, there was already coronary artery dilatation. So my question is, how long should we wait for IVIG before, should we wait for our cultures to come negative and rule out other infections, or should we give away, how early can we give the IVIG?
So Kawasaki is a clinical diagnosis. If you suspect it, you do it. So the role of, the echocardiography is just to, stratify these patients, whether they will need intensification of therapy. So for example, in your case, probably this patient would be requiring some other form of therapy as well, infliximab or steroids. So if you suspect Kawasaki, it's a clinical diagnosis. It's a general pediatrician's case. You don't have to call the pediatric cardiologist according to these guidelines. We don't even have that many pediatric cardiologists. It's a job of a general pediatrician to diagnose, initiate the treatment, get the echo done as early as possible. It's, like I already mentioned, you don't have to wait for the echo. Get the echo done, you don't have to wait. If you suspect, treat it. It's better to treat than wait.
On the new guidelines is that they mention the term first-line treatment for KD. I think we have to get out of that thing, because the whole idea of intensification means that high-dose aspirin is not suitable for all patients. And that message has to come out. And that's because there is no pediatric rheumatologist in the drafting of the AHA guidelines.
Yes.
And it's something that I really take exception to. Because the acute management of a vasculitis, the best person is a pediatric rheumatologist. We are very good at immunomodulation. Okay, that is our strength. That is our skill. And the long-term management is fantastic with cardiologists. We are not the best at all there. So that first-line treatment, I object to that wording itself. And I think we really have to get out of that mindset that every patient get first-line treatment. You can say standard risk and high risk. That would be better.
I think it's time we generate some Indian data as well. We have been, following the West and Japan for way too long. We have our own patients. Our patient cohort is different. We are Indians. We are Indians. So I think no, this is different. Yeah. Yes, yes. Yes. So I think this is the forum to discuss all these points. So we need more we have patients. We need more multicentric data. So PGI, Madam is also doing in South India. I am in Northeast right now. In Kolkata, we have so many specialists as well. So maybe next few years we can collect all our data and formulate our own guidelines. Yeah. Thank you.
Thanks to the organizer and thanks to the audience for patient hearing. Thank you.
Just a small little announcement. We are already running 20 minutes late. So I would request the speakers and the chairpersons to please stick to the time, because it's a day we'll be discussing KD all along. So most of the sessions have been planned accordingly. I think most of your queries will be answered by some talk or the other throughout the day. So please maintain the time, because we have to leave the hall also by 4:30. Thank you.
Let's move on to our next discussion. I will like to call upon stage Dr. Swati Chakravarti, retired professor from SSKM and ICH, for discussion on KD kaleidoscope, the many faces of a disease.
Good morning, and I'm thankful to the organizing committee for inviting me to chair this session. And this session is about it's on the KD kaleidoscope, and the speaker is Dr. Vijay Viswanathan, and he doesn't need any introduction. He already has been introduced yesterday with his lectures and interactions and all that. And by the kaleidoscope, we know that it's all our childhood memories. We have all seen the bright, continuously changing designs and pattern in a tube. And let's see what Dr. Viswanathan say about this kaleidoscopic picture of KD. Yes, over to you.
Thank you, ma'am, for the kind introduction. And I wonder why Priyanka had to make that disclaimer just before my talk. Let's stick to time. So the topic is quite, I wanted to ask him if it is FACE or PHASE of Kawasaki disease, because throughout the day we are going to see the phases of Kawasaki disease. And I thought I should start the presentation with a pretty face. And this is what gets all the pediatricians awake in the morning when I do this talk in Mumbai. So I belong to the western part of India. So that completes the four zones of KD. And the reason any guesses why this picture's there? So Dr. Kawasaki saw his first case in 1961, and this lady on the left was born in 1963 in some village in Andhra Pradesh, and she suddenly drops dead in a bathtub, not even a swimming pool, at the age of 53, and assuming that no homicide, etc. was happening, you would start wondering. I'm not saying she had KD, but it's just to drive home the point that many of us are going to see a lot of young age mortalities in the near future. And the guy on the right side, Kolkata, needs no introduction. That guy actually had passed away after a concert at a very young age. And we are seeing many incidents like this. People are just dropping dead on a football ground, etc. So there is going to be a stage where we are going to see more and more such incidents. And we always, 10 years back, we used to think that KD is a very straightforward disease, and most of us were happy giving IVIG 2 weeks, and many of them did escape the 6-week echo also. And I remember this kid I had seen in 2014 at 4 weeks. So the pediatrician called me up saying, there is a kid who I gave IVIG, just have a look at him and just sign for me. And I saw this child was still having a CRP of 30 and a Z score of 2.7. And this was 2014, where less than 2.5 was supposed to be normal. And I said, please do a repeat echo, and maybe there is a cause for at least a low-dose ecosprin, if not a small short course of steroids. These parents defaulted and came back at 3 months. The kid looks the same, but then his coronaries jumped up from 2.7 to 5.2, the point which was brought out very nicely in the panel discussion. And then you know that KD has got a lot of new avatars, and we all need to be aware of what happens. In 10 years back, when I was seeing, I was not seeing many kids with KD. One day I just Googled up the map of Japan and Navi Mumbai, and this Calcutta map is just a new addition. And you start thinking that beyond the genetics part of it, the old theory of staying close to a water body and mangroves and heavy industrialization, this map of where I come from, Japan and Bengal, it looks very similar vis-a-vis at least the proximity to the ocean and the landscape also. This is how Kolkata looked from the flight when my flight was coming down or landing, and this is where I practice. So you have a lot of mangroves, greenery on one side, and heavy industrialization. However, the phenotype that I keep seeing is a lot of shock syndromes. I don't see many giant aneurysms from the part where I come from. I almost end up in a debate that my KDs bark more but doesn't bite that deeply. So I'm just going to quickly run through this. Most of us know what atypical KD is. Most of us know what incomplete KD is. The situation where the pediatrician gets into a bit of a trap is when you face situations like a shock, a pneumonia, a nephritis, a meningoencephalitis, sometimes an ocular involvement, cranial nerve palsies. So in a busy day-to-day pediatric practice, thinking of Kawasaki becomes a bit of a problem. And more so, when you have a proven infection, will you still think of a KD? Answer is yes. Like we'll show you through some cases where if your conventional proven infections pass out without expected results, you need to start thinking if I'm dealing with a possible inflammatory story. Quickly, I'll go through these cases without going into much details. This was a kid I saw in 2016-17 when the Asian sand theory was going around. This kid was a 9-month-old male who had all features suggestive of KD, dilated coronaries, cultures were sent, and we gave IVIG. Turns out that the fever continued. This child was IVIG resistant, and this child had oral thrush, and blood cultures were suggestive of a fungal infection, actually. It grew Candida albopictus, which is not a contaminant. This child ended up in trouble with bilious vomiting, pseudo-obstructions, and needed to, I gave him second IVIG only because of the fungal part of it, and it was 2014, and I gave steroids, and this child recovered. This was the picture where he had a bit of mucositis, a lot of thrush, but the message was that this was the first kid who actually grew a fungal infection and had KD at the same time and needed a lot of intensification upfront. About 10 days since after I discharged that kid, this was another kid who was 11-month-old, similar features, and I almost was sure that you're dealing with the same kind of a story because both of them came from the same area, the same community. It was quite interesting. So again, grew Candida albopictus. 2 kids who had fungal infection and had KD, and there was a nice BCG reactivation just in case there was any doubt about the diagnosis. The second situation was a 2.5-year-old girl, a boy child who had features of Kawasaki disease, very, very typical KD, but never referred to the rheumatologist initially, got admitted to ICU with low counts, low platelets, went through the usual dengue, typhoid, etc. And the culture actually grew salmonella, and the child tested positive for dengue also. And I got into the picture only because the fever kept on persisting. This is 2017. And this kid actually also, the coronaries were significantly dilated and received treatment for KD. 2 weeks later, same area, same community, we see a 9-month-old kid, again had features of Kawasaki disease, blood cultures growing, Salmonella typhi, and this was the picture, very, very classical, right? This kid was Salmonella typhi with Kawasaki disease. And this was probably, I may never see a kid like this again. This was a 5-year-old girl who looked Kawasaki to my eyes. We gave IVIG, and the fever kept on persisting. The echo was showing LAD and RCA dilatations with a thin rim of pericardial effusion. But this child started having severe abdominal pain post-IVIG, and an ultrasound showed a amoebic liver abscess which was drained, and this is the anchovy sauce which came out. And so with Kawasaki has never been described. And the best part is I could convince Indian Pediatrics to accept this as a publication. I think there were, so entamoeba with Kawasaki disease is something which was very unusual for me. The next situation is a child who was just pouring out pus from the ears, and the cultures grew MSSA, significant myocarditis, heart rate of 200, almost in shock, ejection fraction down, NT-proBNP extremely high, and this kid also was labeled as incomplete Kawasaki disease, and despite having pus after covering up with an antibiotic, ended up receiving Kawasaki, the conventional KD treatment. So this situation is what I want the pediatrician to be aware of. Many of these times you will be encountering this streptococcal pharyngitis, not getting better. You will start thinking of a quinsy or an abscess. With a torticollis. A KD with a torticollis has to be investigated very, very properly, and it's a very simple theory that the retropharyngeal tissue has loose collagen tissue. With a little bit of edema, you will start picking them on a CT scan. A child with torticollis, features suggestive of KD, or you think it's a tonsillitis who doesn't get better, please screen with a CT scan, see RPE or a retropharyngeal edema, and intensify the treatment, because these are typically kids with long-term bad outcomes. This is an epidemic in Mumbai as of now, or a pandemic, not a pandemic, maybe a little bit of an outbreak of mycoplasma. A proven mycoplasma pneumonia, fever doesn't go away. Don't be adamant and stuck with LDH, azithromycin, etc. Think that this child could be a Kawasaki disease as a differential, the classical strawberry tongue, rash, and always remember to look at the joints. All the parents will say, IV dala tha to haath suj gaya. IV dalne se the dorsum of the hand swells up, not the fingers, right? So the typical arthritis or dactylitis is a very unique phenomenon. I started 5 minutes late. I want to catch the flight, so I'll be really fast, right? So infections in Kawasaki's could be causative, coexisting, or as an innocent bystander. You need to have a low threshold and a high index of suspicion to pick these kids up. More resistance, incomplete presentation, often needing intensification, and it's always time to be proactive, right? This is a slide I borrowed from Dr. Suma once, and all of us have seen cranial nerve palsy, especially in infants. So facial nerve palsy with features suggestive, needs intensification, and it's a high risk for coronary morbidities. This is another classical scenario where a 5-year-old, which I see a lot, comes as a shock, 3-4 days of fever, and then comes as a shock syndrome. And the message is simple. It looks like a Kawasaki disease, cultures are sterile, and the child is in shock. Again, treat it aggressively, and especially in these kids, be careful while you are giving the fluids, because many times you end up giving IVIG and the fluids, and you start creating more trouble vis-a-vis the pulmonary edema thanks to the myocarditis. So fluid correction and IVIG and Solumedrol. So this kid became this kid, and this child actually ended up having onychomadesis. confirming that what you did was correct. This is my youngest kid. On day 15 of birth, this aunt of this child was on a bike resuscitating this kid because his child just collapsed. The aunt was a nurse and came with shock. To me, everything looks Kawasaki disease. To the pediatrician, it was just a dry lips in PICU. And this child came with was in severe shock, supremely elevated Z scores. And the very classical thing was there was a slight discoloration of the fingertips, right? So this child did not have fever for information. And as it turns out, intensifying treatment, this is the same kid who made a complete recovery in 1 year vis-a-vis the coronaries. And they actually named this kid as gospel. So the gospel truth is that even if a child doesn't have fever, you should have a high index of suspicion, especially in the index kid. The last slide is very young or very old. What's the scenario? A classic scenario in a pediatric OPD is a child who comes with a lot of urticarial lesions. And there is always this itch for the pediatrician to give hydrocortisone. Before you give hydrocortisone to a child in an OPD basis, just think that this child, and the hint is 364 days. 1 day before the birthday, I have a cohort of 5 kids who landed up with a similar presentation. Looks and extremely irritable, right? So before you think irritability is because of the urticaria, have a look at the BCG because it's very, very classical. This child had a BCG reactivation, right? And sure enough, the BNP came high. This was incomplete KD with dysfunction. And this, the clue is this, can you have the volume? Extreme irritability, and this is very, very classical of KD. And this is just 3 days post giving IVIG and steroids. So this was Apollo Hospital where we cut the cake. You can shut the volume off, thanks. So birthday cake was cut in the Apollo and got discharged 2 days after his first birthday. So the last case I promised was a very elderly girl or a slightly on the outer limit. She was about 14 years. She came with peeling and said, कुछ कर सकते हैं क्या? Then बहुत कुछ कर सकते हैं. Turned out to be KD, was still spiking. We gave her IVIG. 50 kg girl, pre-MISC era, and I still remember I rang up Dr. Suma to ask how much IVIG to give. 100 grams was a lot then, and she just said, do your math and give the IVIG. And I gave her 110 grams, and the fever went away, but sure enough, she started having blurred vision out of the blue. And I was like, what's happening now? Blurred vision. And then turns out I sent her to the eye doctor, and she said, the eye doctor was more excited. She said, this girl has got crystalline uveitis. So IVIG crystals start getting deposited in the iris, and it has been described in literature. And you do IVIG, obviously the IgG levels came sky high thanks to the IVIG. You just gave her Solumedrol, everything reversed. This is the OCT which was there. And so when you're giving high dose of IVIG, remember to explain along with hemolysis, aseptic meningitis, please remember to counsel them about this possibility of a crystalline uveitis. You may not say it, but you may say it occasionally. So KD is certainly increasing, which you are sure. Be very careful, infants and older age. Do not rule out KD or refuse a diagnosis of a KD if you are seeing a coexisting infection. Anasarca, shock, HLH, torticollis, pneumonias are the different phases of Kawasaki disease. Aseptic meningitis, sterile pyuria, BCG in the less than 1 year old. Long-term morbidity is a problem with these kids. IVIG resistant, we will be talking about intensification soon. Rarely iatrogenic and idiosyncratic things like the uveitis or the crystalline uveitis may happen. And it talks about being a bit proactive. So when to think of KD? Fever for more than 5 days, fever for less than 5 days, fever with all the signs, KD with a few signs, KD with unusual signs, no signs, and no fever. That's probably the message. After today, everyone will probably start seeing or thinking of a KD tomorrow. Who's this? Quick. I have a flight at 3:30. inventor of Rasgulla. So this is the classical Kawasaki disease. I think it has to be white, and you have to go to KC Das before you catch the flight. But even they are coming out with a pink-colored, strawberry-flavored Rasgulla. So it is a bit of a deviation from the normal. And this is what you are going to see a lot, the different faces. This lady is someone who's producing 270 types of Rasgullas in Calcutta. How many of you have heard about her or read this? Very few people, which is very unusual. So there are much more surprises in store. And I wouldn't want to try a sun-dried tomato flavored or a capsicum flavored, or for that matter, a lemongrass flavored Rasgulla. So don't refuse a diagnosis of KD. I like this cab. I think all the cabs in Kolkata says no refusal. So
it is, have you ended your lecture?
Done.
So it is simply mesmerizing.
Thank you.
And thank you, Dr. Vijay, for this beautiful presentation. And can we have any questions?
Moving on to our next discussion, I would like to call upon stage Dr. Shubhrata Chakravarti, who is well known for his work in KD in his nascent stage in India. Now he is a consultant at Manipal Hospital, Kolkata, to have the discussion on treatment augmentation in KD, when and what, center-based experience.
Good morning, everyone. I think it's going to be a very interesting session. Treatment augmentation in Kawasaki disease. When we go see the regime in different centers throughout the world, it is variable. Some will use IVIG with infliximab at the beginning. Some will use IVIG with steroids. And at the same time, I will request the speakers to discuss the present, what should be done in our country. Say you are treating in a sort of a district hospital, what should be there? So now we have excellent faculty, and we were just hearing them. Discussion will be Dr. Suparna Guha, Dr. Suparna Guha, please. Dr. Suman Bala, Dr. Vijay Vishwanathan, and Dr. Prabal Barman. Please proceed with you.
So we have a whole day on KD today, and this is primary intensification, something new which has come up, and that is why we have thought to include this in the topic today. It's not moving this screen. So why is the need for primary intensification? So this is a real life, this March 2018, a 2-year-old child admitted with KD. Day 7 echo reveals the mild aneurysms of the multiple coronary arteries, receives the standard treatment, IVIG 2 gram per kg, but the subsequent echoes and a CT angio almost about 5 years later continues to show persistence of the aneurysms. In fact, they have increased in size. So about 80% of those children who present with coronary artery lesions continue to have worsening of Z scores. It occurs in about 1/3 of these patients. They continue to have persistent aneurysms because the endothelial dysfunction continues. So we know that 20 to 25% will develop coronary artery lesions. You give them IVIG, 5% they will persist, out of which 1% will be major giant aneurysms. And these go on to have major adverse cardiac events later on in life. And our aim is to reduce these incidence of the cardiac events. So hence we have to do something like the Uri style. We have to strike them hard and we have to strike them fast. So there is the need for primary intensification. That is, you add on something to IVIG so that you intensify and you augment the therapy. So who needs primary intensification? Those who are at a risk for developing coronary artery aneurysms. Infants, adolescents, a male child, delayed diagnosis like Probal was talking in the morning, incomplete KD, those who have a risk for developing IVIG resistance, KD shock like Vijay has just mentioned, and those who present with mass. And now the AHA guideline has come up that anyone who has a primary, an initial Z-score of more than 2.5 will need intensification. So this session will be entirely on intensification. Options are many. We have invited speakers from all across the country. Suma is from the south, Probal is from northeast, and Vijay is from Mumbai, and we will hear from them what are the options where we are using and what are their results. So Suma, to you first.
Hello. Yeah. So it's my pleasure to be here again, and just hope to. I work in a tertiary institution well supported by an excellent pediatric cardiology, peds, etc. So we can see a lot of complex cases. Not going to waste too much time, but the whole idea of KD is trying to diagnose it early, because the reason why we say IVIG works best in the first 10 days is knowing the natural history of the disease and the pathology of the disease. And if you look at the pathology of the disease, the aneurysms start developing on day 12 and go upwards. So you need, if the earlier you strike, the less the damage. And the last picture, it shows what happens later on in the pathogenesis. You have the luminal myofibroblast proliferation, which is very much led by IL-1 beta. And so basically treatments are all triggered according to the pathogenesis. Now, there's been enough work to tell us that even if you give the standard therapy, IVIG, within first 10 days, we still have 15 to 20% refractory patients. So those patients are the ones who have the highest risk for CAAs. And there is also enough work studied that aspirin has got nothing to do with CAA risk. Whether you give low dose, medium dose, high dose, it's got nothing to do with CAA risk. To me personally, the maximum it does is work as an antipyretic while IVIG starts doing its work. And we also know that predicting IVIG resistance upfront is more important rather than picking up IVIG resistance after it has happened. And especially infants below 6 months with KD have a 50% risk of aneurysms as opposed to older children. There's been a lot of work, which I won't go into now. This is an elegant article. Rakesh is the first author for this article, Rakesh Pilania, who's here. And they have shown us, again, the PGI protocol where they pick up patients who are infants, male sex, prolonged duration of fever, persistently elevated inflammatory markers, presence of IVIG resistance, a coronary artery Z-score above 2.5, the presence of MAS or Kawasaki shock. These patients need primary intensification. So we'll look at a couple of cases now. 20-month-old boy, he has a classic complete KD. He's actually diagnosed on day 6 and he's given standard risk therapy, which is actually appropriate for this stage. Now, after standard risk therapy, he remains febrile, so he has IVIG resistance. He's referred to us. He started having coronary changes. Not by day 8, we are seeing early coronary changes. So what will we do for this? So standard risk KD, IVIG resistance, gave him steroids upfront, because once you have coronary changes, one of the best drugs to use is steroids at this stage. And the plan was, if we do very frequent echoes, if it doesn't improve, then I would give him IVIG next, cyclosporin, etc. But he improved. So this patient, this is all he needed in terms of intensification. This is a 5-month-old child, already high risk, and an incomplete KD with very high inflammatory markers. And actually KD was diagnosed day 4, very astute pediatrician. But they gave what the AHA guidelines say, first line treatment, the term I hate, because this child is already high risk, 5-month-old, diagnosed on day 4, severe disease. Okay? So this child actually needs treatment intensification. Not surprisingly, even though IVIG was given on day 5, the child remains febrile. Comes to us day 7 and has already got a prominent coronaries with a Z-score LAD greater than 2.5. This is a child who will progress to a giant aneurysm if we don't address the situation now. We gave her IV infliximab and 2 mg per kilo oral steroids. She had very good response, no further coronary progression, and has improved and is very well on follow-up. This contrasts that to the 6-month-old child who was febrile, irritable, presenting with various features of KD down the line. Unfortunately, the pediatricians kept thinking it's UTI, 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 hitting him with more and more antibiotics because every time he has sterile pyuria. And it was finally on day 21 that somebody decided to do an echo, and by then he already has giant aneurysms. So just like we say, justice delayed is justice denied, diagnosis delayed is treatment denied to these patients. And here, they started IVIG at that point, but he started having reactions, so just fast-tracked him to us. What do you have? You're on day 22. You saw the pathogenesis chart, you saw the natural history chart. We have very little time to make change. Okay? So this is not a time where you give one thing, you wait 2 days, give another thing, you wait another 2 days, give another thing. You got to give it all together. So we gave him IVIG, we gave him infliximab, IVIG, and methylprednisolone pulses. Repeated an echo, not much difference, gave him cyclosporin. Still no difference, and I spoke to the parents, day 28. I said, there may not be much we can do here to modify the course. There is one more drug we can try, that's anakinra. We have it, it's expensive. I'm not promising you at this stage it's going to make a difference, but we have a small window, we can try it. They were willing to try it, they were willing to spend. If you can't spend, it's okay. Because at day 28, if they can't spend, it's not the end of the world. But we used it anyway. Whether anakinra helped or what, at least it became static. We're continuing to follow him up. He's crossed a year of age, he's running around and playing with these time bombs in his heart. Okay. And here is a 1-year-old boy who, this was 2022 when MISC was over. It was actually over, and this boy had features of KD. He was probably not a bad thing. He was diagnosed as MISC initially because of that he got steroids along with the IVIG, which is not a bad thing in retrospect. But anyway, he was diagnosed as MISC, but what the clinical picture actually was of KD, myocarditis, and HLH. You look at his blood thing, his platelets are low, he has transaminitis, low fibrinogen, high ferritin, etc. So he had a very, complicated KD here. And with significant myocarditis and LV dysfunction, he was ventilated. He was given IVIG, he was given 2 mg per kilo methylpred per day like the initial MISC guidelines, but he wasn't improving and he was referred to us. The HLH was ongoing. I increased his methylpred. Despite that, he wasn't getting better, so we gave him anakinra. So the option was cyclosporin versus anakinra. The family were quite happy to use anakinra. I think cyclosporin would have also worked in this stage. It is cheaper. But this family was willing, and it is the better drug for HLH at this stage anyway. So we gave him anakinra. We just needed to use 8 days of anakinra. Everything improved. Though he had an LAD Z-score of 5.8, that also improved on monitoring. And he continued on low-dose aspirin later, and by the end of a year, we were able to stop that also. So again, this could have been a bad story, but thankfully we were able to avert that. A 4-month-old child, incomplete KD, the diagnosis is picked up on day 13. She gets IVIG and high-dose aspirin. Serial echo actually showed further dilatation, but no intensification was done. She comes to us on day 21. She's got high Z-scores at that point. We gave, methylprednisolone, she's still febrile actually. We gave methylprednisolone with infliximab, changed to oral steroids, but the Z-scores got worse. She went for giant aneurysm. So at this point, again, I talked to the family. We are further down, the further down you are, actually IL-1 beta is the best target. And so I tried anakinra again, and this was remarkable. I don't know whether it was natural history or the anakinra, but after 5 days, the coronaries just started improving beautifully. She came out of the giant aneurysm, went into moderate, and over time has completely settled only on Echosprin, and she's doing well. Where are we with anakinra? There are 2 studies. One was a pharmacokinetic study, and the second one was a phase 2 study looking at a small list of people. The phase 2 study showed significant improvement in the children given anakinra. And then we have a whole lot of small case series and case reports, all with varying doses, varying durations, etc. But there is no doubt there is an increasing, there's a pathological reason to use it, and there is increasing interest, and this is a drug that can actually help these patients when they have bad disease. We looked at our giant aneurysm in the last 5 years with KD. We actually have 18. This paper was prepared for the last year's National KD Conference. That time we had 15. We've had 3 more since then. And out of 15 children, you can see that 9 were complete KD and 8 were infants. Okay? The main factor that we isolated was delay in intensification of treatment that they went for. So delay in diagnosis, delay in intensification. These were the 2 factors that were affecting the development of giant aneurysm. So these are factors we can improve on. Definitely factors we can improve on. 1 death, 1 CABG. Very costly, very, very costly. And 2 patients have actually regressed down to normal levels, but the rest are still wandering around with moderate to large time bombs in their heart. So this is an area where we have to improve a lot. And so I'll just stop here. KD is a high morbidity disease with potential mortality and long-term morbidity. The opportunity presents in the early phase. The earlier we diagnose, the earlier we think of stratifying the risk of this patient, high risk, standard risk, and applying treatment methods. The person you need to call for immunomodulation, I repeat again, is a pediatric rheumatologist, and the person who helps you with monitoring and everything is the pediatric cardiologist. So it's a teamwork. It's a teamwork. And there are more and more immunomodulants showing early promise. Cyclosporin and IL-1 targeting are probably the agents of the future after you've given the steroids, etc. And with that, I invite you to the National KD Conference in Cochin in November 22nd, 23rd. All you need to know about KD, all you want to know about KD, all you don't want to know about KD, everything will be discussed there. So I'll stop there. Thank you.
Thank you, Suma. So from Suma, down south, we moved north, Mumbai wala. Dr. Vijay, he will tell us his experience regarding primary intensification.
Okay, just a small correction. North, I'm slightly south to north. I'm west still. Okay. Typical Kawasaki disease, no issues in life, straightforward diagnosis. Remove 1 or 2 clinical features, you start looking at an incomplete disease and the future. We are going to see a lot more of atypicalities and a lot more complicated stuff, right? And I think I talked to you about 1963, about Sri Devi. 1961 was what this movie was released, Dil Apna Preet Parai. This is the best way to sum up Kawasaki disease. It used to be a very straightforward story, but we still don't know what is the story, when does it start, kahan shuru, kahan khatam, right? And is it really khatam, right? Perfect. I would like to pay tributes to this gentleman who, incident, all of us know this story, that he was in Delhi at the Asian conference and he just happened to ask our Indian Pandits, have you ever seen KD? And they said it doesn't exist in India, without realizing that the person asking the question was none other than Dr. Kawasaki, right? And the rest is, as they say, is history. So we've moved from identifying Kawasaki disease to intensification of therapy in KD. And this is my geographic area. I can't get away without showing this slide because I start from Thane, I reach Vashi, and I finish at the end of Raigad. It's a typical V kind of a scenario, and I'm surrounded by oceans on both the sides. And water bodies, industries, and probably a bit of genetics explains the unique phenotypes that I keep seeing at my place. Lots of shock syndromes, dilated coronaries which regress back to normal, doesn't trouble me like a Priyankar or a Suma's case with giant aneurysms, thrombus, etc. Just for information, I am following about 426 kids in the last 7 or 8 years, and only one kid has had a thrombus. So probably it's something to do with genetics or early referrals. So what are the inherent issues with intensification according to me is, I'm not being cynical, pediatricians are extremely clever, but there seems to be an inherent hesitancy in picking them up, or if they pick up, referring them, or like someone said, it's a pure pediatric disease. And you think of the rheumatologist only when you get into trouble. So it leads to a bit of a delay in diagnosis, like Dr. Suma showed. So delayed referrals will obviously is compounded with varied treatment protocols and the Z-score discrepancies. There are no cardiologists in the audience, right? Because there are? Okay. Because I always use the example of objects in the mirror are closer than they appear. This is the cardio report that I have one KD cardiologist in Thane and one in Navi Mumbai, and very seldom do I get a normal report from one of them, and the other one, if it gives a normal report or an abnormal report, I am super sure I am not missing out. So end decision is mine, and it's not Z-score based, right? So that's one problem that I face. Intensification, again, there are lack of studies or standard guidelines to the how to identify a high-risk KD, because the Japanese scores don't go well with the Caucasians, and Indians are probably overlapping between the East and the West. The Sun score or the SON score that Prabal said is less sensitive and more specific. Myocarditis, KD shock syndrome, HLH, atypical presentations don't seem to figure out in the intensification studies that we encounter. And last but not the least, I'm still waiting for an Ambani or an Adani's grandchild to get a KD. Many of the kids I see are the lower middle class kids who may not have the financial resource to afford an infliximab also, right? And last but not the least, I don't see such bad giant aneurysms till maybe 1 year back, which we'll keep for some other day. And I think it's genetics. Suma thinks that you have taught a lot of KD to Maharashtra, so they get sent to you a bit more earlier. So you end up giving steroids and intensify these kids much earlier. I'll skip this slide because we've discussed. And just two studies where one of them talked about intensification compared with IVIG alone and IVIG with steroids. And the other study, which all of us know, talks about infliximab being an extremely reasonable option with a significant reduction when you give a higher dose of infliximab along with IVIG. So we know that intensification with steroids and or IVIG probably helps in lesser progression, and infliximab is a good, works good at a higher dose of 10 mg per kg. So what do? I think the SON score is not much helpful from where I do, because we are Asians, I think. Z score of more than 2 is something we are all catching up to. CRP is more than 13 and less than 6 months is what we know after the morning. What do? I think all infants below 12 months and not, that's a typo. It's a diagnosis less than 5 days. Most of them that I see will have an ESR which is very high, so the 30 is just a cutoff from my side. The kid with a high BNP will have hyponatremia. AST, ALTs are high and albumin less than 3.5. What I do is like a fusion of the Igami, Kobayashi and Sano scores, because all of them seem to be fitting into the sick kid profile that I see. So it makes my decision to intensify quite easy. And Z scores less than 12 months, I use it as a criteria of Z score more than 2. And above 12 months is more than 2.5. Ask me why. Objects in the mirror closer than they appear. It's just that my threshold to intensify is slightly high in children who are less than a year, right? And obviously KD shock syndrome, severe myocarditis, HLH, and atypical presentations like a stroke or an encephalitis, I do intensify therapy. And I was just going through my case series to make this presentation, and I realized I have a combination of IVIG alone pre-2016, 2017. IVIG with steroids has been a routine, and I must confess that I am not bold enough to use only IVIG and infliximab yet. So all the kids that I have given infliximab have followed an IVIG and a steroid, and infliximab is more out of abundant caution that throw the potential kitchen sink to save these kids' lives. But as I said, it's ASAP. There is no right time to intensify. It is as soon as possible. So what I did was just take 10 from each of my cohort, 10 who received IVIG alone, 10 who received IVIG and steroid, and 10 who it is controversial, but I thought I should pick up IVIG plus infliximab and steroids. The age group is the classical age group, the median age of 3.2. Third of them were less than 12 months, and 30 to 40% were incomplete disease, and the median diagnosis was around 5 days. So I am actually blessed not to have the delays that Dr. Suma sees. Many of these kids do come to me a bit early, between 5 to 12 days. And not much of a difference data-wise. I haven't done any major statistical calculations. It's very obvious that the guy who received all the 3 of them had slightly more of the Z-score elevation towards the 3.5 to 4.5, whereas the kid who got only IVIG, again, it's retrospective, so we're in that 2.5 to 3 age bracket, and somewhere midway was the IVIG and steroids. It seems, at least to the eye, that the triple intensification led to less progression, because over the course of treatment, I'm saying 1% means 1 out of 10, 2% means 2 out of 10, and 3% means 3 out of 10. This is just a random 10, 10, 10 kid that I have taken. But the good thing is that, barring a subtle difference at 3 months, all these kids made a complete recovery vis-a-vis the Z scores in 6 months. Again, I think all of them received intensification between day 5 to day 15, and I am sure that the Western phenotype, if you are aggressive enough, you will probably start seeing a better result, right? So 3 cases and I finish. This was a kid who was 6-year-old, the usual story, red eyes, red lips, gets to the pediatrician who has a lymph node also, starts on amoxicillin, gets a rash, gets labeled as an EBV, and I say today is the cardiologist's birthday, so we won't trouble him. It's only day 5 or day 6 of the illness. The cardiologist comes on day 6 and does the echo, and in a 6-7-year-old boy has a Z score of 6.5 and 5.4. And I say, I am busy, I can't see you today, so that they don't blame me for that 1-day delay. But then this was a very tailor-made situation. A young child, only child, 6-7-year-old, and such a huge coronary on day 5, day 6. Tailor-made situation. This kid I saw about 9 months back. I gave all the 3, IVIG, steroids, and infliximab. The child kept on running fever after IVIG. Fever started spacing out after the steroids, but the CRP was not completely normal, so I ended up giving infliximab also. And the difference was that definitely at 6 months, the LAD became completely normal, but the RCA still remains a problem. So it did seem to reduce the intensity, but there seemed to have been some merit in intensifying this story, right? Remember, the rash has to be always given importance rather than thinking whether it's EBV-induced rash, etc. So we'll go to the next case. This is, again, one of the unique Western phenotypes, as I see, came to me with shock, and this is almost like Dr. Suma's case. Platelets on the lower side, a high CRP, a lowish ESR, transaminitis, a combination of myocarditis and HLH, right? The classical BCG reactivation in an 11-month-old. Very unfortunate to have a GI vasculitis. The child had bilious vomiting and a gangrene, underwent resection and anastomosis. And prior to MISC, I used to call this Konkan Coastal Kawasaki shock syndrome or KD shock syndrome, because we used to see a lot of kids like this. And again, at that time, knowingly or unknowingly, I did intensify with steroids in a kid who was perforating. And this child recovered without any coronary sequel, probably because he had more of an acute severe presentation at onset. The last kid was again seen, this child was again labeled as measles, like we saw in the morning. The rash was labeled as a measles, 9-month-old, and then went to the intensivist and comes to me through the ID specialist. There is something wrong with this child. Sure enough, this child I saw on day 13, and then obviously his Z scores were 3.5. He had an LAD and an RCH Z score of 4. And I again did, and this was a photograph the mom showed. इससे तो और ज़्यादा लाल था जब आया था. Don't miss these things with the because the measles fever will not go on for 13 days, obviously, right? And IVIG steroids, infliximab, this echo was completely normal at 6 months of age. The last kid I will show is, this is a child who was a 1-year-old. Again, one day before the birthday, ended up with shock syndrome. The parents did not want to do any further blood tests like an imaging, etc. The treatment got delayed by 48 hours. This child received IVIG, steroids, methylprednisolone, infliximab, cyclosporin, and by day 18, this child had a Z score of 2310, extremely huge. And I asked the cardiologist if there is any improvement, and he said there is an anaconda sitting inside. So his coronaries were larger than the aorta, right? And this was the first time I thought about using something called as the IL-1 blocker that Dr. Suma talked about. And then day 18, I gave him anakinra, and this child seemed to stabilize in a couple of weeks' time. At least the coronaries did not keep on increasing. So what's the conclusion? I think primary IVIG with steroids, with or without infliximab, I'm not yet sure, but there is definite merit in intensification with 2 or 3 in preventing the progression. There is definitely a better outcome as far as my kind of patients are seen at 6 months. And whether you use steroids or infliximab is anybody's guess. So to conclude, this is the Western side. I am concluding. So I think the Western phenotype is unique. They bark a lot but don't bite. I think it's a combination of genetics as well as early referrals. This is usual Priyankar and Suma that I meet at conferences, but when I speak to at least Suma, Priyankar is too busy. This is, I told you, I am again, so when this her epidemic was happening in Kerala, day 20, day 18, I was like, 2-3 hamare paas bhi bhej do. I want to see how do they look like, and this is how they look, the faces of Kawasaki, and you know, and I think after today, all of us should probably be sensitized that you don't see the bad face of either Suma or Dr. Priyankar. So finally, I think, you know, this is a regular KD. Most of us will not miss. This is something that you should be scared of, and no prizes for guessing that the brainiest people come from Suma's land. So incomplete KD becomes a bit tricky when it comes to managing. the most worrisome thing is, when things are absolutely silent and you don't know what's happening and you don't want to miss out on these kids. So please pick up the phone and ask help if needed, because none of us are experts. So to conclude, straightforward infantile KD without any high risk or coronary lesion, IVIG might suffice. Infantile KD with high risk, Z scores 2.5, the panel alluded to. With low albumin, atypical HLH KD, you may do what I do, steroids plus minus infliximab. Infantile KD with Z scores up to 5 at diagnosis, we definitely intensify. And giant aneurysms, IVIG plus steroids plus infliximab is what I do. Possibly cyclosporin, KAIKA trial, or anakinra is probably advisable, and dramatic progressive course. If you see an anaconda, you give anakinra. Thank you very much.
Excellent, excellent. Next, please.
It is definitely Ajeeb Dasta hai. So, sir and ma'am have described beautifully the difficulties that we have in identifying these patients, particularly the atypical ones. So I have been working in Guwahati Medical College, northeastern part of India. It's a government medical college. So we don't have access to all these drugs that ma'am and sir have been talking about. So even right now, the government of Assam supplies only 30 grams of IVIG per patient, whatever may be the reason. So if a child is above 15 kilograms, we sometimes have to give a dose which is actually less than 2 grams per kg. It's unfortunate, but that's the situation, I assume, even in places where we don't have access to all drugs. So I will not be going into detail, just a couple of cases that I have seen from Assam and even during my tenure at PGI. So this was a case, I think Rakesh sir would remember. So this patient comes from a remote island called Majuli. You might have heard, it's one of the largest river islands. It's a remote place. So this particular boy had the fever, some rash, but because of the patient, the physicians were not aware of Kawasaki or anything else, was just given antibiotics. In the 4th week of illness, he had developed some respiratory distress. The echo had shown pericardial effusion, some mitral regurgitation. So he was treated as viral myocarditis, then referred to Guwahati because we have a pediatric cardiologist who works there for an echo. That echo revealed giant aneurysm which was larger than the aorta itself. So then this patient actually came to PGI when I was the 3rd-year resident at that time, and we managed this patient. I'll be discussing how we went about managing this particular patient. So just wanted to highlight the delay in diagnosis that I still encounter, especially in areas where people are not even aware of what exactly Kawasaki disease is, even amongst pediatricians. So we have another patient. This was a boy which I saw 2 months back, a master 8-year-old boy who presented with acute febrile illness, some maculopapular rash on day 1 of illness. So these were his counts initially. On day 3, there was some neutrophilic leukocytosis, anemia. By day 5, the platelets had started to rise. Someone did think that is this Kawasaki, so that's why that they referred this patient to me in GMC. On day 7, by day 6, day 7, as you can see, the platelets have started dropping, the ESR started dropping, and the CRP was high. He was extremely febrile, and on day 7, he had developed skin peeling. So there was no doubt that this was definitely Kawasaki, and probably he had started developing HLH or KD shock syndrome-like features. So this was the pro-BNP, which was very high. The echo did not show any coronary aneurysms, but the ejection fraction was low, around 30%, and there was some evidence of myocardial dysfunction. So how do we go about managing that patient? One more patient we have. This was a patient just 2 weeks back I saw. She was a 5-year-old girl, again came with acute febrile illness with a GI focus, was being managed outside as diarrhea. And however, the fever did not come down even after 10 days of getting high-grade antibiotics. Someone had thought about UTI, had sent the urine culture where there was some pus cells. The culture had grown E. coli, multiple antibiotics, no response, so referred to my institute as a case of PO. When he took the history, the mother said that she had some conjunctival injection, some cracking of lips, and when we showed her photographs of what a strawberry tongue looks like, she said this is how her tongue looked on day 2 of illness. So this was a typical case of Kawasaki, but because of lack of awareness, the initial physician did not think of it, and by the time they came to us, it was a bit late. On initial investigation, she had anemia, there was thrombocytosis, high ESR, CRP, proBNP was also elevated. Fortunately, the echo was normal, although the proBNP was elevated. So she was given the standard treatment, IVIG, aspirin. She responded dramatically, became afebrile, improving clinical parameters. Post IVIG, we repeated some of her parameters. The proBNP had reduced, but it was not normal. The CRP had reduced, but it was not normal. The repeat echo was also normal. How do we manage this child now? Does she require intensification? Should we just send her home? Let's discuss. So several risk factors, risk scores have already been discussed, so I will not be going into detail. These are some of the risk scores which I also discussed in my previous talk. Various countries have developed their own scoring systems. The common features amongst all these scores is infant, coronary aneurysm at diagnosis, very high inflammatory parameters, atypical presentations, particularly KD shock syndrome or HLH. So these are some of the common features which may let a doctor know that probably these are the cohort of patients who require intensification of therapy. So these are the various groups of patients who may benefit from intensification of therapy. So this was the paper which I wrote with Dr. Rakesh sir and my mentor, Professor Sujit Singh. So this was the sequence of drugs that have evolved over in the management of Kawasaki disease. So it was only in 2014 when the concept of primary intensification came into clinical practice from a paper from US. So and after the landmark KAIKA trial, which showed that cyclosporine is also a good drug in reducing the incidence of CAAs, in the last few years and even in recent AHA 2024 guidelines, all of these guidelines have recommended the concept of primary intensification in these patients. Now, which drugs to use? Ma'am and sir have access to almost all the drugs, including anakinra, which is actually not available in India. You have to import it from outside. So it's not available in any of the government hospitals. So right now, there are no head-to-head trials showing which of these three combinations is actually better. So we don't know whether infliximab is better over steroids over cyclosporine. So there are multiple network meta-analyses which have shown that both works, but which one is better, we are still not aware. So just a brief role of statins as well. I think Rakesh has already spoken about how we use statins as an anti-inflammatory drug. So this is probably not dealt in detail in the latest guidelines. Probably in the next update we'll have, because 2 trials are currently undergoing, one in US and Japan, where they are trying to show whether statins may have an additional role in addition to the biologics that we discussed right now. So who is the ideal candidate for treatment augmentation? So this is the algorithm that is followed at PGI Chandigarh. So in an infant or adolescent male child, prolonged duration of fever, persistent elevated inflammatory parameters, IVIG resistance, CAA, MAS, KD shock syndrome. In this group of patients, probably a combination of these drugs would be useful. So at PGI, a combination of all the 4 drugs are used, IVIG, followed by infliximab, steroids, as well as cyclosporine, in addition to aspirin and atorvastatin. So I just want you to focus on the points which I have highlighted, because we have strong evidence for infants, male sex, CAA, MAS, and KD shock. For the others, although we have evidence, but the level of evidence is slightly less as compared to the ones which I have highlighted. So in Guwahati, what I do is, if those highlighted points are there in a particular patient, we would be starting the standard treatment because that's what the government supplies. followed by methylprednisolone. This is also supplied by the government, so it's easy for me to start methylprednisolone. Then cyclosporin. This is not provided, but compared to infliximab, it's a cheaper option, so we give in cyclosporin. If patients are affording, and once I explain to them the risk of cardiac compromise, then probably I would start infliximab. So in the last 1 year, over a cohort of around 50 KD patients, around 15 fulfill the criteria for high-risk stratification. So mostly I start IVIG followed by steroids and cyclosporin. Only in 2 patients right now I have been able to use infliximab. So this is what I did, and even in PGI for the case 1 and 2, which I discussed. The case 3 is a peculiar case because the patient did respond, but on the investigations, there was some mild inflammation. So there is no data to suggest what exactly we need to do. But because that particular patient, again, came from a remote area, and it's not always possible to do a repeat echocardiography at 6 weeks or even 8 weeks follow-up. In fact, most of these patients get lost to follow-up once we treat them for the initial acute attack. So in this particular child, what I did was we just started a low dose of oral corticosteroids and then tapered over the next 2 to 4 weeks. So although research is still lacking, in places where we don't have access to all the available drugs, sometimes financial constraints also influences retreatment decisions. Thank you.
So, thank you all the speakers for enlightening us with your experiences of using different agents in different scenarios. So in Kolkata, in our center, we have been using a lot of infliximab and steroids because anakinra is not so easily available. Though in ICH, Dr. Priyankar is trying to procure the drug. So I would like to hear from Dr. Priyankar his experience regarding intensification. Priyankar, are you there in the audience? Priyankar, you're there? Huh.
I think Anindita is presenting our data. So she has a paper, Treat to Target in Kawasaki Disease. So I think she will elaborately present the data. So we have been using infliximab for years together now, and cyclosporin, and somehow or the other, I don't know, steroids have not really worked much in our cohort of patients. I don't know what is the reason. Something may be genetic. But infliximab, we are very happy with infliximab. And cyclosporin also we have used in a cohort of patients, along with infliximab.
Thank you. So same with our experience, we are not very much comfortable with steroids. We have been using infliximab along with IVIG upfront in the high-risk patients. So the need of the hour is to understand these children who need intensification. You should hear the KD child shouting out, "Ye dil mange more." That is, you have to give them something more apart from IVIG. So from after this panel discussion, we have come to a conclusion that we have to identify this, as Suma had rightly pointed out, stratify these children who are at high risk and intensify and augment their therapy upfront. Do not shy away from using steroids, infliximab, anakinra, whatever access you have to, even cyclosporin, along with IVIG. So it is basically an icing on the cake. So any questions from the audience?
In Japan, they have actually reported sibling risk. I haven't seen sibling risk in India. I've seen one patient with... In Japan, they have actually reported sibling risk and KD happening within the family. I have seen recurrent KD in the same patient, only in one patient.
So just to answer that question, just recently, just a couple of weeks back, we had a patient whose mother actually diagnosed KD. So The elder child had a KD in 2018. So it was a late diagnosis. And the mother knew the symptoms. So she had visited, she comes from a little remote area outside Calcutta. So she had visited a pediatrician on day 2 of illness. Some bloods were done, which were completely normal on day 3. But day 4 of illness, she thought that redness of eyes, redness of lips is going on. So she came to us. So it was a Kawasaki disease, which was actually diagnosed by the mother.
I, just to add, so I think there is a higher risk in twins, is what I remember reading. If there are twins, then there is a higher risk. The other history that I often find useful is to ask for a history of young heart attacks in the family. Especially, I remember 2 kids. One father who was an absolute teetotaler, 35-year-old, non-smoker, non-alcohol, just drops dead. That was one. And the other kid was treated properly, and I just pocket dialed by mistake. I asked, how's the kid? The kid is fine, but the uncle dropped dead of an MI. And one mother who has migraine. So it's unique, it's peculiar, but not surprising. Migraine is a vascular disease, young age heart attacks. We talked about the LMP responsible for premature atherosclerosis, young age attacks. Sometimes the history of such incidents in the family would probably come handy as far as monitoring and diagnosis of the current case is concerned.
I mean, I have one family where the father has ANCA vasculitis and the child had KD. Simultaneously diagnosed.
Just as
Any
you
more-
were asking
any more
regarding
questions
the
or comments here,
siblings or family members, so in our cohort of 1,500 patients, we have 7 families where their siblings has been affected. It's extremely uncommon, but in our cohort, we have 7 families, like their siblings are affected. And these siblings are affected sometimes within 4 weeks or 6 weeks, or sometimes they are independently, like they are coming after 1 year or 2 years. Because once one child is diagnosed, parents are more think that whether this child is also having KD, and they'll be more forthcoming for the consultation also. So, but we have 7 families.
So
I don't think so, and I don't know also.
So basically, it is an interplay of your genes and your environment. That is in a nutshell. Yeah. So anyway, any more questions from the audience, or otherwise we close the session? Thank you.
Thank you for all the faculty for the excellent deliberations, and thank you to organizing committee for organizing this session. Thank you.
Now I would like to call upon stage Dr. Shumita Basu, HOD Pediatrics of RKM Kolkata, to have a discussion on quantifying inflammation in KD.
Good afternoon, everybody. May I now request Dr. Rakesh Mondal to come to the dais and give us a talk on quantifying inflammation in KD. We all know that in KD, as a general pediatrician, we want to identify these cases very early. So CRP, beyond CRP, ESR, and the leukocytosis, thrombocytosis, what else can we know from you? So over to you, Dr. Mondal.
Actually, sorry, I was not there yesterday because of some personal work. So already a lot of discussion on rheumatology and KD for last 2 days. And since morning, there are a lot of experts from different parts of the country. They are delivering recent updates on your Kawasaki disease. I'll just go away from that. I'll talk something uncanny, something probably not that explained. Let's see whether it actually helps or not. As you know that as a doctor, what we can treat, infection, inflammation, these things. But how much actually we know about inflammation? Just I will see that perspective. Actually, we are doing some project on inflammation research. What actually inflammation, how much we know about inflammation, and how much is there in the literature, and how we can do further in future. I will discuss some of the inflammation, and then we'll discuss inflammation in KD. Hey, next, please. These actually are very old things. Everybody, all the MBBS students since beginning, they know this is the 5 cardinal signs of inflammation, and very important epic picture, as all know. And if you see the inflammation, the historical perspective, it is a very old thing, the basis of actually our existence, our treatment, our whatever we do. Since Hippocrates from 5th century BC, he recognized inflammation. This is a very other way of seeing it. Then Celsus, he actually described four signs. Then in 6th and up to 17th century, then a lot of aspects of inflammation have discovered. And in 18th and 19th century, the inflammation, the relation in the blood, this was given some light. And as you know that only aspirin, we use the anti-inflammatory drug. The prototype, it was marketed only in 1899. So hardly we are 100 years something. And even we are using, how much medicine do you have in treating treatment? Either antibiotics or anti-inflammatory or chemotherapeutics. Others are support mainly. So anti-inflammatory treatment is very, very, very important part for our practice. Even corticosteroids have come up in 1950s and 60s. Then there are a lot of milestone. Biological drugs in 1990s. The inflammasomes 2002. And innate immunity. Now it is only in 2000 somewhere in that, and they got the Nobel Prize also. Previously, when we see the things, we are more of adaptive angle. But recently, we have entered into innate. We believe that probably it was not looked after that way. And in 2024, researchers have identified some mechanism where you can see the inflammation live. This is just information I got from the. So this is the science, you know. This is the injury, inflammation, pain, warmth, all these things. Etiology, people know, physical agent, chemical, biological, these are the things, exogenous or endogenous. There are two things, innate and adaptive. Adaptives are discussed, researched more. Innate are being focused in later part of the century than last few decades. And these are the complexity of inflammation. Initially, we were in the cell lines and only RBC, WBC, platelet. Now we are further down. We are already in the cytokine and chemokine. And the development is going that way. So it is going to stay. But it is a very complex thing. So just things, you cannot read all those things. And now everything is pro-inflammatory or anti-inflammatory. And most of the disease, if you read the mechanism, treatment, recent advance, people are going through those aspects. Manifestation, most of the things we know, pyrexia, constitutional symptoms, these are the things. And in rheumatology, our existence, one of the things is mostly inflammation management. This is one of the basics. So actually, how much we know inflammation? Inflammation, though, is very, very old things, but it's a very heterogeneous things. Sometimes they say it is according to pathology, serous, catarrhal, fibrinous. Some people say it's acute, chronic. Some people say it's systemic, localized, organ-specific. Some people say it is auto. What does mean? What do you mean by auto? Auto means you are saying inflammation, but you are saying auto. The others are not inflammation. They say that only innate immune cell dysregulated is auto. So others, if you use adaptive autoimmunity, this is also inflammation, but not auto. There's a very delicate difference. But sepsis also inflammation, cancer killing also inflammation. So it's a very varied and heterogeneous things, what I have read. And many a disease, after starting from one limb or innate or adaptive, then it get mixed. Because there will be T-cell, B-cell talk, MSc class presentation. It's a very complex thing, heterogeneous thing. Though what I have learned, studied earlier, it's not that simple. So tissue damage, now it's cytokines, inflammatory mediators, you all know that, cytokines, tumor necrosis factor, these are that things. Then CRP, people know, I will not go to that. And how we measure inflammation, systemic, CRP, fibrinogen, ESR, albumin. Then we have phagocytic cell, antitrypsin level, coagulation protein, complement factors, transport proteins, many things are there in the literature. These are the very complicated things, classical pathway, alternative pathway, final pathway. These are the things. Then TH1, TH2 cytokine. Now, just I will tell you one thing. Have anybody quantified it? After COVID, people are lot of paper on hyperinflammation. What is normal? What is hyper? What is hypo then? How do you do that? People are publishing papers, hyper, treating. How much hyper? How much mild? Have you quantified it? So there is a lot of things I think should be searched out. So what is hyper? What is hypo? Then what is normal? How much is normal? Any measuring skill? Any scoring for any systemic or organ specific? Whatever I got from the literature, this is very ill-defined. There are some hypotheses. The hypo is called lack of inflammation. What is lack? They have given some causes, possible causes. Most of them are theoretical. Then they have said these biomarkers to be seen, cytokines, blood cells and others. But what is normal, how much is high, that I didn't get anywhere. They said you can do this marker. But how to quantify hypo, how to quantify hyper, is seriously lacking. I have read all those things. Whatever information I can gather, I couldn't answer. But you can do this marker, they say. There are some scoring available, but it is not actually inflammation scoring. This is more of targeted disease scoring. H score, SOFA score, SMASH score. These are more of HLH score, SOFA for your intensive care. These are more of something not exactly inflammation score. It may be having some inflammation parameter, but it is not exactly inflammation score. Only one score I got, that is called Systemic Inflammation Index. It was published earlier. Okay, one information I got, one, sorry, to time is not there. So, in some information they have tried to identify mild, moderate and severe. Now, if you give anything in ChatGPT or DeepSeek, they will give you some information. And most of them may not be having reference. There is there, but I didn't get the reference. And it is heterogeneous. If you see, in mild, they have not taken ferritin. In moderate, they take ferritin. Hare, what is this? So, the time is not there, so I will just tell you. So, systemic inflammation index is there. But it's a very simple thing. They have used platelet count, neutrophil count, and lymphocyte count. If you see, it is basically a hematological parameter. So, what is inflammation? So, actually, they have not taken other parameters of inflammation. This is only hematology. But this is there. And they published also in big journals, also, systemic immune inflammation index. But it is a very simple thing. Platelet count into neutrophil by lymphocyte. So, but actually, I believe it reflects only the hematological part. So, it's not taken in account other inflammations, whatever we usually advise for when we are sending. But they have published some papers according to those inflammations and whether that help or not. So, and they have given some scoring also, but I believe it is very miniature things. It should not be representative of actual inflammation in the body. So, I am not going to that. Then one more score is that infla score. But that's also taken only C-reactive protein, leukocyte count and platelet count. That's why we actually were trying to know the systemic inflammation in the beginning. And we have taken around 8-9 parameters. NLR, PLR, ESR, albumin, CRP, D-dimer, ferritin, fibrinogen, procalcitonin. These actually we send. And we have taken control also. And we want to know sepsis also inflammation. Some part of it is inflammation. And SOIA prototype of inflammation. We want to know the difference. How much difference is there in systemic inflammations? So this is still going on. And we see that if we only see the inflammation part, the SOGIA inflammation is much more. But we actually, I am not going to the details of the study. We have not gone to the shock stage so that we can get something, it gets more complicated. So we have come out, we have come out with a inflammation scoring. Other scoring in inflammatory disease, lupus and other things, most of them are histological. Disease activity scoring. But exact inflammation scoring is not there. So we, one scoring is there in KD, but what actually they all always focused on only the coronaries, resistance. So these scoring they have made, but it is very simple thing, only AST and this thing. They only want to see the resistance and coronary part. There are scorings are there in KD. They too just to predict IVIG resistance, but patient severity, inflammation, that point is not probably looked into. So we have taken those parameters, in 8 parameters, we have come out with the systemic inflammation score. It is already accepted. So trying to know how much inflammation is there in the body. And we took also the your control and temporal control and made a score. 2 to 7 is minimal, 7 to 10 is moderate, more than 10 is more. We also compared SOGI with KD and seen that SOGI having more inflammation, systemic inflammation, not organ-specific inflammation. This is another part of the study that we have not done, but that can be done. So these are the things in nutshell, but detailing will be requiring more time. And we have taken the presentation, flare and remission also. And we have shown if you use that score, it will help you to know. Patient is saying, I'm fine, but how much inflammation is there biochemically. That probably will help. And we also did that box plot and all those things. And so it's still we are trying to know that inflammation, everywhere is inflammation. There is the international relation inflammation. Everywhere people are always having inflammation. So to be careful, to be stress-free, we have to have less inflammation, I believe. So we are doing these things so that we can quantify inflammation. Then we will see whether it will help the patient in prognostications, management, if at all. So that's much I can say. Thank you.
Thank you, Dr. Mondal, for that very lucid presentation. Do we have any comment or questions from the floor?
I have already have a book, one book, sir.
Yes.
I have published one book on pediatric clinical and rheumatology.
Whole day is required for discussion of this topic, and KD has been allotted one day. In next conference, I will suggest one day entirely for inflammation.
Many of our colleagues are the author there. One book is there.
Okay. Please mention the book.
It is. I have not seen, but it is there, sir.
Yes, I think that's a very valid point. We need a standardization of all the scoring system to guide us for these KD patients. Thank you so much.
Now I would like to call upon stage Dr. Devdatta Mukhopadhyay to chair the next two sessions. The first session will be on tidbits of echocardiography in KD, and the next will be on utilities of CT angio in KD.
So moving on to the next session, I would like to call Dr. Joyita Das, who is an interventional cardiologist from NH Howrah, and her interest is in advanced imaging, fetal cardiology, and structural intervention. She'll be speaking on the tidbits of echo in imaging of Kawasaki disease.
Thank you. Thank you for the nice introduction. I would like to present, I heard about all the lectures and all the speakers are wonderful about the KD. Just a little deviation from the topic. I would like to focus on the cardiology part about the tidbits of echocardiogram. Now we all know that the role of echocardiogram in KD, it has taken a little upfront in assessing the coronary artery involvement as a first-line imaging tool, as also for detecting the coronary aneurysm in case of serial monitoring, also for prognostication, and it's a very safe, non-invasive and widely available tool. First, we have to know about the few tidbits, like we have to have a high-end machine, the knobs, and obviously the person behind the machine. According to the function of the machine, we should have a proper high-frequency probe with a proper frame rate, proper mode, proper depth, sector width we have to adjust, and also a proper contrast. We have to bring a crisp image so that we can measure the edges and reduce the artifacts as far as possible. As far as the knobs, you can clearly see the left image and the right image. The left image is a little blur one. The right image, it is a little crispy, where we can see properly the edges of the coronaries, which is useful for the measurement. Now, as for the assessment of the coronary artery, these are the methods. We actually should have a cine mode in the echocardiogram machine. We'll do a we have to store the cine images, and then we have to do a post-processing, basically. We should measure after a magnification from the inner edge to inner edge, and also perivascular cuffing, which is now not so relevant. We should avoid the bifurcation, multiple views. We should take serial measurements and then take out the average, and standardization should be done with Z-score, and we should always obviously appreciate the aneurysm and the clots. Perivascular cuffing, as of now, it is not under any guideline of which will detect the diagnosis or management. Now the key considerations are, we should look at specifically the two arteries, which is the proximal LAD and the proximal RCA, which are the most frequent location of the coronary artery aneurysm, and posterior descending artery, it is the least common. And in LMCA, the left main rarely has a coronary aneurysm in absence of LAD or LCX aneurysm. So I have just kind of summarized from the AHA latest update. What is the patient preparation? It should be a high frequency transducer with a digital CNA recording mode. As for the sedation protocol, as the ideal age group is 1 to 5 years, we have a cranky child, irritable child. So we give a kind of sedation, pediclorin, for proper visualization of the coronary artery. In case of the left main and the left anterior descending artery, the parasternal short axis view is at the level of the aortic valve. It is the best view. We also use the long axis view of the LV. I will subsequently show few images, and the subcostal ventricular long axis. And also in case of LCX, we use parasternal short axis again, 4th chamber, and in RCA we use the short axis and the long axis views. In case of qualitative assessment, we see the thrombus, we see the regional wall motion abnormality and the functions. And quantitative, we all know, we see the Z-score normalized to the body surface area, where if it is less than 2, no involvement. Dilatation is 2 to less than 2.5. Small aneurysm is 2.5 to less than 5. Medium is 5 to 10 with the absolute dimension of less than 8. And giant aneurysm is more than 10 or more than 8 absolute dimension. In case of, one thing in case of posterior descending artery, we have to look in the posterior interventricular groove, where we sometimes miss. We also look for the LV function. As we know, the KD patients, in 20% cases, they present with dysfunction. We look for the end diastolic volume, the end systolic volume, the strain, the diastolic functions, the regurgitations, the AV valve regurgitation, few patients present with pericardial effusion, and also aortic root dilatation, where more than 10% patients come with aortic root dilatation with Z-score more than 2. Now, repeat echo. What is the indication of repeat echo? In acute phase, more frequently we repeat the echo. I'll also tell you the frequency in patients with coronary artery involvement, unless the dimension stabilizes. Or before discharge also, in those with high-risk clinical features like already discussed, less than 6 months or with Z-scores more than 2.5 at the baseline level. So this is the repeat echo guideline which I have taken from the latest update of the AHA guidelines, where if there is a Z-score, if it is less than 2, no coronary artery involvement, we'll do echo at 1 to 2 weeks, then repeat at 4 to 6 weeks. Where it is 2 to 2.5, that means only dilatation. We presume it resolves within 6 weeks to 1 year. So our frequency will be 1 to 2 weeks and 6 weeks as usual. Then we will take annually and 2 to 5 years if it is persisting. If small aneurysm is there, we'll again after we'll do weekly echo once a week till it is normal. Then at 6 weeks, 6 months and annually. Medium aneurysm will further intensify, or echocardiography will further increase the frequency up till normalization, and then 6 weeks, 3 months, 6 months, 12 months and yearly. And in case of giant aneurysm, furthermore, at 3 months after normalization or after once a week, then 6 weeks, 3 months, 9 months, and then 6 monthly. So this is how we see the 2D echo. We are first recording the cine mode. In the left hand image, it is a cine mode. Then we have freezed it and then post-processed and then taken the measurement in the right hand side. Here also, I don't know why it is not moving. Sorry, few of the videos of mine are not working. Here also, we have left hand side, we have done the cine mode and then we have stopped and then we have measured the giant aneurysm. Perivascular cuffing, I have just given the picture just to show you as to how it looks, the increased enhancement of the borders. This is the cardiac function. It is not, okay. We see the M mode and also the short axis mode, left ventricular short axis mode. See this patient is presented with dysfunction. Okay, this is the pericardial effusion, which we at times see. It is a mode of presentation. The turns and bends, this is the one of the limitation which I will discuss in detail, just a few details. Like up to the proximal turn, we can see clearly in 2D echocardiogram, but after the proximal turn, we are unable to see in 2D echocardiogram. These are the other forms of echocardiogram like the strain imaging, the stress imaging for inducible myocardial ischemia, which is the integral part of follow-up of the KD patients. It provides us risk stratifications. We also see the valvular regurgitation part. In this patient, we have mild MR, mild AR, which are the signs of inflammation. To detect the right and the left coronary system, we have used the short axis view where we have shown the dilated RCA, the left main coronary artery dilatation with aneurysm, giant aneurysm with a thrombus. Now, these are the two things. We also in 2D echocardiogram, we see the color mode also. This is a form of 2D echo. To just enhance the imaging, we can use the aqua mode or the sepia mode in the color maps. We have to check from all the angles and we have to average it out. We have to check the flows also, like the coronary flows at times we have to see. Because there other structures are there with which we can confuse, like the pericardial fold and the appendage. So very necessary, we have to see the coronary flow at times. Here also we can see giant aneurysm in RCA and in the LAD and LMCA. So this is a lookalike of the KD where we have seen the dilated coronaries in multisystem inflammatory disease associated with COVID-19. This is also a thrombosis with a giant aneurysm with a big clot inside. These are the limitations of echocardiography, which are best for the proximal segments, distal arteries, poorly visualized, very much artifacts are there of ribs and soft tissues. Full extent of proximal aneurysm are not clear. Transition to normal sized artery also not difficult to assess and may underestimate the true disease burden. And left circumflex is very difficult to assess in transthoracic because it is located posteriorly. We should look at the PIV groove also, but at times it is not visible. So we may miss aneurysm or stenosis and LCX if we do 2D echocardiogram. So in older children also there are many challenges. Here comes the role, just in short 2 slides, role of CT angiogram, advanced imaging apart from echocardiogram where we get stuck in an echocardiogram. We get help of the CT aneurysm, CT for coronary angiogram, like to assess the stenosis part. Here are the few iconic papers from PGI where we see the role of CT angiography in case of LCX aneurysm as well as in case of follow-ups and in case of giant aneurysm. Here also in this paper they have told that how echocardiography, we miss something, we miss the dilatation and all in echocardiography which are detected by the CT. And also the role of angiogram. A few patients we have to do angiogram also. This is one of our patients where there were giant aneurysms and later on this patient undergone CABG. So the key points, obtaining an echocardiogram should not delay the initiation and normal results do not exclude the KD diagnosis. Normal baseline echo results in the first week do not exclude the possibility of the later development of aneurysm. Other imaging modalities are also needed in high-risk cases for detailed coronary assessment. And at risk is right coronary artery or left anterior descending artery Z-score more than 2.5 and age less than 6 months. They are at high-risk features in multiple racial and ethnic group. And already discussed, these patients should be considered for intensification. And this is our latest update, which we follow, which has told that echocardiogram has taken upper hand in diagnosis as well as in monitoring as well as in prognostication. Thank you.
Thank you very much, Dr. Joyita, for this very nice presentation. So just to sum up that we need to see the coronaries well in a clear way, and that we have to zoom while measuring. We must put in the colors. We must never forget to put the color and check, and also decrease the Nyquist limits a lot over there. And it was a wonderful presentation. And any questions from the audience? I think we had a session just before, hands-on session. Okay. Thank you. So we'll proceed to the next session. That is Dr. Rakesh Pilania will be showing us the importance of the CT scan in Kawasaki disease. Dr. Pilania is has done quite a lot of work on this particular disease and is an associate professor from PGI Chandigarh. And he has arranged the Jian workshop for Kawasaki disease last month only in PGI. So all over to you.
Thank you, ma'am, for the introduction. And again, I'm thankful to the organizing committee to providing this opportunity. And I can see that like now that we are waiting for the lunch, but still hall is full actually. So that it suggests itself that there is a interest in this disease. And I can tell you that there is no interesting disease other than Kawasaki disease in pediatrics. So like so I have given duty to about that utility of CTCA and KD. And before starting that, I want to again re-emphasize that in echocardiography is the imaging of choice for the standard imaging of for coronary artery assessment in Kawasaki disease. And what in next 15-20 minutes we will see is that where the CTCA comes in the Kawasaki disease. So again, you may have seen this case in Prabal's slide also. And this baby who came from the Guwahati with 7-month-old boy who had diagnosed KD at around 4 weeks of illness, and echocardiography was showing giant aneurysms and with thrombosis. So what we can see in echo is that you can see the giant aneurysm with thrombosis, but you would agree with me that when we did the CTCA, you can see the extent and the size of aneurysms and that extent of aneurysms and the thrombosis which we can clearly see. So that is the difference between echo and CT coronary angiography in a one scene. So this is a CTCA provide detailed evaluation of coronary artery assessment in children with KD. So why we are worried? Because CAS may develop in 15 to 20% of patients with KD who do not get timely treatment, and precise diagnosis of CA is vital for treatment planning, because that is the life limiting, or rather I would say for long-term morbidity and mortality related issue in Kawasaki disease. So 2D echocardiography is the standard of care for imaging of coronary artery assessment, but CTCA there is a role, and it's a new imaging modality so to discuss. So again, to highlight that if we treat these patients, the less than 5% of children who receive treatment on time can still develop a coronary artery abnormality. So what we have learned from this in Kawasaki disease is that coronary artery abnormalities can be form of aneurysms, ectasia, dilatations. It can be in form of stenosis in long-term follow-up, and thrombosis, which can occur during the acute phase and also during the chronic phase. And these CAS can involve any segments of coronary artery abnormality. And what is most important is that we need to have a precise identification, because that would provide us a long-term follow, how to follow these children and planning the treatment and management in the follow-up. So echocardiography is the preferred imaging, but however, echo is not enough for delineating the extent and morphology of CAS. Like, we cannot say that what is happening in the distal segment, if there are more than 2 aneurysms in one coronary artery, so how they are behaving. So that is important. So there is no unanimity on ideal imaging modality for long-term surveillance. So echo is the standard of care during the acute phase, but
how to follow these children during the long-term follow-up, that is still evolving. So we all know that standard of care is echo, but it cannot evaluate the middle and distal segments, and it cannot evaluate mostly left circumflex coronary artery. The complications like thrombosis, you can see thrombosis, but it's always a dilemma that what is the extent of thrombosis, and sometimes because of artifacts, we sometimes misidentify the thrombosis also. And stenotic lesions, although you can see by echocardiography studies that there is a possibility of stenosis, but complete delineation of the stenosis would not be difficult, would be not easy. And it's an operator dependent thing, and in young struggling child, you know that doing an echocardiography is a significant issue. So we all know that the gold standard for coronary artery evaluation hitherto remains the coronary cath angiography, that is coronary angiography. But what is the problem is that it's an invasive and there is a significant radiation exposure, and you cannot repeat that procedure. And possibly now you would be agree that the role of catheter angiography is that when we want to intervene in these patients, so there is no surveillance catheter coronary angiography which nowadays people do, because in the late 80s when Dr. Kato has given that study, at that time we didn't had even echocardiography. So that time cath angio has shown that what these patients can have because of the coronary Kawasaki disease. Everybody want to have a MR coronary angiography, but the problem is that expertise and doing MRCA is not very easy thing, and there is a difficult issue is that temporal and spatial resolution of MRCA is comparison to CTCA is not very good, and there are long acquisition time. You cannot you need a sedation rather than more than sedation. General anesthesia is required in most of the patients for doing MRCA in young children. So it will take around 60 to 90 minutes for acquisition of the coronary angiography for a MRCA. So that is something which we do when children are more than 10 years for the better evaluation, and more it's helpful in a myocardial assessment rather than a coronary artery assessment. So there comes a role of CT coronary angiography, because CTCA is a non-invasive, relatively non-invasive in the form that you just require a cannula and contrast, and it's a procedure which will just hardly require a minute, but before that there is a lot of preparation is required. But it can explicitly demonstrate CAs along the entire course of the coronary artery, so, and even left circumflex can be seen, and also delineate the temporal changes of CA resolution, stenosis, thrombosis, mural calcification, and remodeling of aneurysm during the follow-up. So as you have seen that AHA scientific statement also say that how long to them follow these children. So the radiation exposure is always a concern in children, because we as a pediatrician want that there should not be an inadvertent radiation exposure in these children. And if you talk about the CT coronary angiography in children, 10 years back there was a different thing, because we didn't had a higher platform, higher dual source platform for radiation CT coronary angiography. So if you talk about the multi-detector CT angiography or 64 slice CT angiography, the radiation dose was significantly high. At that time the radiation dose was coming to do a CTCA was around 5 to 10 millisieverts, and we do not want children to exposed with that type of radiation exposure. But with the advent of the radiation 128 dual slice CT coronary angiography, and beyond that fourth generation CT coronary angiography platform, and there is a prospective ECG gating strategies. Now radiation exposure is less than 1 millisieverts in most of the patients. So that less than 1 millisievert is almost equivalent to the 10 X-rays. So which is not very significant radiation exposure in comparison when we are doing CT coronary angiography not very frequently. And in these patients, based on the guidelines, it requires for the giant aneurysm at baseline and then 1 to 5 years based on your assessment. So that type of radiation exposure is still acceptable, and people are further in infants the radiation exposure is around 0.2 to 0.3 millisieverts, which is hardly a radiation exposure in the children. And there is excellent correlation with measurements on echo and coronary cath angiography study. So we always want to say that what happens with the coronary artery diameters when we are measuring in the echocardiography or cath angiography based studies, whether they correlate with CT coronary angiography, and there are several studies, and one study is just compared the echo versus CTCA also, and the diameters correlate very beautifully. And it has become a potential to become the standard of care for the diagnostic evaluation of CAH in children with KD. So we at Chandigarh has seen that over the years the prevalence of coronary artery abnormalities has increased. This is possibly a multifactorial, because there is an increase ascertainment of the disease, but we are doing echocardiography nowadays very frequently in these patients during the in-house. So if you are doing echocardiography during in-house, our fellows does the echocardiography, rheumatology fellows do the echocardiography as a point of care. This is a point of care echocardiography assessment, and if you will do the echocardiography assessment, frequent echocardiography assessment, you will not miss the small coronary artery assessment abnormalities, and if there is a severe disease, possibly you have to do more frequently echocardiography, and then there is a role of dual source CT angiography. So since 2013 we are doing CT coronary angiography in these patients, and the indications are still evolving when and where we have to do CT coronary angiography, and I will come to that also. So CT coronary angiography is an imaging paradigm, and we have our radiologist, Professor Manful Singhal, who does himself as all CT coronary angiography. This is a very important, because we should not depend on the technician for a performance of CT coronary angiography. Radiologist should be there, because he would be having an expertise in dealing with the radiation exposure, and also the acquisition time, and also the image quality of the. So that's why we can do CT coronary angiography and there are several papers have emanated from our data, and I'll come to that also. So this is our paper on distal coronary artery abnormalities in Kawasaki disease, experience on CT coronary angiography in children. So what we have analyzed is that out of 1676 patients, we have tried to analyze that how many patients are having a distal coronary artery abnormalities, and whether the distal CS can happen in absence of proximal segment abnormalities. And what we have shown is that in around 10% of patients who have coronary artery abnormalities can have distal segment abnormalities in absence of proximal segments, and that is a very important concept, because we used to read the conventional literature that distal CS doesn't occur in the Kawasaki disease. But more importantly is that even if there is a proximal segment coronary artery abnormalities, the distal extent is also essential. For example, you are doing echocardiography in a proximal segment, there were coronary artery abnormalities, and those coronary artery abnormalities has resolved. We don't know what has happened in the distal segment, so we should not depend on all the decision just on echocardiography. We should do CTC, and if there is no distal coronary artery abnormalities, possibly you can just follow these patients on echocardiography. If there is a distal CSR present, possibly you have to do more frequently CTCA in these patients during the follow-up. This is again a paper which suggests that left circumflex coronary artery abnormalities are hardly picked on echocardiography, and we have seen in morning also that you can just see the origin of L6 in most of the patients. You are not able to see a distal extent or complete extent of L6 coronary artery abnormalities, and these patients will also will not be able to pick on echocardiography. We can do calcium scoring on CTC, and there is one study to suggest that those patients who are having a coronary artery abnormality, small, medium, or anyway, even if they have normalized, possibly you can do a calcium scoring after 10 years or after 5 to 10 years, just to see that whether there is some residual changes or there or not. You can use it as a follow-up, because again AHS statement has also shown that these patients should be undergoing the CTCA for the long-term follow-up, and this paper has been shown by Professor Tapas Sabui also in morning, that whenever a young MI or young acute coronary syndrome patients are coming, possibility of missed Kawasaki disease should also be considered, and that there are studies and based on the cath angiographic studies that almost 5% of young MI can be because of missed Kawasaki disease. That is based on very large studies of 500 patients and US based studies, that 5% of patients who have missed Kawasaki disease can present as a young MI. So what are the features which suggest that this is not a routine coronary artery disease, then Kawasaki disease, that proximal segment involvement, and that the aneurysm and calcification which is at the aneurysmal site only, and intervening segments are usually normal in the patients with Kawasaki disease. I'll just touch on the different guidelines on CTCA, that indications for CTCA in AHA, Japanese Circulation Society, and Italian Society of Pediatrics is almost overlapping, but they recommend the use of CTCA during follow-up when 2D becomes limiting because of poor acoustic window. Japanese Society says that recommend the use of CTCA for its improved spatial resolution and improved accuracy of stenotic lesions, while Italian Society of Pediatrics says that important to assess persistent CA in children with KD and monitor the remodeling of either coronary or systemic artery in the whole body. In acute phase, there is a significant dilemma that when to consider CTCA, because HS standpoint says that CTCA can be of value in the assessment. So this is a well-crafted sentence, and they just don't want to commit anything. And in Japanese society say that to visualize the entire course of coronary artery, but in what type of patients, they just come like writing something. And in the Italian Society Pediatrics, that CT scan should be used to confirm CA, define the size and morphology of CA. So there is a evolving literature on that. While in follow-up, there is almost a consensus that these patients should go every 2 to 5 years CTCA in follow-up, and consider in a convalescent phase at 1 year from onset and every 3 to 5 years. So we are in consensus that every 2 to 5 years or 1 to 5 years CTCA should be considered in these patients. This is a latest AHA 2024 statements, and I'll just want to highlight that in this they have said that CTCA is particularly useful at hospital discharge for giant aneurysm. So this is something which has come in a recent statement, that if there is a large aneurysms, possibly at discharge, CTCA should be done in all patients with large aneurysms. So this we have published recently in Archives of Disease Childhood, and what we have suggested that standard operating procedures for CTCA in children with KD, that how we are doing in our setup, and that how can we do, and this is a daycare procedure. So the patient will come at around 9 a.m. and he or she will go with a report at lunchtime. So within 3 hours everything is done and the reports and films are available. So, but what we have proposed that indications of CTCA in children with KD is this, that during the acute phase, we all know that it is difficult to do a echocardiography in older children for a coronary artery assessment. So in older children and adolescents who have a poor acoustic window, children with a severe disease course, like there is a KD shock syndrome, KD with macrophage activation syndrome, or symptomatic myocarditis, and KD in infant less than 6 months. We all know that in KD in infant less than 6 months, almost 50% of infants can have a coronary artery abnormality. So possibly there is a role of CTCA in a detailed evaluation, and children with CA on 2D for confirmation of 2D findings, and children with equivocal 2D findings. So these are the proposed indication. I'm sure that these are not just cannot be taken in isolation, and these things are evolving. In follow-up, to document the resolution or progression of Cs every 3 to 5 years, and to monitor the distal aneurysm, as these cannot be evaluated, and long-term monitoring for the detection of mural abnormalities and delineation of thrombosis, stenosis, and dystrophic calcification. So there is a significant role for assessment or follow-up of the patients using the CT coronary angiography in a Kawasaki disease. To summarize, it's a non-invasive and daycare procedure, often without sedation, because in children beyond 5 years, there is hardly any requirement of sedation, and it's a 1-minute procedure. You just have to teach the children whether that they have to lie down for 1 minute, and then everything is completed. It's a superior imaging of entire coronary arteries, including distal segment and LCX. It can detect mural abnormalities, thrombosis, stenosis, and calcifications. And there is a lower radiation with new generation CT scanner. So almost a sub-millisieverts exposure, and it can be useful in acute, convalescent, and long-term monitoring, and it's increasingly become the preferred imaging modality for detailed coronary artery assessment in Kawasaki disease, and it reduces the need for invasive catheter angiography, because that is an important aspect. If there is no need for an intervention, possibly you just do CTCA, and depending on that, if there is a requirement of intervention, then only you go for a catheter angiography. Thank you.
Thank you so much for this fantastic speech. And I must mention here that the papers and the work done in PGI on KD, and particularly on this aspect of CT angio, has given a phenomenal work in global platform. And thank you for that. And so anyone, any questions from the audience? Okay, so I think we'll wrap up for the next session.
The heart rate being so high, we often have to put them on some kind of beta blocker to get it down to a level where it can be, the coronaries can be meaningfully assessed by the radiologist. Previously, we used to have a 128 slice CT machine where it used to be absolutely routine direction or request, whatever you say, from the radiologist to get the heart rate down. What's your comment on that?
So you have touched a very important point in a heart rate monitoring, heart rate control in doing CT coronary angiography. So we have published on this aspect also in this. So in children, the heart rate, high heart rate doesn't kill the CTCA imaging. It is a variability which kills the CTCA examination. So what we do is that we give a beta blocker almost a half an hour or 1 hour prior, and that decreases the variability in, even at 120 heart rates, we are doing CTCA, but the variability should not be what do I mean by variability is that if there is heart, because in children you can see that it can variable between 80 to 120 or 140. If within a 10 seconds, if it is variable, it is variably doing variability between 80 to 120, that would be a problem rather than a high heart rate. So what we do is that we give a metoprolol in these patients, and that decrease the variability. It will variable within plus minus 10 only, and that is a very important thing. So in our radiologist, Dr. Manful Singhal always tell that he's not concerned with the high heart rate. He's just concerned that it should not be variably, like it should not be very variable. So that is a very important. So possibly with the higher 128 and 256 dual source CT scanner, heart rate should not be, high heart rate should not be an issue.
Thank you.
Yeah. Yes, sir.
You said that 5% of the missed Kawasaki disease will end up in myocardial infarction. So it's just my concern, and I was discussing with you just so do you think there can be ethnic variability? Means these are all US data. So in our country, is there any study or something long-term study, or is there any ethnic variability? Because 5% is quite high. If you see the 5% will go to myocardial infarction, that's quite high. Just your point of view.
So what I was highlighting is that the people have analyzed the coronary catheter angiography of the young MI patients. So those who had young MI, so this is a study by John Gordon from the US, and what they have analyzed is that around 500 patients who had a young MI, out of those 500, 5% were because of missed KD. Not because that 5% of all children with KD will be having a MI because of that. It's a study based on young MI where they postulate because of, based on the CT coronary angiography findings, the 5% had possibly because of the missed KD, not because of the coronary artery disease which we conventionally see. Yes, there would be ethnic differences, and we don't have a very these studies. Possibly one has to analyze all the cath angio or CT coronary angiography data from the adult MI, and possibly that will give. This is just a 4 case based series which we have published in IGRD, first time based on the CT coronary angiography. All data is based on a cath coronary angiography, because nowadays you all will be agree with me, and cardiologists would be agree that, and the first imaging for acute MI in adults is nowadays CT. And the recent non-ionic contrast dyes has not having any significant renal complications. And what we have done is that around 350 patients with CTCA till now, and we didn't have any complications in any of the patients with those who have had coronary CT coronary angiography, and we have used non-ionic contrast in these patients, and we are using this non-ionic contrast in several other indications also. And one important thing is that CT coronary angiography in Kawasaki disease is not an urgent thing during acute phase. We are not doing during the acute phase, and most of the CT coronary angiography should be done once the child is stabilized. And once children are stabilized, they are not having any critical issues. Possibly at that time, these contrast related issues are not very much a concern. Yeah, definitely when there is a child is sick, if there is already a issue of the hemodynamic instability, if there is already a renal issues, then possibly these issues would be more, and you would be agree with me that this non-ionic contrast we'll be using for several other indications also, and we are not seeing many problems with these things.
Thank you. Thank you so much.
Thank you.
Moving on to the next discussion, I would call upon the stage Dr. Amitava Pahadi, Dr. Prabal Barman, and Dr. Madhumita Nandi to judge the award paper presentation on original research by the PGTs.
I think if you permit, we prefer actually sitting on this side so that we can actually have a
Let me tell the rules. A total of 5 minutes will be given for the presentation. First bell will be at the 4 minute of presentation. Final bell will be at 5 minutes, followed by 2 minutes of discussion by the judges. Our first presenter is Dr. Riya Ghosh, Kawasaki disease in infants.
Yeah, just welcome everyone to this very important session of paper presentation. I think it's very important to do a proper time management, and you can start your presentation, Riya.
Good morning, everyone. I am Dr. Riya Ghosh, junior resident from IPGMR SSKM Kolkata, and today I will be presenting our study titled Kawasaki disease in infants. We all know that Kawasaki disease is an acute febrile illness predominantly affecting children under 5 years of age with predilection for the coronary arteries. KD in infants mostly present in incomplete or atypical form, leading to delays in diagnosis and coronary artery aneurysms. There is lack of data on the clinical profile of infants diagnosed with KD, especially from India. Hence, the objective of this study was to analyze the clinical profile of infants diagnosed with KD and compare these findings with older patients diagnosed with KD. It is a prospective observational study conducted in our hospital for a duration of 13 months. All children aged 30 days to 12 years fulfilling the AHA criteria for KD were included. 19 KD patients were diagnosed during the study duration, out of which 52.6% were infants. Of these, 40% were under 6 months of age. Demographically, median age of onset for infants was 7 months, with male is to female ratio being 7:3. On comparing the clinical profile, we found a longer median fever duration in infants compared to older population, with the difference reaching statistical significance. 80% of the infants presented with irritability, followed by edema of hands or feet, while cervical lymphadenopathy was rare. On analyzing the lab values, we found a high degree of anemia for age at presentation, CRP and ESR levels in infants compared to the older population. Again, the p-value reached statistical significance for these. On presentation, 80% of the infants presented with incomplete KD, while most of the complete KD was in the older population. There was also a significant delay to diagnosis in infant group with a median of 10.5 days versus 7 in the older population. Again, this was highly statistically significant. On comparing the echo findings, we find that coronary artery aneurysm presented with almost equal frequency in both the study groups. However, giant coronary aneurysms were more in the infantile group. The left main coronary artery seems to be most commonly involved in the infant category, while a left anterior descending artery was more commonly involved in the older cohort. This is a table showing and comparing the treatment profile and response between infantile KD with the older children. All the children in our study cohort received IVIG transfusion according to standard protocol, but there was a higher degree of IVIG resistance in the infant category. Escalation of treatment with infliximab, steroid, and or cyclosporin was also higher in the infant category, with the use of LMWH also being higher in this group. This is the summary of clinical profile of infants diagnosed with KD under 6 months of age in our study. All of them were males with almost incomplete KD in all, with a longer median delay to diagnosis than rest of the cohort. 75% of them had coronary artery aneurysm at presentation, with more than 50% being giant in nature. Almost 1/4 of them developed IVIG resistance, and more escalated therapy was used in this population. Use of low molecular weight heparin was also more in this cohort, probably due to the high incidence of giant coronary aneurysm. Our study also had limitation, and this was small sample size, short study duration, referral bias, and being a single center study. In conclusion, KD in infants presents as a diagnostic challenge for us clinicians, as majority presents in incomplete form with higher fever duration causing diagnostic delay. Most common symptoms, irritability and pedal edema, while cervical lymphadenopathy was rare. Infants with KD have more anemia for age with higher levels of inflammatory markers, and risk of development of giant CAA and IVIG resistance is also more in this cohort, especially in less than 6 months of age. This is the comparative table showing the comparison between our study and rest of the studies done internationally worldwide. As we can see, most of the studies are retrospective. Ours is a prospective study. While there is a comparable frequency in incomplete KD between the Indian study done by Singh et al. And our study, and also the incidence of coronary aneurysms in our study is comparable to the Italian and Mexican cohort. Thank you.
Yeah, very nicely presented.
Thank you.
Just one or two issues. Just I need that information. You two are in a government medical college and you have used infliximab.
Right.
So did you get infliximab from government supply or from where did you procure it?
Yes, ma'am. I am from IPGMER, so
Yes,
we have a free supply of infliximab in our institution that is given by the government.
But we don't get it. And number two, what is the median duration of follow-up in your series?
Ma'am, median duration of follow-up is around 6 months in our study.
Yes. And did you get any gender predilection for, outcome-wise?
Outcome-wise, ma'am, all of them are doing well right now.
Gender, male, female wise, any difference in?
No, ma'am, I have not.
Thank you.
Thank you.
Thank you for your presentation. Just a couple of questions. Some of your patients, you decided to give infliximab, some received steroids, some received cyclosporine. So what was the rationale behind different modalities?
So,
like you mentioned that all of these drugs are available for free. So what was the rationale behind using different regimes?
In some of the patients, we did not get coronary artery aneurysm, so we followed the standard protocol. Before the AHA guidelines were there, we gave IVIG and intensified the therapy to infliximab because that was available to us, and our departmental protocol was not to give steroids. But after the AHA guidelines happened, we intensified therapy. Giant coronary aneurysms got all the 4.
Okay.
IVIG, steroid, cyclosporin, and infliximab. They got all 4.
Okay. Thank you.
Thank you. One quick question. This is a prospective observational study. Do you have a specific number in your mind when you designed the study, and was there any exclusion criteria? And last but not the least, if you tell us about the dose of infliximab that you have used for your patients.
So, no, there was actually no defined set of that these many patients we need to include in our study. We just followed up all the patients that came to us during the whole study duration because we were getting a high cases of infants with KD. So we started keeping those numbers. Sorry, the next question. What did you ask?
Is there any exclusion criteria that are used?
Yeah, the common diseases that need to be excluded, which are KD mimickers, they had to be kept in the exclusion criteria. And
was it exclusion criteria in your study?
Yeah.
Or, yeah?
Yeah.
You didn't mention it. Anyway,
Sorry.
and what was the dose of infliximab that you used?
So, as I mentioned, before the AHA 2024 guidelines came, we gave infliximab of 5 milligram per kg, but only one patient of giant coronary aneurysm received that. After the AHA guidelines came, in the recent guidelines came, we gave 10 milligram per kg per dose.
So, some of your patients on infliximab had 5 and some of them had 10. Okay.
Yeah.
Okay. Thank you.
Thanks.
Our next presenter is Dr. Shiny Pan on cardiovascular complication in Kawasaki disease and assessment of risk factors for development of coronary artery aneurysm.
Good afternoon, my respected judges. I am Dr. Shiny Pan from Bardon Medical College and Hospital, and today I will be presenting on cardiovascular complications in Kawasaki disease and assessment of risk factors for development of coronary artery aneurysms. As we know, Kawasaki disease is an acute self-limiting medium vessel vasculitis, which is now increasingly being recognized as the leading cause of acute heart disease in Indian children. Coronary artery aneurysm, or CAA, which can develop in 15 to 25% of untreated children, remains the most treated complication of KD. So predicting the risk of CAA can help in early detection and aggressive management. Our aims were to study the spectrum of cardiovascular complications in patients with Kawasaki disease and to assess the associated risk factors for developing coronary artery aneurysms in the patients under study. Ours was a prospective hospital-based observational analytical study that we conducted from July 23 to December 24, and the sample size was 52 patients. We included children aged between 1 month to 12 years of age, meeting the criteria for complete or incomplete Kawasaki disease according to the American Heart Association 2017 guidelines. For our study, once the diagnosis was confirmed, two-dimensional echocardiography was performed at diagnosis and at 2nd and 6th week of the disease and repeated as necessary depending on the coronary artery involvement. All the patients were followed up for 6 months as of now. Univariate and multivariate analysis were done for assessment of risk factors, and IBM spaces was in 26 and STATA was used for statistical analysis. The p-value of less than 0.05 was considered as statistically significant. Coming to the results, we found that most of our study population were below 4 years of age, and 54% of them were male and 46% were female. We found a spectrum of cardiac abnormalities in our study population, of which myocarditis was most common, observed in 46.15% of the patients. Next in line was coronary artery abnormalities, which are found in 36.54% of the patients. Other abnormalities included cardiogenic shock with reduced left ventricular ejection fraction, aortic root dilatation, valvular disease like mitral regurgitation, pericarditis, or pericardial effusion. This bar diagram shows the maximum Z-score of coronary arteries on serial echocardiography, and according to the American Heart Association 2017 guidelines, we found that 28 of our children had no involvement of the coronaries, 5 had dilation only, 14 had small aneurysms, 4 had medium aneurysms, and 1 had large or giant aneurysm. Coming to the risk factor assessment for development of coronary artery abnormalities, so first we did univariate analysis including all the variables that we considered, and of them we found 7 variables to be statistically significant, which was duration of fever more equal to 10 days, IVIG resistance, thrombocytopenia, hematocrit of less than 35%, Alanine transaminase of more equal to 100 units per liter, hyperalbuminemia, and raised NT-proBNP of more equal to 1000 picogram per ml. So with those variables that came significant in the univariate analysis, we performed multivariate analysis or binary logistic regression with them. And in this analysis, we found two variables to be significant risk factors, and those were IVIG resistance and raised NT-proBNP. These slides summarize the results that I just mentioned. Coming to the discussion part, so we did a review of literature and we found that most of the studies are done in some of the developed nations of the world, namely Japan, China, USA, or Canada. And their studies corroborate partially with our studies because, as we know, that these risk scores that are formed in Japan and USA, like the Kobayashi score, Igami or Sanu score, or recently the SON score, they cannot be totally validated on Indian population. So in conclusion, cardiovascular complications are the predominant cause of morbidity and mortality in Kawasaki disease. Although several Japanese risk coding systems are available for prediction of coronary artery abnormalities in Kawasaki disease, none of them are validated in Indian population. In the present study, we have identified the risk factors for development of coronary artery aneurysms in our cohort, and this risk stratification will hopefully help to assess the probability of coronary artery aneurysms early in the course of the disease and take appropriate measures to minimize the sequelae. Further studies on these parameters with larger number of patients might help devise an Indian risk coding system for coronary artery aneurysms. Thank you.
Thank you, Shayani. Very well presented.
Thank you.
Just one or two issues. You have got an array of cardiovascular abnormalities, not only coronary artery abnormalities, but other things also.
Yes, ma'am.
Have you tried to compare the incidence of cardiovascular abnormalities with other published studies, either from India or you've tried to compare the risk factors,
yes,
but have you tried to compare the incidence?
Yes, ma'am, we did.
Does it tally with your incidence tally with the
Yes, ma'am. In most of the other studies also, the incidence of myocarditis was most common. And the rest of the findings that we found, like the valvular abnormalities, they were, or the cardiogenic shock or pericardial effusion, they were found in a small percentage. And there was some other cardiovascular abnormalities also in the other studies that we didn't find in our study.
Thank you.
Thank you, Shani. Just wanted to know, did you stratify your patients based on the cardiovascular manifestations and the treatment that you would give? For example, what sort of management would a patient with myocarditis receive? Someone with poor ejection fraction, was it the same, was it different?
Actually, sir, our findings overlap. The cardiovascular manifestations overlap. Like the 19 patients that we found coronary artery aneurysms, initially they presented with myocarditis. So our management was just like we did in aneurysm only in that case. And sometimes like the myocarditis was found with pericarditis also. In that case, we managed with that particular problem, but most of the cases overlapped with each other. Like there were total 27 patients who had cardiac abnormalities, of them 19 had coronary artery aneurysms. So maximum management was done according to the aneurysm only and others.
Thank you, Saini. One of the analysis that you showed in univariate analysis and your multivariate analysis are actually found to be a little bit different.
Yes.
Can you explain that?
Sir, for univariate analysis, we considered variables that we found in different literatures which came to be significant in those literatures, and there were total, I think, 15 variables that we considered for univariate analysis. For multivariate analysis, we only considered the 7 variables that came significant in the univariate analysis. So that
and out of that, you found only 2?
Only 2, yes.
IVIG resistance and hypoalbuminemia.
NT-proBNP, high-raised NT-proBNP.
And proBNP. Okay.
Yes, sir.
Okay, thank you.
Thank you, sir.
I would like to call upon stage Dr. Anandita Nandi to have a talk on treat to target in Kawasaki. Is initial intensive polytherapy making a difference in outcome in terms of coronary artery aneurysm?
Good afternoon all. So there is no doubt that treatment intensification is an important step to prevent coronary artery sequelae in Kawasaki disease. So today I am, on behalf of my department, going to share our experience over the last few years. So my presentation is treat to target in Kawasaki is initial intensive polytherapy making a difference in outcome in terms of coronary artery aneurysm. So we all know that Kawasaki disease now is the common cause of, leading cause of acquired heart disease in children, and coronary artery aneurysm is the most dreaded complication. A large aneurysm may develop thrombosis and stenosis as well. So treatment intervention is very pivotal to prevent poor outcome. So our aim or target was to manage KD patients with medium aneurysm and giant aneurysms with treatment intensification to prevent progression of coronary artery aneurysm and to note the outcome through 6-month follow-up. It's a retrospective observational study conducted from January 2020 to July 2024, almost 4.5 years, on Kawasaki disease patient who received additional immunosuppressant for therapy intensification. And serial follow-up echocardiography findings were recorded and Excel sheet were analyzed. So total number of patients included were 18. Among that 14 had medium, that is 77.7% patient had medium aneurysms, and 4, that is 22%, has giant aneurysms. And number of patients with multiple aneurysm was 8, that is 50%. So total number of aneurysms were 20, among which 22 were medium and 8 were giant. Median age at diagnosis of aneurysm was 11.5 months with a range of 2 months to 12.5 months. All patients received IVIG and low-dose aspirin at diagnosis of KD. There is some format problem. It is not coming in the box. Previous slides. So this is the next, yes. So treatment intensification showing patient with medium aneurysm. The total number of patients were 14. Can I take 1 minute time they are asking for? There is some format problem. Yes, keep this slide now. Yeah, sorry for. So among these 14 patients with medium aneurysm, only infliximab was given in 8 patients, that is 57% patient. 4 patients were treated with infliximab and cyclosporine, and 1 patient with all 3, infliximab, steroid and cyclosporine, and only steroid were given in 1 patient only. In the giant aneurysm group, the number of patients was 4, and 2 of them were treated with all 3, infliximab, steroid and cyclosporine. Only infliximab was given in 1 patient, and infliximab cyclosporine combination was given in 1 patient. Additional therapy, low molecular weight heparin, was given in 8 patients in the medium aneurysm group and the 4 patients, all 4 in the giant aneurysm group. And among these 8 patients, 6 were given low molecular weight heparin for increasing size, 1 for development of thrombus and 1 for development of new aneurysms. Double antiplatelet therapy with addition of the clopidogrel was given in 3 patients in medium group and all 4 in the giant group. Statin was used in 1 patient in the medium group for persistence of aneurysm. And beta blocker was given in 2 patients in the giant aneurysm group. So outcome of our aneurysms, total number of aneurysm in our cohort was 30. Among the 22 medium aneurysms, 17, that is 77%, became less than 5 Z-score and 3-month follow-up. And 5 remained to be medium at 3 months. Among these 5, 3 became less than 5 Z at 6 months, and 2 remained to be medium at 6-month follow-up. These 2 patients we analyzed show that both have LAD aneurysm who received infliximab only. Among the giant group, 1 patient remained giant at 3 months, that became medium at 6 months, and 5 patients remained medium who became normal at 6 months, and 2 normal at 3-month follow-up. Outcome of thrombus, only one disappear by 1 month, another by 2 months follow-up. So limitation, definitely our single center study with small sample size, and CTCA confirmation we could be done only in 2 patients. So in conclusion, treat to target strategy can be applied successfully in treating KD patient to improve outcome. Thank you.
Thank you, Anindita. A good study.
Thank you.
Again, the same thing. Have you tried to compare your outcome with other published?
Yes, ma'am. I tried,
things?
but as it is the intensification for KD, so all centers are using different intensification strategies. So exactly matching with this cohort was not available.
Thank you.
Thank you for your presentation. I just wanted to know, for your patients with medium CA, did all of them receive the same regime as compared to, say, the ones with giant aneurysm?
No, sir.
I mean, different patients with the same
Yes.
aneurysm receive different sort of
Yes, depending
regimes.
on the high risk factor is there or not,
Okay.
age of the patient, considering the age, male, sex. So we intensified depending on the patient only. It is not that we fix one regime for each patient.
So when you say treat to target, what exactly are your targets?
Our target was to prevent the progression of aneurysm.
Okay.
And see the outcome in 3 and 6 months, how we are able to treat, hit the target.
Just an observation.
Yes.
2 giant aneurysm patients you have given beta blocker. Was there actually preemptive treatment or they developed some symptoms?
In giant aneurysm 2, I have given beta blocker. That was persisting. The giant aneurysm was persistent to be more than 5. Even it was one patient, it was 8, and one patient, it was 8.5 on follow-up. So in those patients, they were 2 years plus also. So we started statin in these patients.
No, I'm talking here about beta blockers.
Oh, yes, sir. Beta blocker, what was the question, sir?
In 2 patients of giant aneurysm, actually was discharged on beta blockers.
Beta blocker.
Was it just a preemptive treatment to prevent any cardiovascular complications,
sir.
or
Yes,
they
sir.
developed anything?
Yes, sir.
Is there any guideline about that?
One patient had thrombus with giant aneurysm.
I'm talking here about beta blockers.
As I remember, sir, can I go back to the slide? Yes, these 2 patients of giant aneurysm, we are thinking why you have given beta blocker. In these 2 patients, there was, I remember, there was some tachycardia persisting. And ECG changes was not there, but some resting tachycardia was persisting in these 2 patients.
What beta blocker you used?
Yes, sir.
What beta blocker you used? What beta blocker you used? Which one?
We gave propranolol in 1 patient, 2 patients.
Okay, thank you.
Thank you, sir.
Our next presenter is Dr. Oishik Mukherjee, who will have a talk on low-dose aspirin at treatment initiation in Kawasaki disease, a study from a tertiary care center.
Good afternoon, everyone. Today, I will like myself, Dr. Oishik Mukherjee. Today, I will like to shed some light on the use of low-dose aspirin from treatment initiation in Kawasaki disease. Now, as we know, Kawasaki disease is a systemic vasculitis with a predilection for the coronary arteries. The cornerstone of the therapy is intravenous immunoglobulin and aspirin. Although the dosage of IVIG is standardized as 2 grams per kg, but there is significant discrepancy regarding the dosage of aspirin. Usually, the standard norm is that begin with a moderate to high dose aspirin that is greater than 30 mg per kg per day, citing that it has anti-inflammatory action, and thereafter reducing it to a low dose aspirin 48 hours after the fever resolves. The low dose aspirin, as I told, was 5 mg per kg per day and continuing it till any echo abnormality resolves. Now, what does the world say? In US, they usually follow high dose, that is 80 to 100 mg per kg, or moderate dose, whereas Japan and Western Europe follows a moderate dosing. In a contrast, the Royal Children's Hospital, Melbourne, uses 5 mg per kg per day from the very beginning. Now, why are we so worried about the high dose or moderate dose aspirin? Because it has significant side effects like gastrointestinal bleeding, perforation, hepatopathy, etc. Now, as we all know that the initial bolus dose of IVIG has the main anti-inflammatory action, thus we want to see whether this moderate or high dose aspirin contribute to any of the significant anti-inflammatory effect or just add to the side effects. Now, in Institute of Child Health, we use 5 mg per kg per day of aspirin from the very beginning. So, what we aim to study in this that reduction in the inflammatory markers, 48 hours post-IVIG transfusion, and the duration of fever defervescence in patients who receive only low-dose aspirin, that is 3 to 5 mg per kg, along with IVIG. Now, this is an observational cross-sectional study. We have included the patients who have been diagnosed as Kawasaki disease as per American Heart Association 2017 guidelines. The study period is between January 2019 to December of 2024. And the most important criteria included only patients, those who received low-dose aspirin along with IVIG. Anything apart from this, like infliximab or steroids, those patients has been excluded. So coming to the results, in the 5 years, we have received 166 patients. Out of that, 14 patients' data were missing, 72 were excluded because they received either infliximab or steroids or both. So that boils down around 80 patients. Now, coming to the results in defervescence of fever, we have subclassified them into less than 36 hours and more than 36 hours. As per the guidelines, in fever defervescence, greater than 36 hours is labeled as IVIG resistance. So coming to our data, 70 patients out of 80 patients, that is 87.5% of the patients, became afebrile within 36 hours. What does the global data say? The global data hovers between 80 to 90%. And I must mention, this global data is of patients who received moderate to high-dose aspirin. Coming to the IVIG resistance, out of 80 patients, only 10 patients did not respond to IVIG, that is 12.5%. And what is the incidence of IVIG globally? It's 10 to 20%. So this also corroborates with the global data. Coming to the reduction in inflammatory markers, 10%, that is 80 of the 80 patients, have dip in their inflammatory markers, although the dip varied across IVIG responders versus the IVIG non-responders. What does the global data say? It's greater than 90%. So this also goes along the track. Now, what does he conclude from here? That the dose of initial aspirin has minimal effect in lowering the inflammation in Kawasaki disease. The incidence of fever defervescence and lowering of CRP in our low aspirin group corresponded to the data globally in which higher dose aspirin was conventionally used. Thus, high or moderate dose aspirin has no additional beneficial anti-inflammatory action in Kawasaki treatment. Obviously, this study has some drawbacks like small sample size from a single center without any control group, and most importantly, we did not compare the incidence of coronary artery aneurysm formation in our cohort with data from moderate or high dose aspirin groups. So as I was citing multiple global data, these are some of the references, but I could not include all of them because of the shortage of space. Thank you.
Thank you, Oishik. Nicely presented. Just
Thank
one
you.
or two
Thank you,
things. Was it a retrospective or prospective study?
It's ambispractive because I have been included in the institution from 2023. So I have collected those retrospective data
so what
from
was the criteria for inclusion in this low-dose limb or low-dose aspirin limb? And which patients did you choose to
Now
include
it's become a norm that we have been using 5 mg per kg for the last 2 to 3 years. But before that, some of the units were deferred and have given 30 mg. So I have excluded those patients out.
And have you tried to compare with, did you have any control with the high dose, control limb?
No, I just compared it with the global data that is available from the moderate or the high dose.
Your own data, you had 166 patients, out of them some were excluded, and 80 you included, and rest of them probably received standard dose aspirin, in the initial period. So did you compare the outcome between the two groups?
Actually, ma'am, those patients which were excluded, 72, majority of them were given steroids or either infliximab. So they were not excluded on the basis of high or moderate dose of aspirin because majority of the patients in our institution received low dose.
Okay. Thank you.
Thank you for your presentation. So what I understand is you've excluded all patients who had some form of coronary involvement. Is that it?
No. Who received either steroids or infliximab as a part of intensification therapy. So I have removed those patients.
Okay.
Because it might have a confounding effect on the use of aspirin also. So I just want to keep it as simple that IVIG, high dose aspirin or moderate dose aspirin versus IVIG plus low dose aspirin.
I think what ma'am has suggested, probably you can do an ad hoc analysis also, the patients who have received a lower dose vis-a-vis some higher dose.
Okay,
that
sir.
would be important because the latest AHA guidelines still mention that only, that we
Yes,
have to
yes,
use
yes,
a
yes.
higher dose.
Yes, ma'am.
But
Yes.
as far as I think most institutes across India actually use a lower dose. So this would be, I think, a good study to do.
And sir, I want to mention one thing also, that another studies are going on the basis of this incidence of coronary aneurysm and their follow-up. But as we are follow-upping them on monthly 2 to 3 weeks, then after 6 to 8 weeks, then on 1 year, that analysis is not complete. So we will also incorporate that incidence and the progression of coronary arteryism in this data also.
Thank you. I think your study, when it's actually going to be over, will be actually possibly changing the practice of pediatricians, that we are actually still under a bit of influence of higher dose of 30 to 50.
Yes, sir.
I think if the lower dose, the way you are actually saying, it's actually in a long-term follow-up in the coronary artery aneurysm is also going to be similar, then hopefully
Yes, sir.
it will be also changing our practice. Thank you.
Okay,
It's
sir.
a very
Thank
nice
you.
study.
Thank you, thank you, thank you, sir.
Now, I would request everyone to have the lunch and be there by 2:30 p.m. for the next session.
You may not request, people will run for the lunch. Hello. Since we are actually running quite late, I would request everyone who are going for lunch to actually rush back after your lunch. So because we start at 2:30.
We are requesting all the delegates and audience, faculty, please come inside. Hello. So, it is our honor to organize first CME of ISKD, Indian Society of Kawasaki Disease. You know it is another society. Pediatric Rheumatology Society and ISKD is another society. And this is the first time we are honored to organize a CME of, one-day CME of ISKD also. And all credit goes to Priyankar and others and for their leadership. So now, today, we are next topic of discussion is thrombus in KD. The complication of KD. KD is no more infant, so it is already grown up. So we are discussing the complication of KD, and Dr. Priyankar Pal, you all know, one of the pioneer in propagating pediatric rheumatology in Eastern India, and everybody knows him. So he will moderate, and panelists will be Dr. Anil Kumar Singhi, Dr. Archon Sil, and Dr. Devasri Gangopadhyay. Dr. Priyankar, please.
So, you have all been through the different presentations of Kawasaki disease. You have seen the different manifestations from a febrile to a afebrile KD. And now we come to the most dreaded complication of Kawasaki disease, which is a KD presenting with a thrombus. And we have, as panelists, I think this becomes actually a domain of the cardiologists. So we have two celebrated cardiologists with us, pediatric cardiologist, Dr. Anil Singhi. Anil is a pediatric cardiologist in Medica Hospital. Medica has been renamed as Manipal EM bypass. And Devostri Ganguly. Devostri is basically a pediatrician who is now a pediatric cardiologist. She is a consultant pediatric cardiologist in RNT. So that is RN Tagore, Narayana Health, RN Tagore Hospital. And Orchon is the sole rheumatologist, the pediatric rheumatologist, sandwiched between the two cardiologists. So I've kept his name a little apart also. Can we request everyone to come in? So, Madhumitadi, please request everyone to come in. So let us have a look at the incidence of Kawasaki and thrombosis. So this is a very interesting paper which came out in 2023 from, I think, one of the Asian countries. So they had a look at their incidence, and this found that the cumulative incidence of coronary thrombosis in KD patients with giant coronary artery aneurysms was 59%. So the most important is a giant aneurysm, and that results in thrombus. So coronary thrombosis mainly occurred in the acute phase, the median time of 16 days after onset, and the bad prognostic factors were male sex, left LAD involvement, and the coronary artery absolute diameter more than 8 millimeter, so which is a giant aneurysm. So with this background, let us start having a look at this baby. So we happen to treat this baby in the month of November of 2024. So this is a 9-month-old male baby admitted with a fever of 11 days. So on admission, you see that the count is high. The total neutrophil count the total leukocyte count is 15,800 with a platelet of 9.5 lakhs and a CRP of more than 100. And the echo shows a giant aneurysm in the left main coronary artery and a thrombus, 4.6 into 3.5 millimeter thrombus at LMCA bifurcation at the LCX origin. And we treated the patient with IVIG, infliximab, aspirin, oral cyclosporin. So for the first question goes to Orchon. So of course, this is still in the domain of the rheumatologists. So would you like to say anything about the combination therapy that was initially given?
Yes, so this is an infant. So infant behaves in a little different way from the other patients with KD. Infant and older children, they are high-risk groups. And specifically in AHA 2024 guideline, it has been mentioned age less than 6 months and coronary artery Z score of more than 2.5 as two of the most important risk factors. So here in this infant, 9-month-old baby presented with fever for 11 days with high inflammatory parameters, and as expected, one giant aneurysm and 2 medium aneurysm with a thrombus. So primary intensification, so if this coronary artery involvement detected at diagnosis, so primary intensification, we tend to give infliximab even before the first dose of IVIG, because it has been seen if infliximab is given before the first dose of IVIG, the chances of reactions, anaphylactic reactions are less. So it was intensification, infliximab was given along with IVIG and oral cyclosporin. So cyclosporin in the recent guideline, it has been mentioned to give for 10 days. And one of the other things, important thing is that dual antiplatelet therapy has been recommended in cases of medium and large aneurysms, along with anticoagulants for large aneurysms. So we generally prefer to give low molecular heparin to start with, and then depending on the echocardiography.
We will come to
status.
anticoagulation later on.
Yes, yes.
So we started off with a battery of therapies. Anil, would you like to comment? Because he was unhappy with what we had done.
No, thank you. I think you are the giant of KD in the city. Very, very interesting case. One point I just wish to add on, there are two parts of the therapy. One is anti-inflammatory therapy and another is antiplatelet. So aspirin at a 5 milligram dose should be kept away from the stage 1 therapy. Aspirin, clopidogrel and heparin. So they will form limb A, limb B. 3 drug anti-inflammatory and that will treat the inflammation component. 5 milligram aspirin is purely an antiplatelet therapy with possibly no anti-inflammatory action. So that along with clopidogrel will form part of that dual antiplatelet. Regarding antithrombosis, yes, again we can come and
we'll discuss that. So these were the echoes. You can see that there's a large thrombus sitting in the LMCA. The first picture, I think that's very well visualized, and there's a video also over here which shows LMCA with thrombus. So now that you have a thrombus, how would you like to manage the thrombus? So, Debashree?
So, as if a giant coronary aneurysm and multiple coronary aneurysms were not sufficient to add salt to the wound, we have now thrombus. So now it should be managed like an emergency, and as the treating clinician, one should be very cautious about monitoring the thrombus regularly so that a partially occluding thrombus does not become a completely occluding thrombus. So to achieve that target, we should try and start heparin as soon as possible. You had started low molecular weight heparin. The other practice could be unfractionated heparin. And on top of it, already the child has received aspirin. We should be adding clopidogrel as well.
Clopidogrel.
And with daily monitoring of echo, needless to say, maybe twice a day monitoring of ECG to see any ECG changes which could probably indicate underlying coronary ischemia.
Yes.
That's a very, very interesting point you have added on. If there is a thrombus and patient is inpatient, going by this criteria, possibly unfractionated or regular heparin will be better off to start with, and low molecular weight can be given as when you are discharging the patient, because the faster onset of action, better monitoring, we have APTT continuously, so those parameters, and it's very nephro-friendly. So this kind of regular heparin in the initial phase, then you can switch over. You can give continuous infusion. You can titrate 15-20 milligram per kg per hour, and that will help immensely to dissolve the thrombus. And once thrombus is there, at that time itself, the cardiac team should be in, so that if it progresses, we can possibly take step faster.
Definitely. So yes, what the cardiologist says, it makes definite sense, because if you are giving IV heparin, you can monitor. The problem with the low molecular weight heparin is monitoring. So Archon, will you say anything? How do you monitor low molecular weight heparin therapy?
Yes, low molecular heparin mainly antagonizes the effect of activated factor 10. So anti-factor 10A we can monitor, and the reference range that we follow is from 0.5 to 1 unit per ml. So anti-factor 10A generally will do to monitor the therapeutic effect of low molecular weight heparin.
But unfortunately, as far as my knowledge goes, none of the centers, almost none of the centers in Calcutta does anti-factor 10A.
So that is
the
problem.
What the cardiologist says actually makes sense, because the other thing that APTT can be monitored everywhere. So clopidogrel, would you like to add a clopidogrel?
Yes, for medium-size aneurysm onwards, we can add clopidogrel along with aspirin. So dual antiplatelet coverage is required.
Definitely. And over here, you have a giant aneurysm and 2 medium aneurysms. So 3 aneurysms in an infant. Day 3 of admission. So echo was done in this baby regularly. So regular echo was done. So we had the advantage of, because Devdatta was doing the echo actually. So this patient was admitted in a tertiary center, and we had the advantage of getting an echo done regularly. So day 3, and now you have another thrombus, LAD thrombus. So there was a LMCA thrombus, and a second thrombus has come up. So in spite of anticoagulation, in spite of so much of therapy, still the thrombus develop. So what can be the possible reason? Anil, yes?
Again, you are asking all difficult but all very relevant questions. The most common cause of developing thrombus is actually ongoing significant inflammation. So if a new thrombus develops in spite of giving adequate the heparin and anticoagulation, that means the inflammation possibly is not well controlled. So we need to hike up and work on that ground. Secondly, the dose of the anticoagulation may not be adequate. We have not touched. So these 2 points are more common. Then it's extremely rare if we are giving good anticoagulation and giving control therapy for the inflammation, a new thrombus will come. It may take time to resolve, but new thrombus or we possibly had not demonstrated the next thrombus because the child is crying. Frequently the KD problem, we are focused on the coronary, we are seeing crying child and we are unable to see the next one. Next time when we are seeing some anti-inflammatory action quieten the child, so we are seeing the distal and other coronary component better. And coronary focus, just to add on, so nice 2 papers were presented by the PGs that it is beyond coronary, other components are all maybe associated, and subtle myocarditis is extremely common, 20 to 30% with effusion or with little bit of regurg. So those points also will help us to ascertain that whether inflammation is ongoing or not, like subtle tachycardia.
Any comments regarding this, what I have given, that even in the presence of therapeutic levels of anticoagulant medications and antiplatelet therapy, thrombosis in aneurysms, in giant aneurysms, can occur due to unfavorable blood flow mechanics and decreased wall shear stress in the aneurysm.
This is also one of the reasons, but in practice, possibly all the patients, whatever I do recall, on good, you are very fond of giving low molecular heparin on continuity. I have not seen a single one developed on your therapy, second one, but I think I cannot conclude based on my own data. It's extremely rare. This is also a theoretical cause.
Possibility.
Definitely it's a possibility. But primarily, Devasri can tell that. Yeah.
No, this is definitely a possibility because we do see that giant coronary artery aneurysm children or patients who maybe did not have any thrombus to start with, and they have been on a good dose of anticoagulant, double antiplatelet. But despite that, they develop like thrombus. They develop acute myocardial infarction. So this abnormal flow mechanics would explain that. So it is extremely important to be very vigilant about the anticoagulant dose and to maintain the necessary INR ratio, which is like very challenging for babies to maintain a tight INR ratio because of weight and a lot of food and drug interactions. But this pathophysiology is important.
So yes, so because of variety of factors, even in spite of the best of therapies, these babies can develop a new thrombi. So that is, I think, what we understand from this discussion. So how to monitor adequacy of LMWH, we have already covered that. So now you have a thrombus in LMCA and the bed of the LAD. So you can see the echocardiography over here. There are 2 thrombi. How would you like to monitor the baby? So we have to remember this is a 9-month-old baby with giant aneurysm, large size thrombus. So almost a nightmare. So this is actually a nightmare. So how do you like to monitor the baby? Devasri, yes.
So yes, it is literally a nightmare. You would definitely like to keep the baby in ICU to do a continuous heart rate and vitals monitoring. Do regular ECG, troponin to suggest if there is any serial rise in the biomarkers, cardiac biomarkers. Do echo, which will show if the clot is extending or there is any regional wall motion abnormality which may be developing as a new event. So all those would say that this thrombus is becoming significant and this is leading to injury to the myocardium, ischemia to the myocardium, and we need to maybe change our treatment protocol. Whenever there is a thrombus and we have had all the necessary drugs on board, now it is time to consider thrombolysis.
Okay. So basically, you have to be very vigilant and keep a continuous monitoring. So that is the most important. So now let us have a look at the myocardial infarction. I understand it's very rare, it's extremely rare. Still, we have occasionally lost babies with AMI. So these terms have come up recently, the STEMI and the non-STEMI MI. So Anil, would you like to say something?
I think again, very difficult thing you are asking. All the AHA 2024 guideline, actually they have drawn the data from adult population, just copy. In the practice with infant who cannot tell, diagnosing an acute myocardial infarction or developing is extremely difficult. There can be two types of presentation. Baby with giant thrombosis and presented with features of AMI. And we are diagnosing with ECG and high sensitivity troponin. Then that child is a candidate for thrombolysis versus resolution in cath lab. The door to or diagnosis to needle time is 90 minutes. That frequently will be extremely difficult in our scenario because the baby is present very vaguely. So when the symptoms started and when it is
say
going,
something about how an AMI can present in an infant.
It will be very, very bizarre. It will be distress, sweating, irritability, crying. So the traditional pain chest, how the adult manifest, will not be there in the kids. Excessive cry, sweating, and not feeling well. So subtle pictures. So how somebody can even suspect? If it is a diagnosed case, yes, then we know that it is the candidate for developing AMI. Then we are vigilant, we are doing all blood test or ECG, and then we are picking it up. But in an unsuspected cases, it's extremely difficult. And 2 of the ICH patients, I do recall, had sudden cardiac death, and that's how they present. It will be occluding thrombus and will not give time. Partially occluded thrombus, like you showed, flow will be maintained and they will not possibly create the symptom what we are expecting. That's what I am telling from ICH, whatever I saw.
So, infants, what about the little bigger children? How can they present with MI?
In the bigger children also, they will be irritable. The pain component, they may not be able to tell. The age group what we are considering, it will be distress, sweating, and that's all. Pediatric population will not present with classic excessive cry during feeding. As we tell in Alcapa type of symptom, they can present. When they are taking feed, they are getting restless because of the stress like exertion.
May I add something, Anil?
Yeah. Yes, please.
So there may not be classical chest pain which we expect in adults, chest pain radiating to arms. Abdominal pain, vomiting, this could also masquerade as acute myocardial infarction.
Exactly. We had one of the patients who had presented with pain, abdomen, and vomiting. We couldn't realize actually it's an MI. And then suddenly overnight the baby crashed. So, yes. So, just 1 or 2 words about this ECG, this ST changes. Devashree?
So basically, this is the J point, which is the transition between S and T. There is J point elevation beyond the baseline. And it is significant because it has gone up by more than 2. 5 millimeter, 1 small square elevation is significant. Now it has gone up by 2 small squares. This is classical of ST elevation myocardial infarction. A trained adult cardiologist's eye would need no further telling what we need to do.
So,
Q should be pointed out because this
Q is a late finding.
So, what will be the indications for thrombolysis? If you want to thrombolize a baby, what will be the indications for thrombolysis?
If we are demonstrating symptomatic child not responding, we should thrombolyze. Because AMI documented, then it's an indication for resolution. Now whether we'll do it by going cath lab or by thrombolysis, this thrombolysis in our scenario possibly will dominate because of the time and reaching to a center. If we can
and
reach
also
to a center,
non-availability of hardwares.
so
Small babies,
getting
hardwares could be an
access, a small 6-month-old child, we are getting an arterial access and going to the LMCA to, as a first line, may be tricky, difficult. To salvage the time, possibly thrombolysis is a good option. If first line fails, then possibly intracoronary thrombolysis. That's what is discussed in literature, but I am yet to see one.
So what drug would you recommend? Any drug, particular drug for thrombolysis?
So basically, the drug that is frequently used, most frequently used in adult PCI is recombinant tissue plasminogen activator. The other name is alteplase. And that is given as infusion. There are other drugs also, tenecteplase, retiplase. But alteplase has got the short half-life. So that means like when you need to actually stop it, it reverses instantly. So then, so this drug is chosen for thrombolysis, and it is given as an infusion. And preferably, when you are giving alteplase, we need to establish two accesses, two peripheral accesses. Through one goes the alteplase, and through another, we should also start unfractionated heparin. So because these two drugs have synergistic action that leads to eventually clot resolution and improvement in the coronary myocardial perfusion. So, and yeah, that's basically its thrombolysis.
So I think we have discussed this IV heparin and subcut LMWH. So how long to continue anticoagulation? Orchun?
This is a very difficult question, and so actually there is no definite answer. It depends on the serial monitoring, and it depends on the serial echocardiography monitoring, then CTCA. So if there is the fate of aneurysm as well as the thrombus, it will determine the duration of anticoagulation. So case-to-case basis, you will have to individualize your treatment. There is no fixed duration that you will have to continue. So there is no prefixed thing. It depends on the particular case scenario that you are dealing with.
So just considering this baby has a giant aneurysm. So how long would you like to continue?
So as long as the giant coronary aneurysm remains, so you'll have to continue anticoagulation plus thrombus.
So let us see what happened to this baby. Sorry, I think. So we continued the baby on cyclosporin, steroids, low molecular weight heparin, clopidogrel, as well as aspirin. And if you look at the serial echoes, so 9th of November, the baby was admitted. There was an aneurysm in the LMCA. 13th of November, so after 3 days, you had a LAD also. And on regular echo, we see on the 25th of November, the LAD thrombus has almost resolved. And by 28th of November, so both the aneurysm, both the thrombi has disappeared. And this is the what happened. So this is the, I think, 28th November. You can see both the thrombi has resolved. The aneurysm is definitely persisting, but both the thrombi has resolved. I think this is coming up, the newer oral anticoagulants, the direct oral anticoagulants. Any experience regarding this?
Used some of the CHD bigger patients, not in a smaller patient. The literature is also very limited, but I wish to use because two disadvantage of two drugs, the injection of heparin versus the INR maintenance of warfarin, both are very difficult for the patients. The compliance goes down in both, and at the end we lose on the efficacy. So this is a very, very promising, going by my adult experience, it works very well. The dose, what I saw is looks, I think, 1/4 of tablet of 2.5, half, like very nicely mentioned. So should be the coming time therapy as aspirin, clopilate and apixaban, or in adult practice they use apixaban plus clopilate. So that may also come, but let time decide, and I'll be very eager to use this drug.
So this 2024 AHA guideline, they have published the early result of saxophone trial, which is a multinational open-labeled phase 2 trial looking at safety of apixaban. So because this is a very attractive drug, does not have narrow therapeutic range, does not need any blood studies to maintain the normal range of anticoagulation. So obviously for pediatricians, it would be a very welcome drug. And this saxophone trial shows as their primary endpoint that there is very minimal risk of bleeding. Now it needs to be seen whether it is efficient as well as our age-old anticoagulants to maintain the required level of anticoagulation in pediatric age group.
Definitely. So we have used in our center, not in patients of Kawasaki disease, but 2 patients with cerebral venous sinus thrombosis. The last one was a patient of nephrotic syndrome who had a factor V latent mutation, who had presented with central venous sinus thrombosis. So we had used rivaroxaban in the patient. So this baby was, finally the baby went home. So giving us almost heart attacks throughout the day.
Can I ask a question?
Yes.
Did you actually use alteplase in this patient?
No.
Only heparin. Only heparin.
Yes,
yeah, okay.
yes. Only heparin. So finally the thrombi dissolved, and we could send the baby home on injectable LMWH. So of course the thrombi had dissolved, but the LMWH was continued. A CTCA was done actually subsequently from PGI, and which showed regression in the size of aneurysms. So I don't have the data over here, but definitely the size of aneurysms also regressed. And this is looking at our data of coronary thrombosis in KD patients. So we have had 6 patients over 17 years who presented with thrombi. So 2 of them died. I think Anil already said 2 patients died. And what was interesting, post-COVID, so beyond 2020, the number of thrombi were more, the number of incidents of thrombi were more, and they had a earlier incidence of thrombi. So that was one of the 2 observations. I don't know whether COVID had really anything to do, because we again know that COVID was a thrombogenic condition. So whether it had anything to play, that is just a speculation. I'll just brush over the next 1 minute. So this was an infant, again 2 months old, very late diagnosis, KD, giant aneurysm, and this baby had a thrombi obstructing the LAD. And we could manage the patient at ICH at that time. We didn't have the facilities. The patient was transferred to Arjigor. Professor Sabui was the head of the department in Arjigor at that time. And along with the cardiology team, they did a thrombolysis. So they used streptokinase. So they used streptokinase at that time, and the baby successfully, there was a successful thrombolysis. And I think the baby came today also for the echocardiography session in the morning. He's around 6 years old now. Otherwise, he's doing fine. But he continues to have a giant LAD aneurysm. And this was the unfortunate thing that happened on warfarin. So warfarin can sometimes be a very, very difficult drug. This baby had you can see that huge bleed around the neck. So I'll end the session over here. Thank you to the panelists. I understand it's a difficult session. It's a difficult situation. It's a rare situation. But I think since we are discussing a lot of KD, we should also discuss about the thrombus in KD. Thank you. Just
Madam,
a minute.
please. Just any question from the audience? Though it's a difficult session, everybody said the audience will also be saying it's difficult. Any difficult question?
Rivaroxaban, I think we just discussed. So we have, there is a guideline coming up, as Debashree also discussed. So there are a few trials, but I don't think anyone has really tried in Kawasaki patients. We have tried in, I just now said.
The AHA update says it may be considered, but there is no, that too Apixaban, not Rivaroxaban.
Possibly
yeah,
it will be coming,
update.
yes. Possibly, yes.
Anybody among the panelists has experience in using epidemiology in children?
So before we end, I just have one question. You have covered only half, because you have covered KD in thrombus in only the coronaries, but peripheral artery you have left. So what about your experience in aneurysm in peripheral artery in KD, and do you have any experience of seeing thrombus, or you have done anything for that?
No. I had experience, I have seen a patient who had a late diagnosis of Kawasaki disease. I can tell you the story. So this was a baby around 6 months old who had fever. In the peripheries, he had fever, high inflammatory markers, treated with antibiotics, the fever subsided. After about 8 weeks, the baby develops an axillary swelling. And the baby was taken to a hospital. People thought it to be a lymph node. They were almost on the verge of giving an incision to the lymph node, but someone thought, let's do a USG before giving the incision. And it was actually an aneurysmal dilatation of the axillary artery. And it really feels like a lymph node. I have felt that. It feels like a lymph node, only it is pulsatile. So it's like a pulsatile lymph node. And so that baby had a whole body, so that baby had multiple giant aneurysms throughout the body. So there was axillary aneurysm, there was iliac artery aneurysms. I think I've shown those.
Yeah, I saw you.
The mother was a nursing staff. Yes.
So we also had one child at PGI, I think Rakesh sir would recall. So that child was around 3 years old. That child also had multiple peripheral artery aneurysms, to be specific, axillary, subclavian, and mesenteric also. So there was no visible axillary swelling. It was incidentally detected. Then doing the angio, that child underwent CTCA and echo, detected multiple aneurysms, but luckily we didn't have any thrombus. That child has also been reported.
So peripheral artery involvement
is it because of late diagnosis? Is it because of late diagnosis that?
But it,
Antibiotics are being changed over and over again, and they are not being investigated. Like Priyankar was saying, I have seen another patient coming with multiple peripheral artery aneurysms.
That is the problem of Kawasaki.
Yeah, exactly.
It's a self-limiting vasculitis.
Absolutely. The fever will go
so
away.
So the fever goes off.
Exactly.
And once the fever goes off, what is happening inside?
No one knows.
No one understands.
Right now we have a patient in our college also. He's having femoral aneurysm. I believe probably it's a part of Kawasaki.
Okay.
They do occur actually.
One add-on point, just 2014, we published from Chennai, one 60-year-old gentleman having giant multiple aneurysm with organized thrombus, and that was historically taken. Professor Kawasaki diagnosed or established Kawasaki disease in 67 around. And this publication I am talking about 2014 of a 60-year-old gentleman. So Kawasaki disease existed before he diagnosed that time. And what is the fate of this aneurysm persistent? So that 60-year-old gentleman having multiple layered thrombus organized, and he was the survivor. So it can present like that in late So this, usually we fear more of late complication of the giant aneurysm because cicatrization is more common. So obstruction to the coronary flow, that's what we fear more. Acute, now it is gaining more attention. We fear more late complication.
So I think the last Gyan that happened in PGI, Arjun was also there. So they had this beautiful poster over there. This what KD does to the heart in 5 days, atherosclerosis does over the next 5 decades.
Yes, correct, sir. Absolutely. I think in one line it summarized everything.
That summarized everything.
Correct, correct.
So thank you, all the panelists, learned panelists.
Thank you. Thank you.
For a wonderful session.
Moving on to our next session, I would like to call upon the stage Dr. Rakesh Kumar Pilania and Dr. Prabal Burman for the award paper presentation of the cases by the PGTs. Our first presenter is Dr. Marim Irin on Kawasaki's disease, perfect storm, a very rare convergence of intestinal obstruction, acute liver failure, and macrophage activation syndrome.
Do I get a cursor?
You have to swipe it.
Okay.
Just wait.
I can't see my presentation. Good afternoon, everyone. I am Dr. Irene, junior faculty from North Bengal Medical College. I'm not a PGT, but still a heart who has a learning heart, and I've come here to present a very unique case, a Kawasaki disease. So bear with me. Okay, my time is 5 plus 2, right? 5 minutes, right? 5 minutes, right? Thank you. So how do I swipe? Just like this? Okay, right. So I'm Dr. Irene. Let's see when the GERD leads to a systemic surprise, what does it happen? So here is an 11-month-old child from a non-consanguineous marriage who has come to us with a fever, with bloody loose stool for the last 7 days and was on treatment somewhere else, but brought to us due to recent abdominal distension and inconsolable cry. On examination, the child was conscious but yet irritable and crying excessively, maybe because of the pain, maybe because of the distress and abdominal distension, and there was tenderness. X-ray abdomen shows multiple air fluid level, and the ultrasound of the abdomen confirmed that it was a ileocecal intersusception. So the child was admitted under pediatric surgeon, and after stabilization of the child, emergency laparotomy was done at 12 hours of admission, and we were waiting for the response. So, however, instead of the clinical improvement after surgery, which usually happens in interceptions, he continued to cry inconsolably and clinical conditions worsened. He developed jaundice on the third day of surgery with increasing pallor, coagulopathy, and progressive hepatic dysfunctions. We can see in the picture there is a redness of the eyes, lips, cracked lips, red tongue, and we can also appreciate the jaundice and the puffiness, facial puffiness. There was also perianal excoriation. The shocking lab reports on the third day of the surgery happened to be there was a dip in the hemoglobin along with the platelet count, and the ESR was strikingly low, just to 2, and the ferritin was quite high. The LFT was deranged with PT-INR going up to 5 and SGOT going around 4,000. So we have a child who has got a fever with red lips, tongue, red eyes, irritable crying child with pancytopenia, with low ESR, but high inflammatory markers, acute liver failure in an 11-month-old infant. So this led us to a diagnosis of a Kawasaki disease presenting as interception with acute liver failure and macrophage activation syndrome, a very rare convergence. So it was a surgical course. Now it has been transferred to a pediatrician, and it has become the responsibility of the pediatrician. Echocardiography was normal. Bone marrow showed hemophagocytosis. So with intravenous immunoglobulin, within 48 hours, the child showed rapid clinical improvement, transforming from an irritable, crying child to a smiling one, bringing significant relief to the stressed mother. LFT was normalizing and pancytopenia resolving rapidly. This is a picture of the investigation. See, on day 1, we see there was no pancytopenia and the LFT was absolutely normal. But on day 5 of admission post-surgery, we can see the hemoglobin dipping down and the platelet also coming down with high SGOT, SGPT, and a high INR. And it is on this day 6 that we started giving immunoglobulins, and after 3 or 4 days, the ferritin arrived to be around 3,839. So after 2 days of immunoglobulin, we saw a significant decrease in the liver function with enzymes coming down. And on the 10th day, where we are about to discharge the child, the blood counts, the pancytopenia has resolved, the LFT has come almost to a normal. So this is a very satisfying picture. We saw that, this is a child with a very happy face, and the mother, a very happy face, at the time of discharge, clinically stable. And but this picture is give us more satisfactions, because this picture is taken on day 10 post-admission, like post-discharge, and we can see in the picture clearly the periangular desquamations, which is usually visible on second or third week of Kawasaki disease. So we have nailed it because we have diagnosed much earlier. So the child was successfully discharged, and post-follow-up echocardiography showed no coronary artery aneurysms. So why I am presenting this case? First of all is Kawasaki disease with interception, Kawasaki with acute liver failure, Kawasaki with mass are individually very rare, but they have been reported. But combination of all these 4 in just one child, we have searched the literature and still we are unable to find yet. Second point is strikingly low ESR despite worsening clinical and lab conditions. Increasing pancytopenia serve as a crucial clue in post-operative case on day 6 of admissions. So it has helped us in diagnosing KD with mass. Third is, since KD is a clinical diagnosis, a high index of suspicion is crucial even in incomplete case for avoiding delaying the diagnosis. Last but not so important, timely intervention has resulted in preventing life-threatening complications. Thank you.
Thank you, Dr. Irene. That was indeed a unique case. Just wanted to highlight, do you think doing an ESR was necessary after, IVIG?
No, it was not done before IVIG. It was done, sorry, it was done before IVIG.
No, what I understood was on day 6 and day 8, the patient received IVIG, right? Then
No, though on day 6, we just sent the blood sample and then we started the IVIG.
When the ESR was 2, right?
Pardon?
When the ESR was 2.
Yeah.
So you gave the IVIG?
Yes.
Then on discharge, before discharge, did you repeat the ESR again?
Yeah, that was on the last slide.
Yeah.
Day 10 of that was normal already.
Okay, so that's what I wanted to highlight. The ESR should not be done as an inflammatory marker when you have given IVIG because it may be falsely elevated. A better marker would have been CRP.
Okay. No, it was done to diagnose the mass.
I understood.
Yeah.
So I understood that you diagnosed mass when the ESR was low, ferritin was elevated. After that, when the patient received IVIG, following IVIG, usually the ESR should not be repeated.
Actually, ESR was part of the normal CBC. That's why I put initially it was very low and then.
Yeah, I get it. So because postgraduates are also here, just wanted them to also realize that it's not an inflammatory parameter.
Yeah.
So CRP would be a better option. It's a good case.
Yeah. No. We had to give blood transfusion for this case.
So
there were so many other treatments that went on. It was a roller coaster, a stormy, clinical conditions. But we had to, because of the time constraint, I had to just reduce it to just few points, important points, takeaway points.
thank you, Dr. Irene, for the nice case. Basically, my question is that this is an infant, and as per AHA scientific statements, if this case you have a next time similar case, will you manage differently or will manage just with IVIG?
Sir, I couldn't get your question, please.
So this is an infant with macrophage activation syndrome,
Yes,
with your liver failure and very high inflammatory marker. As per the latest AHA scientific statement, if you will manage this case again, so how would you manage? You will just manage with IVIG or you will give more than that?
if this case re-happen, if the child comes with Kawasaki disease or mass?
If you see a similar patient in the future, would you treat
Similar patient in future if it comes back again?
You will treat it with single dose of IVIG or would you like to do something else?
And the second question is that whether you perform the pro-BNP in this child? Pro-BNP.
No, sir, we didn't do that.
Okay, thank you.
Thank you.
Next presentation, please.
Our next presenter is Dr. Barsha Agarwal on the topic From Febrile Unrest to Recovery, a Voyage of Infantile Kawasaki Disease. Good afternoon, everyone. Today I am going to present a case on infantile Kawasaki from febrile unrest to recovery. Kawasaki disease in infants is a diagnostic dilemma because of its incomplete or atypical presentation. Current literature reports that children below 12 months of age have higher prevalence of incomplete and atypical Kawasaki disease compared to older children. Incidence of Kawasaki disease in infants less than 6 months of age is approximately 10%, and in infants less than 3 months of age in Korea and Japan is only 2.2% and 1.7% respectively. In our case, we had a 2 months and 28-day-old female baby weighing 6 kgs with no significant antenatal birth and past medical or family history, presented with a high-grade fever for 7 days. The parents also reported increased crying during micturition and there were no other signs. Initial investigation suggestive of hemoglobin 8.5 with leukocytosis neutrophilic, urine REME suggestive of WBC 20 to 25 cells per high power field, and urine culture was positive for E. coli. Therefore, initially managed as a case of UTI with IV antibiotics. Despite appropriate antibiotic therapy, the infant developed new clinical signs, including perineal excoriations and maculopapular rashes over face and trunk on day 3, bilateral non-purulent conjunctivitis on day 5. Given the evolving symptoms, the possibility of an alternate or additional diagnosis such as incomplete Kawasaki disease was considered. So further evaluation was done ferritin was raised, CRP was raised with normal procalcitonin, echo suggestive of dilated coronaries. LMCA 3.5 Z scores, LAD 3.3 Z scores, and RCA plus 2.3 Z scores. We diagnosed it as a case of infantile Kawasaki disease. Then it was managed with IV antibiotics along with IV immunoglobulin and aspirin. Follow-up echo at 1 week after IVIG suggestive of decreasing trends of coronaries. And at 1 month, the coronaries were within normal limit. KD is a rare but important differential in febrile infants less than 3 months of age. Diagnosis is often delayed in this group due to atypical or incomplete presentations. In our case, the infant was initially managed as a case of UTI. However, the development of perennial excoriation, rash, and bilateral conjunctivitis raised suspicion for KD and treated as Kawasaki disease. Early recognition and timely initiation of therapy are critical to prevent coronary complications. This case emphasizes the need for high clinical vigilance for KD in patients with persistent fever, even when an alternative diagnosis appears evident. We have seen KD in patients with adenovirus, rhinovirus, coronavirus, and certain other bacterial infections such as Staph aureus and Streptococcus pyogenes. In this case, we have seen rare association of KD with gram-negative E. coli. Early echocardiographic assessment and prompt therapy significantly impact outcomes, reducing the risk of coronary aneurysms and long-term morbidity. Every tiny heart matters. A fever today may be a life-threatening event tomorrow. Kawasaki disease is thought to be triggered by an abnormal immune response to infectious agents in genetically predisposed children. Although no single pathogen has been confirmed as the definitive cause, numerous infections have been associated with KD. So viral infections such as adenovirus, Epstein-Barr virus, coronavirus, parvovirus B19, CMV, enterovirus, bacterial infections such as Staphylococcus aureus, Streptococcus pyogenes group A, Mycoplasma, rickettsial species. The observed relationship between infections and subsequent development of KD highlights the importance of clinicians remaining vigilant for signs of inflammatory protuberance secondary to infections that may indicate the onset of KD. Furthermore, the association with bacterial infections underscores the value of pathogen culturing and judicious use of antibiotics. Thank you.
Thank you, Dr. Barsa, for a nice presentation. What is the cause of pyuria in Kawasaki disease?
Sorry, sir?
What is the cause of pyuria in Kawasaki disease?
Sir, in Kawasaki disease, it is generally sterile pyuria due to inflammation of the urinary tract.
Complete urinary tract or specific, you can localize that where it is like because of, it's a pyelonephritis or it's a myotitis?
Myotitis, sir.
It's a good case. Do you think there is a difference between the terms atypical Kawasaki disease and incomplete Kawasaki
Yes,
disease, or do you think they are the same thing?
No, sir, they are different.
Okay, so how would you differentiate?
So incomplete Kawasaki disease means instead of 4, less than 4 criteria out of 5 will be fulfilled, and in atypical Kawasaki, other organs such as renal will be involved.
So which are the least commonly involved organs in Kawasaki disease? I'm sure you know the commonest ones, the least common. Okay, it's okay. Thank you.
Thank you, sir.
Next. It's the CNS and the kidneys.
Our third presenter is Dr. Pallavi Agarwal on Kawasaki disease with giant aneurysm, a case series.
Good afternoon, everyone. My name is Dr. Pallavi Agarwal. I would like to present a case on Kawasaki disease with giant aneurysm, a case series. It's not going. Why early diagnosis of Kawasaki disease is important? It is an acute febrile illness affecting children less than 5 years of age, where echocardiography remains the primary modality of investigation. Involvement of RCA, LAD, Z-score more than equal to 2.5 at diagnosis and age less than 6 months should be considered for intensification of primary therapy. IVIG plus adjunctive anti-inflammatory therapy reduces the risk of coronary artery aneurysms. A 4-year-old baby boy had a history of fever for 15 days, presented with mucositis with maculopapular rash all over the body with periorbital redness 4 days earlier. On investigation, the total leukocyte count was very high, CRP was high, there was thrombocytosis and SGOT-SGPT was raised. Echo was done because of extreme irritability and thrombocytosis that revealed giant aneurysms in LMCA, LAD and RCA. Because of a fever of 15 days, because of the infant, the medications that the child received was IVIG, infliximab, aspirin, cyclosporin, low molecular weight heparin, steroids, and clopidogrel. Alternate day echocardiography was done that showed the gradual reduction in the size of the dilated aneurysms. Blood count showed improvement after 48 hours. The child became hemodynamically stable and afebrile and was gradually discharged. Diagnosis incomplete KD with giant aneurysms. The second case, a 9-month-old baby boy had a fever of more than 1 week with left-sided neck swelling for the same duration with redness of eyes, lips, tongue associated with perianal excoriation for 1 day. It was a case of complete Kawasaki disease because the child was irritable, sick-looking with oral mucositis, non-purulent conjunctivitis, bilateral cervical lymphadenopathy, bilateral dorsal edema of hands and feet with no BCG scar reactivation. IVIG plus aspirin was given as usual, but there was persistence of fever for 24 hours after IVIG completion. Echo was done that showed that the size of LMC aneurysm has increased. Therefore, oral steroids was added. After 1 day, child started complaining of vomiting, abdominal distension, and constipation. Straight X-ray was done that showed subacute intestinal obstruction. Repeat echo was done that showed a further increase of the Z-score that was 5.2 to 8.2. Infliximab was added at the rate of 10 mg per kg and low molecular weight heparin was added. Repeat echo was done that showed a further increase in the Z-score. Low molecular weight heparin was increased to 2. IV antibiotics was given and a stress dose of hydrocort was given for 3 days, which was gradually changed to oral steroids. With gradual tapering doses, the child became afebrile, hemodynamically stable, and was discharged. The third case, a 9-month-old boy presented with history of fever for 7 days, high-grade intermittent, with edema of dorsum of hands and feet, red palms and soles, rash during the first 2 days of fever, presence of cracked lips, red discoloration of eyes. The diagnosis was of infantile KD. Moderate size aneurysms was seen in LMCA, LAD, and RMCA. Infliximab was started, followed by IVIG. Low molecular weight heparin was started along with aspirin and oral steroids with gradual tapering. When the child came with follow-up after 2 weeks, it was seen that there was an increase in the diameter of the coronary aneurysms. Therefore, cyclosporin was started at 2 mg per kg per dose 2 times a day, and the dose of low molecular weight heparin was increased. According to many trials that has been done, one that was done in the Mexican children, it has been seen that patients younger than 1 year, those with high duration of illness at the time of diagnosis, and those who received additional intravenous immunoglobulin showed a significantly higher frequency of giant coronary aneurysms. Conclusion. Large coronary artery aneurysms are at a higher risk for complications for luminal narrowing, thrombosis, and major cardiac events. Per day delayed in treatment increases the risk of medium and giant aneurysms. Prognosis of KD is determined by the extent of coronary artery involvement, which ranges from transient ectasia to giant coronary aneurysm. Size of the coronary artery aneurysm in the acute phase is predictive of the future outcome and determines interval follow-up. Treatment, when it is done before the day 10 of illness, is associated with a lesser risk of coronary artery aneurysm, with greatest benefit if the treatment is started well before day 7th of illness. Thank you.
Thank you, Dr. Pallavi, for the nice case series. So my question is that what is your take-home message from these 3 cases? Your conclusions are not supported by your 3 cases. I am saying, what is your take-home message from those 3 cases?
So any child who presents with history of fever, less than 5 years of age, should always undergo an echocardiography. Or irrespective of echocardiography also, should always be looked for. If any symptoms present, then should be treated with IVIG. Even if this is not present. Like for example, it's a very common case. For example, in the first case, the child already had a fever for 15 days. In the X-ray, there was mild pleural effusion that was present. So first 2 days, the child was being treated on that line. But because of excessive irritability and thrombocytosis, we went for echocardiography. So if it would not have been delayed to a much later part, then we should have been started with IVIG then and there. So or jo 2 din the day that was delayed would not have been done. So I think that any child who presents with fever for a longer duration, more than 5 days, especially when the incidence is increasing to such a great level, should always undergo echocardiography.
So I can see is that all 3 patients had age less than 12 months.
Yes, sir.
So because you have presented all 3 as infants.
Infants, yes,
and
sir.
second thing is that the child who had a moderate size aneurysm, you have called after 2 weeks, and within 2 weeks there was a giant aneurysm.
Yes, sir.
So possibly the take-home message would be that if there is a medium-sized aneurysm or moderate-sized aneurysm, so you should do a frequent echocardiography to look for whether they are progressing to the giant aneurysm. And in infantile KD, they will be almost always incomplete, and in any infant who is having a fever more than 7 days, we should look for a Kawasaki disease differential.
A nice series. What was the dose of infliximab that you used?
So 10 mg per kg.
10 mg. So previously it used to be 5 mg per kg. Do you know the reason why it increased from 5 to 10?
No, sir.
Okay. We'll discuss later. We are short of time. Let's move to the next one.
Thank you, sir.
Our fourth presenter is Dr. Biman De Tarafdar with the topic, Pneumonia Does Not Rule Out KD.
Hello everyone, I am Dr. Biman De Tarafdar, Junior Resident, ICH, Kolkata. I am going to present a case of pneumonia doesn't rule out Kawasaki disease and uncommon presentation. 1 year, 6-month-old boy, child, born out of non-consanguineous marriage, presented to us with chief complaint of high-grade fever since last 6 days, lips and tongue erythema since last 4 days, cough and cold since 4 days, fast breathing, poor oral intake and lethargy since morning of the day of admission. On examination, child is tachypneic, drowsy and febrile. Heart rate was 160 beats per minute. Blood pressure was 50 to 90 centile. SpO2 was 88% in room air. Respiratory rate was 48. Oral mucositis was present. General examination was normal. On systemic examination, no organomegaly was noted. CNS, GCS was 13/15 and pupil was bilateral equal reactive. Initial investigation shows high CRP with low hemoglobin. These are the chest X-ray on admission showing bilateral lower zone opacity. Course in the hospital, as the child was having respiratory difficulty and high grade fever, he was given IV PCM and Livolin nebulization in emergency and was admitted in a ward with nasal cannula support. In view of initial blood investigation and chest radiograph, bilateral lower zone opacity, injection ceftriaxone and teicoplanin was started empirically. The child became afebrile after 3 days of admission and repeat sepsis marker also shows decreased. After 5 days of IV antibiotics therapy, there was still oxygen dependency and persistent oral mucositis, and child continues appeared to be sick. Repeat X-ray was done and showed not much improvement, still showing the bilateral lower opacity. On 10th day of illness, mother noticed that swelling over both hands and feet that eventually resolved spontaneously on the same day. On the 11th day of illness, the child was started having peeling of skin over both hand and feet, perianal redness, and became irritable. Repeat blood count showed elevated ESR and CRP also, and thrombocytosis and neutrophilic leukocytosis. These are the exclamation. With these clinical symptoms and laboratory parameters, diagnosis of incomplete KD was done. Child was given IVIG at 2 milligram per kg on 7th day of admission with low dose of aspirin. After completion of IVIG, the child improved well, both clinically and radiologically. There was no tachypnea, and child was maintaining SpO2 well in the room air. Echocardiography was done, and which was normal. This investigation showed CRP was high and then gradually decreased, and platelet was thrombocytosis also there. Echocardiography done, and that is shows normal. Thank you.
So what do you feel that, what is the cause of chest X-ray finding in a child with Kawasaki disease?
Sorry, sir?
Why there is this radiological finding you have seen in chest X-ray? Is this related to just because of infection, or it can be because of Kawasaki disease also? And if it is yes, and what are the findings which can be seen on a pulmonary manifestation of Kawasaki disease on radiology?
Yeah, it is due to Kawasaki disease only, sir.
Why I am asking is that because you have shown an X-ray,
Yes,
and post IVIG there is almost a resolution of the pulmonary shadows. So which suggests that possibly it is not related to the bacterial pneumonia, because it's possibly interstitial pneumonitis or pulmonary nodules because of the Kawasaki disease. Because you have shown that X-ray is almost normalized post IVIG, which would be almost impossible in any bacterial pneumonia.
So, what do you think is the relation of pulmonary presentation of Kawasaki with the evolution or development of coronary aneurysms? Have you compared this case with previously published data?
No, sir.
No. Okay. Thank you. Thank you. Next.
Our fifth presenter is Dr. Shubhro Somdas with the topic of infantile Kawasaki disease with multiple thrombus.
Good afternoon, everyone. I am Dr. Shubhro Somdas, DNB resident from Apollo Multispeciality Hospitals. I am going to present a case of infantile Kawasaki disease with multiple thrombus. So this is a case history of a 9-month old baby boy who presented initially outside hospital with a history of fever for 12 days with red lips. There was unilateral neck swelling from last 5 days. There was associated with redness of eyes, which was lasted for 1 day on 5th day of fever. And on outside OPD basis, the child initially got antibiotics, then outside it was not resolved, then admitted to the outside hospital. And on outside hospital, on examination, they found there was oral mucositis present, and he was diagnosed as Kawasaki disease. And the investigation they did, significantly they got the raised total count, raised platelet, and CRP was raised. And echo did outside hospital. They got multiple aneurysms and thrombus at LMCA bifurcation at left circumflex origin. They given IVIG at the rate of 2 gram per kg. They initiated on infliximab at the rate 10 milligram per kg. They initiated on LMWH at the rate 2 milligram per kg. And referral was given for better management to our hospital. At our hospital, we started on aspirin low dose, that is 5 milligram per kg per day, along with cyclosporin 5 milligram per kg per day, with subcutaneous LMWH with same dose that previous hospital 2 mg per kg, along with oral prednisolone. This all started due to there was evidence of multiple aneurysm presence from outside echo. And on investigating, we found that the platelet count was high, and along with there was aneurysm. So we added clopidogrel with the ongoing management. The echocardiography we did that showed there was giant aneurysms in LMCA, LAD, left circumflex, and right coronary artery, everything with giant aneurysms in LMC and LAD, and left circumflex and RCS, moderate set aneurysm, and there was thrombus in the left middle cerebral artery, coronary artery present there. Subsequently, echo also repeated on the third day, which also showed another presence of another thrombus in the left LAD. Near the bifurcation, but on color Doppler it was shown that color flow thrombus was not obstructive type. As there was a presence of a new thrombus, on suspicion of if there is any infection is going or not, we did an ECG which was normal, and we also did a trop level which was also in normal range, and NT-proBNP was also done, which showed there was no features of myocarditis. So the same management was continued and a serial echo was done. At about 1 week, that is 20th, the echo was repeated, which shows there was decrease in the size of aneurysms, along with the thrombus was actually resolved and no thrombus was seen. So on further course of management, the steroid dose was decreased. Initially, the steroid was 2 mg per kg per day. Then we decreased this to 1 mg per kg per day. Their family members was demonstrated how to give LMWH at home, and the child was finally discharged on aspirin 5 mg per kg per day with clopidogrel, prednisolone, and cyclosporin with LMWH. So outcome was, both the thrombi was resolved when the baby was discharging. The giant aneurysm in LMCA and LAD reduced to moderate size aneurysm within 20 days. And the last follow-up after 6 weeks of discharge was all coronary arteries significantly reduced and lumen free of thrombus, which further confirmed by CT coronary angiography that it was resolved. And this is the echo showing. Echo showing at 6 weeks, which shows that there is no aneurysm, there is no thrombus and resolved aneurysms. So conclusions from my case is that frequent echocardiographic monitoring during the acute phase of Kawasaki disease helps in early detection and complications like progression in size of aneurysms and formation of thrombi, and timely aggressive management that can lead to discussion of the dissolution of thrombi and also regression in the size of aneurysms. Thank you. Thank you.
Thank you, Shubhra. Very interesting case. So, can you tell me something about the role of atorvastatin in the future? If you come across a case like this, would you be considering a use of atorvastatin in these patients?
We didn't use atorvastatin, sir. We used aspirin and clopidogrel. Dual anti.
Thank you.
Nice case, and slides were also very colorful and nice. So you have given a conclusion that aggressive management. What are the you are aware about the AHA 2024 scientific statement? What are the risk factors, or what are the factors which are necessary to think for a treatment intensification in children with KD?
Sir, when I will start aggressive management? Sir, in case of giant aneurysm, that is Z score more than 10, presence of thrombi, if the child is a small kid like the infant we treating here, and there is other any features is there, if that is features of infarction, raised troponin levels, or any features of myocarditis, if it is there, then we should start aggressive management.
What I can see is that NT-proBNP levels were almost normal in this baby. So that was that was possibly reassuring also that you are not having an effect of thrombus on the myocardial.
On the myocardium, yes, sir.
Yeah. Thank you.
Thank you, sir. Thank you.
Our last presenter is Dr. Snigdha Moral with the topic of PUA in infant, think Kawasaki disease.
Till she's starting that, on lighter note, we can just give this session name as Infantile Award Session, because all are like an infant with Kawasaki disease.
Good afternoon. My name is Dr. Snigdha Moral, and I'm going to present a case of pyrexia of unknown origin in infant, think Kawasaki disease. So this 4-month-old male baby presented with fever associated with increased irritability for the past 22 days. He developed redness of lips and tongue 14 days back, which subsided. He also developed loose stools for the past 5 days, followed by perianal excoriation for the past 4 days. Birth history, it was not very significant, single, term appropriate for gestational age, male, cried immediately after birth, and there was no history of NICU stay. So key notes in this child's clinical history was that this child was initially treated by a local practitioner and oral coamoxiclav was given, and following which this child became afebrile for 3 days. Subsequently, the fever reappeared and the irritability of the child had persisted all along. This time he was prescribed with oral cefpodoxim. This time fever persisted and mother also noticed that there was increased redness of the tongue and lips. He got admitted to an outside hospital. During the course of the hospital stay, he was admitted there for around 7 days. He received injection meropenem, ceftriaxone, linezolid, clindamycin, yet the fever persisted. Oral mucosal redness had reduced on its own, but this time there was new onset passage of loose stools. Echo was done on 27th of March, which showed structurally normal heart with normal coronaries. So this child was transferred to ICH, and on arrival, this child was irritable and sick-looking, high-grade fever, 103, and head-to-toe examination showed perianal excoriation and redness at the BCG scar. It is important to note here that this was persistent since the child had received the birth dose. There was no oral mucositis at this time, but had a history of oral mucositis. Systemic examination revealed the child was irritable, and respiratory-wise, there were bilaterally, their chest was clear on auscultation. Saturation was 98% in room air, per abdomen soft, non-tender, no apparent organomegaly, and urogenital-wise, there was perianal excoriation. So here we can see the perianal excoriation and the BCG scar. During the course of the hospital stay at ICH, investigations which were sent routinely showed significant thrombocytosis and high CRP. IVIG was given at 2 gram per kg over 12 hours, and aspirin 5 mg per kg per day was added. The child became afebrile. Echo was done on 31st, which showed LMCA, Z-score plus 10, LAD, aneurysmal dilated and tortuous plus 22, proximal RCA 12, Z-score, and when we got these reports, we immediately started the child on injection infliximab, injection enoxaparin, syrup cyclosporin, and on the next day, tablet clopidogrel was started. We did cyclosporin concentration from the blood samples, and it came within normal limits and less than the toxic levels. So it is interesting to note that on 27th, this child had completely structurally normal heart, and on 31st, we are seeing 3 full-blown giant aneurysms. Serial echo was done, which showed no thrombus formation. Diagnostic dilemma was that this child had presented with only fever. And there was history of definitely mucositis, but on presentation at ICH, there was no mucositis, only fever and some irritability. So this was the echo which was done on 27th, and then on 31st, we can see 3 giant aneurysms. And if you see the routine investigations from day 4 or 5 of illness, we can see that the total count has increased. But on day 10 of illness, it was first, on day 14 of illness, it was first documented that the platelets have increased. Other fever profile was done, which came out to be negative. ESR was high, 42. So my take-home messages would be infantile KD can present with fever as the sole clinical feature. In case of pyrexia of unknown origin, Kawasaki disease needs to be considered as a possible differential diagnosis. American Heart Association states that it is imperative to diagnose Kawasaki disease as soon as possible, and treatment to be started within 10 days of fever onset is associated with a lower risk of coronary artery dilatation or aneurysms. Frequent echocardiography monitoring during the acute phase of Kawasaki disease helps in early detection of complications like progression in the size of aneurysm and thrombus development. Thank you.
Thank you, Dr. Snigdha. So I was looking for a take-home message, for something different take-home message. Can you if I give an opportunity, can you change your take-home message? Because I'm not comfortable with so many antibiotics.
Sir, we did not give these antibiotics.
So what is your take-home message?
Sir, if the child, if a child who is presented with a fever of unknown origin and that is not subsiding with maybe one antibiotic which you are upgrading to another antibiotic, then we should definitely suspect that it is not an infective cause but inflammatory cause, or maybe in some cases a malignant cause.
So that is a very important thing, because in children do well in spite of us actually. So like as a pediatrician, we should think 100 times to switch for a second line of antimicrobials. Till the time we are using amoxicillin, and that is fine. But beyond that, the names you have written like cefpodoxim, then possibly linezolid and meropenem and everything, they looks very fancy, but they are scary actually. So when we are not having a diagnosis, sensible diagnosis, and specifically in infant, that's why AHA 2024 statement also says that in infant, if there is a prolonged fever, just prolonged fever of infant and infantile age, possibly a marker to think for different as a Kawasaki disease as a differential diagnosis. So I'm not saying for KD, I'm just saying as a blanket that when we are using antimicrobials in children, it should be very judiciously, should not be like now we all are in a social media era, and we have seen that fever is not a sign of ceftriaxone deficiency, and that is holds true. So that is a very important thing. And
Also,
second in when Priyankar sir and Suparna ma'am is there, so as a infantile KD is a very different thing, and possibly I can propose that we should have our possibly multicentric experience of infantile KD as from India, and possibly we should evaluate them as all our nationwide data to see that whether how infantile KD behave in India in comparison to other countries.
Also, sir, here I would like to add that this child got all the IV antibiotics in an outside hospital, and after which this child started having those diarrhea symptoms. So it sometimes can mask the features.
Yeah, just but to add, you have presented beautifully, so I think that would be the main take-home message. So we use the word upgradation frequently, but it's a paradoxical word actually. We should be very careful when a young infant not responding to fever, we have to think of Kawasaki. So just wanted to know, you have done the trough level for cyclosporin. So according to the latest guidelines, what do you think should be the cutoffs?
Sir, they have given cutoffs for this in the test only. Usually we try to keep it in the therapeutic range. We do it on the day 5 of the...
It should be above the therapeutic range actually. You say it was normal. So in this particular patient, the dose was actually subtherapeutic.
It was less than, but sir, we usually do it on day 5 of after starting cyclosporin, and we just and at that time we try to see whether it is more than what we need,
So
whether
that's
there is
what
causing any toxicity.
So that's what happens in India because of we don't have access to all labs. But in Western nations, especially in Japan, after a single dose, they actually check for the trough levels.
Okay.
So according to Kaika trial, they had given it only for 5 days. Only the latest latest AHA 2024, they have said that we should give at least for 10 days.
Yes,
and
sir.
at least in PGI, we used to give for between 2 to 4 weeks.
Okay, sir.
Thank you. Nice
Thank
to
you.
present.
Thank you, sir. Sir, here comes the proper history taking. We there at any single point of time, for the longest time, this child had only fever, and after that he developed mucositis, and there was some BCG scar redness. But if we see the serial investigations, Serial investigations show that progressively platelets are increasing, and also total count is on the higher side. ESR is also high. And sir, we have done all, more or less all routine fever profile that we need to check, and everything came out to be negative. So if it is not an infective cause, it has to be an inflammatory cause. And also it is necessary that we diagnose KD as early as possible. In this case, it was delayed. And initially also echo came out to be normal. So it was...
So in this case, possibly there is a no doubt because this baby is having a giant aneurysms, multiple coronary arteries. So but what I think sir will add, but what was the important thing is that there was a perineal rash and BCG site reactivations, and these are the two most important, almost considered as one of the most specific signs for Kawasaki disease, and that is a problem with infantile KD. Infantile KD is a different subgroup and it's almost always incomplete. We are not saying that all febrile child is an equivalent to Kawasaki disease or all febrile child when they are having, they should be, but it should be investigated, not treated as a sepsis. I was seeing one presenter's slide says sepsis marker. We should not say them as a sepsis marker. These are inflammatory markers. Nothing is a sepsis marker. And that is a problem that we all equate ESR and CRP as a sepsis marker. These are inflammatory markers and we should identify the cause of inflammation, whether that can be an infection or any other inflammatory cause.
So, speaking about this child, so this child was admitted in ICH on 28th. Look at the 28. So this was a baby who was admitted, 4 months old baby.
4 months.
Who was admitted with 22 days of fever?
22 days.
22 days of fever. Received multiple antibiotics. Show the blood reports.
Blood reports.
And so if you look on admission 28, overwhelmingly high platelet counts, almost 9.5 lakhs. So the counts are high, the platelets are so high. The CRP 5.6, it was 0.5. 0.5 cutoff. The CRP is high. So 56. So with the 22 days of fever, a small baby who has received multiple antibiotics, even we had an echo which was done outside was negative. So this was a Saturday, I still remember, I had to come for the rounds. We decided to give IVIG. That day echo, we did not have a cardiologist, and echo was done actually 2 or 3 days later, which showed multiple giant aneurysms, scary aneurysms.
Also, sir, I would like to add that this, what made this diagnosis even more difficult was that this BCG scar, the mother said repeatedly that this redness had persisted since the time the child got the dose. So maybe for the previous clinicians who saw this child, this was, they had to ignore this on the basis of this fact. It was not a reactivation, sir. It was there since the time the child got the dose.
We had a child, I think it was a 6-month infant, culture-proven UTI. The child had received ceftriaxone for 5 days. When I came for rounds on the 6th day, I said, why is this child so cranky? The child is getting antibiotics, the platelets are soaring high. Why is no other sign? It was a dark-skinned child, no rash, nothing. In a dark-skinned child, you cannot appreciate the changes. But why is the child so cranky? Even after day 6, running spikes of temperature, the platelets are shooting up to 10 lakhs. You give IVIG, then we'll do an echo later on. We gave IVIG, echo done, there were giant aneurysms. Yes, absolutely.
Starting from the range of abscess to pneumonia, everything were there, arthritis, septic arthritis, and associated KD also there. So infection, there is associated infection that doesn't rule out the diagnosis of Kawasaki disease. it can be infection associated also. And one point I'd like to convey to the audience that initial normal echocardiography doesn't rule out the diagnosis of Kawasaki disease. So most of the coronary artery aneurysms and coronary artery lesions develop in second week, after first week. So initial echo may be normal, and you shouldn't say at the comfort that initial echo is normal, so this can't be Kawasaki disease. So echo has no role in diagnosing Kawasaki disease. Echo has role in intensification and in stratifying and in prognosticating Kawasaki disease. Kawasaki disease is diagnosed based on the clinical and laboratory profile, and there are some soft pointers which have been mentioned: the BCG site reactivation, perianal perineal excoriation, and the soft pointers in the laboratory profile. So that we should be careful.
So I'll just conclude by saying that our comfort zone is in playing with antimicrobials. And that should not be a comfort zone, basically. Like whenever we have to change an antimicrobial, we should have a very significant decision making. Possibly, if we are using oral antimicrobial as a amoxicillin and next antimicrobial, we should be thinking 10 times if there are no sensible cause to hike up the antibiotics. And that is the take-home message. Rather, like that diagnosis can be anything. Diagnosis can be anything. Like it is not necessarily that every febrile child will be having a Kawasaki disease only. That can be there are several causes. But the important thing is that the antibiotics should be used very judiciously, and antibiotics should not be like that one like after another which we use. And if there are specifically when their cultures are negative, then at that time it becomes more mandatorily that we should use antimicrobials judiciously.
Moving on to our next session, I would like to call upon Dr. Neena Ghosh to chair on the topic, what is not KD?
Can you hear me? Thank you and good afternoon, everyone. We've spent most of the day trying to learn what can be KD and what is KD. You think it's a viral fever, it can be KD. You think it's a UTI, it can be KD. You think it's a measles, it can be KD. So now Jigna will tell us when it is not KD. What is not KD? I invite Jigna to the dais to tell us.
Thank you, ma'am. To be honest, I actually didn't think we'll have so many people at the end of the day, and I became a bit lax in this presentation. So I will try my best efforts to make it up by discussing, if any. And usually whenever we have a case, people say that, oh, this is a very textbook case. But then I would say my presentation is a very Dr. Pal presentation, I would say, because this is what I have been learning since my PG days when I was under him. So let us now unlearn what we have learned so that we don't overdiagnose KD now. These are audience questions so that I want more active interaction. Out of these three, which one do you think is not KD? 1, 2, or 3? Right, left, middle, or right? Right? It's true. And any... Correct. It's scarlet fever, definitely. And middle one? Middle one does look strawberry, I don't know, but then the mucositis is also there. Maybe the picture is not that well, so I cannot put two very good pictures to make it very obvious for everybody. So this is a little bit of a, this one, which is not KD. Less, it's true. So the difference between scarlet and KD, scarlet is a post-streptococcal upper respiratory tract reaction where the tongue is more involved, and you will, if you find, you will have the tonsils enlarged. Whereas in Kawasaki disease, the lips are more prominent. As I show, if we see this one, we see that there's crusting, there's hemorrhage, the left one. And the rash is scarlet paper-like, typical scarlet paper-like, a little generalized desquamation, whereas in KD, in the acute state, it's perianal desquamation, and in the later stage, we have periungual, which is sheet-like, and it's very classic. It really does come out like this. And we have actually had patients who maybe sometimes come with us with a history of fever of 22 days. No other signs at that time. Maybe there was a prior history of conjunctivitis and mucositis, but then they come and go. So by the time they come to us, we only have fever, and it's just sometimes only this desquamation if we see, and then we diagnose. So that also should be kept in mind, but then I shouldn't be talking about KD. So that was the difference between KD and scarlet fever. So I have one scenario with 3 different type of variations. So this one is a 4-year-old female with a fever of 6 days, mucositis, conjunctivitis, maculopapular rash. So the top part will usually remain the same in the next, the 3 variations. The first one is slightly irritable, puffy, hepatosplenomegaly. There is bilateral cervical lymphadenopathy. We have the hemoglobin, which is 8, lowish, normal TLC. Platelet is 90,000, CRP is raised. And SGPT is raised. What do you think? What are the possible DDs? I don't know. Anything else? 6 days fever. Okay. Okay, I'll go over to the answer. So next one is a 1-year-old female, similar findings, mucositis, conjunctivitis, puffy, irritable, tachypneic. The findings are same, almost same, SGPT slightly lower here. Okay. And this is a slightly younger one, 1-year-old female, similar thing, but active and well. Platelet is lowish, but the CRP normal. Here? Okay, so I will start off with the first one. So this is what, usually if we start off with infective markers, this was a case of a scrub typhus. So what happens in scrub typhus is that the picture is usually like this, like a KD, but then the total TLC is usually normal. Platelet is on the lower side. Whereas in Kawasaki disease, after the first week, the platelet starts rising. So that's one very core difference. Even it's a 6 days fever, so in KD it could have been normalish, but this is less than 1 lakh, 90,000. So we have to keep maybe scrub in mind. The SGPT is high. So that's what, this is like a scrub-like scenario. This one was a case of adenovirus. It is also similar, but that's why I added tachypneic. So that will help you. A history of cough, cold, you will have a URTI-like picture, and there will be a URTI, LRTI-like picture. So that's where it will help you. Now the point here is, I think this was discussed yesterday, is if the child was really sick and the fever was becoming more persistent, then, and the counts had become more lower, we should then consider infection-associated hyperinflammation, or infection-associated, what we call as what commonly is known as HLH. So that also should be kept in mind. So even in any infection, you can have HLH. And this is just a viral exanthem. CRP is normal. And sorry, this should be 1 lakh, my mistake. As I said, I went a bit lax in this presentation today. So I will take this back. Boogie on my side. So even a viral exanthem can be like this. we actually had referrals like PGs have become so KD aware that they start referring to us and we say, no, CRP is normal, so isko baat do, tum khud le lo, mujhe nahi jana hai. So next is, this is an interesting case which was a referral from PICU. A 3-year-old boy presented with a history of fever for 7 days, maculopapular rash, mucositis. So the referral was for incomplete KD. Then the investigations were hemoglobin is 10, TLC is 8,000, platelets are 80,000, SGOT-PT is raised. So we started thinking, is it really KD? Then obviously I was a fellow, we were like, it could be KD, but then obviously sir was there that day. The point here is that the differentials here. First of all, the eosinophils are a little higher. Platelets are low for a 7-day fever. In Kawasaki disease, by the 2nd week, the platelets should be higher. SGOT-PT is also raised. So we started looking into the history properly. It is a known case of seizure disorder on phenytoin. So it is a DRESS syndrome, yes. So I think I will avoid the theory bit. Oh, sorry, the answer is already written here. So 8-year-old boy, high-grade fever for 7 days, maculopapular rash, drowsy, desquamation, loose stools, pain abdomen, and hypotensive. Hemoglobin 10, total count is high with neutrophilic predominance. Platelets are a little lowish. LFT is, there is transaminitis. Again, this was also, we were giving our rounds. These are all cases that I have seen as a fellow myself. So we were giving our rounds and the PGT was giving, another unit, PGT was giving round and like, sir, do you think it is KD? Can you just have a look at this case? So an 8-year-old boy can have KD. It's not that it cannot have KD. Fever of 7 days. Again, platelets are lowish. So again, we started taking a proper history. It revealed that there was a history of sore throat. Tonsils were enlarged. We immediately asked, the child was looking a little drowsy. We immediately asked, please go and check the BP. So the BP was low, and we saw that the tonsils were enlarged, so it was toxic shock syndrome. And this is also a common differential. In fact, what happens, the difference between toxic shock syndrome is that if the child comes in frank shock, where you need inotropes, it's more of a cardiogenic shock, distributive shock, whereas in Kawasaki disease, it would be more of a cardiogenic shock. So this last one, 1 year, 9-month-old female, fever for 2 weeks, maculopapular rash, which subsided on its own. With this history, the child got admitted to us, and we saw that there was a history of conjunctivitis. If we see the investigation on day 5, the counts are high neutrophilic, platelets are also high, CRP is high, and on the day of admission, everything has increased. And echo was done, there was dilatation. So we were like, this looks like KD, so let's give IVIG. We gave IVIG, and the fever subsided. Then the fever reappeared after a few days. Then sir tells us, no, then this is SGIA. So why SGIA? So those of you who attended my talk yesterday on how PUO becomes SGIA, if I had said that any PUO with raised inflammatory markers and we have ruled out any other possible causes of infection, we have to keep inflammatory causes in mind, and one of them is also SGIA. So you see that day 5, 6 lakhs platelets. So in KD, what happens is you will not, again, we are not supposed to get such high platelets in the first week of the fever. So high platelets, high CRP, fever not going down, it is a case of SGIA, and then we started giving steroids, and that's when the child responded once we started the immunomodulation. So Z scores of 2.5 Z. So the dilatation is 2 to 2.5 Z scores, can be seen in febrile illnesses, it can be seen in SGIA, it can be seen in EBV. I think some infections do have a tendency for even higher Z-scores. So just because a febrile illness might have aneurysms or dilatations does not mean that it is always KD. So I don't mean to confuse anybody today because we've been learning all this, but there are subtle markers which we have to look that how the bloods, the supporting markers of bloods are helping us in excluding or diagnosing cases. So this was my last case, but then maybe I'll just have a little bit, a small talk, just a small discussion on how to differentiate between MISC and KD, even though MISC is vanished, but we are getting patients, it's not post-COVID, but some post-infectious MIC-like cases we have seen. MIC-like, it was completely a septic, MIC-like, I would say. So, even if it's not like, now they're not coming like KD, they will not come as KD, but they'll come like a septic shock. What we have to think about is a child with very high, with lymphopenia, as it was in MISC, high counts with relative lymphopenia. Then you will have other features like myocarditis, then hepatopathy, loose stools. That's when we have, and has not responded to antibiotics. You have to consider MISC and maybe you have to give steroids.
And coagulopathy was almost a very common feature with MISC, which we don't see that much with KD as compared to MISC. MISC had a lot of coagulopathies.
Yeah, and myocarditis is more MISC and KD will have more of coronaries. It's not that myocarditis will not be there, but then to some unknown infection. Yeah, that's it. I'll finish it today. We can.
Thank you, Jigna, for this nice interactive discussion. So I want to say one thing, that the role of the primary care pediatrician here is very important. The person who is actually making the first diagnosis, who's sending the KD patient to the rheumatologist or for an echo, is the primary care pediatrician, who is actually having to have that very high index of suspicion and that clinical eye. That's really important, because if we don't have that, then all the things that we learned today are not going to get implemented in time. We're not going to be able to do half the treatments. That intensification treatment is not going to work. Nothing is going to work. So the primary care pediatrician has to be more alert so that we can make more diagnosis of KD. Thank you very much.
Our next session would be My Most Difficult KD, and I would like to call on stage Dr. Shumantro Sarkar to chair this session.
Good afternoon. It's really very pleasing at the fag end of the day in the last program. We have so many audience. Thank you all. Without much ado, I will call our speakers in the session, the last session, My Difficult KDs, Most Difficult KD. So after all day long KD, even we have the most difficult KDs are remaining. So I will call upon Dr. Paramita Nath, Associate Consultant, Pediatric Rheumatology, Manipal Hospital, Mukundapur, Kolkata, for take the session first.
Thank you for the kind introduction, sir. Okay, without much delay, I just want to jump to the case. So this is actually my most memorable KD rather than difficult, because this was I saw this case when I was a trainee, postgraduate trainee to be specific. Okay, so and beforehand I am saying there are a lot of learning points which I found out from this case. This was in 2018 when I saw this case, and there was no AHA guidelines at that point. So the onset of the disease, the sequence of treatment, it's not according to the recent guidelines. Okay, so coming to the case, it was a 2-year-old child who was brought with complaints of fever since 9 days and redness of eyes since 2 days. And on examination, the child was febrile, he was irritable, pulse was 120 per minute, there was non-purulent conjunctivitis, periangle disformation, erythematous maculopapular rashes which was generalized, and rest of the systemic examination was normal. So coming straight to labs, hemoglobin was 10.6, which was almost normal. Total count was on the higher side with a neutrophilic predominance. Platelet count was also on the higher side. CRP, ESR both were raised, but although ESR was not much raised. Chest X-ray was normal, urine routine was also normal, and LFT shows hypoalbuminemia. So this child was diagnosed as incomplete Kawasaki disease, and 2D echo was advised, which revealed minimal pericardial effusion, left middle LMCA of 3 mm dilatation with a Z-score of 2.1 and LAD with a Z-score of 1.1. So for the course of treatment, this child was started with IVIG on this particular day along with aspirin, high dose of aspirin. After 3 days, the child was having persistent fever and there was worsening of Z-score. So initially it was thought of IVIG resistance and a second course of IVIG was given. But no further improvement, whereas there was further worsening of Z-score. And at this point, infliximab was given, but also at a lower dose, 5 mg per kg. And finally, after 6 more days, because of persistence of symptoms and worsening of Z-score, IV methylprednisolone was given for the first time. Pulse was given for 3 days, followed by oral steroids. So the story continues. The child, the fever continued on oral steroids, and second dose of infliximab was given at this point. And after remaining afebrile for few days, again the fever returns. And the echo reveals further worsening of coronary aneurysms. So at this point, cyclosporin was started, along with beta blockers, statin, and low molecular weight heparin. So after that, the child becomes afebrile, finally, after almost a month. So this is the lab trends. We can see hemoglobin initially it was 10.2, 10.6, but gradually in a decreasing trend. Total counts was always on the higher side with a neutrophilic predominance. Platelet again on the higher side. ESR was not very high, although CRP was also high. And after giving that second dose of infliximab and cyclosporin, it started declining. So this is the coronary artery Z-scores, the graph I have shown. On giving the first dose of IVIG, the Z-score were not that high, but after the second dose and even after giving first dose of infliximab clopidogrel, it continued to stay on the higher side till the first dose of IV methylpred, the continuation of the Z-score. So at this point, the second dose of infliximab was started and low molecular weight heparin, cyclosporin, statin was started. From that point, it started decreasing. So there were a lot of learning points from this particular case. That's why I included this case today. First of all, intensification of therapy from the beginning, which was not a concept at that time, 7 years back. And also, when should we, the importance of giving methylpred, infliximab and cyclosporin, consideration of that, even if the child is not an infant, if the child is having some high risk with an incomplete KD, we should consider those. So with that, I want to end my case. Thank you.
Thank you, Paramita, for a crisp presentation of the case. What will be the already have told the take-home message that our plan of management, the assessment of risk should be different from that was done in 2018. That's fine. So any other comments, Rakesh sir? Any comment on this particular case? Why it was so late in changing the G-score? Why there is no change initially, and then why in later there is a change later on?
So, sir.
And another question: why ESR was not high in this case?
Yeah, initially
And
ESR
also there
was
is an
not
anemia. Later on, the hemoglobin fell
started
to 8.
falling.
So even then, ESR was
Not
the lower
much
side.
raised, which was unlikely other than like the other KDs which I have seen later on. And the Z score, sir, so the idea of intensifying therapies is to prevent the giant aneurysm or dilatation of Z score. In this case, the first mistake was initially only IVIG was given. And once the Z score starts increasing, at that point, even if we are giving infliximab or cyclosporin, maybe we can't prevent that much. Maybe that was a mistake here.
Another point is, after giving IVIG, don't see the ESR. ESR may be falsely changed.
Elevated.
So that is
After
the thing,
IVIG.
ESR is not...
Right, sir.
Okay, sir. Rakesh sir, please.
So basically, the dose of infliximab has evolved over the time. So infliximab, the trial, initially Jane Byrne group has started with infliximab 5 milligram per kilo, and then because they have titrated the dose from 5 to 10. So the recent trial of 5 versus 10 also, which suggested that 10 milligram per kilo is associated with increased resolution of fever and associated with like the regression of G scores, and so that is possibly related to the higher dose is associated with the. And one more thing is that when we are giving infliximab after IVIG, because there is a lot of immunoglobulins are there in the body, so that at lower doses they can bind to the infliximab, and at higher doses like 10 milligram per kg, that phenomena is possibly not there, and that's why the dose of infliximab has not gone to the 10 milligram per kilo.
Okay, thank you, Paramita, for nice presentation.
Thank you,
so
sir.
Yeah.
So my thing is that with these anti-inflammatory, how much you are hiking, the ultimate coronary outcome doesn't change much. Maybe you are not, the progress doesn't happen more, but the ultimate coronary outcome doesn't change much. Isn't it so? The fever, effervescence, etc. occurs.
So what you are highlighting is that, like, what is the impact of immunomodulatory therapy on treatment intensification on the coronary artery abnormalities? So which is that there is there are two studies. One is that what happened to the regression of the coronary artery abnormalities, those who have received adjunctive therapy versus those who have not received adjunctive therapy. And this paper is from the Boston group. Dr. Friedman is the first author, and that study elegantly shows that if you do a treatment intensification with any of the therapies, that whether that would be a infliximab or steroids, that regression of CAs would be much faster. So possibly that is also an important thing, because we are seeing that what happens to these patients, but what happens in the follow-up, how they are behaving in follow-up, and how whether the regression of CAs are much faster in those who are receiving intensification. That literature is there. So impact on CAs may not be acute, or rather I would say it may not be there during that time, but they will regress faster, those who have received treatment intensification.
So the long-term effect will be much more than the acute effect, what you want to mean. So we will move to the next case, Dr. Anindita Nandi. She's a fellow, Pediatric Rheumatology, Institute of Child Health, Kolkata.
So after Dr. Jigna's what is not KD, again we are back to what is KD. So presenting with pneumonia. KD presenting with pneumonia, definitely a diagnostic dilemma. So some theory. KD is basically diagnosed clinically, so always there is an importance of clinical features, supported by some laboratory investigations. So I'm going directly to the cases. This is a 1.5-year-old male child who had high-grade intermittent fever for 5 days, cough and cold for 4 days, mild redness of lips as shown in the figure for 4 days, and breathing difficulty, lethargy for few hours before admission. There was no conjunctivitis, loose stool, rash, swelling of hands and feet, etc. So on day of admission, that is day 5 of fever, child was sleepy with saturation of 88% in room air with intercostal subcostal retraction, and there are fine crepitations on auscultation. Child was anemic with a hemoglobin of 8.8. Otherwise, platelet was 2.7 lakh. CRP was sky high, 225 milligram per liter, and there was sterile pyuria. So X-ray was done, which showed patchy opacity bilaterally. So child was put on broad spectrum antibiotics and nasal cannula oxygenation. 72 hours after starting antibiotics, that is day 8 of illness, mucositis, child became afebrile, but irritability persisted and there was mucositis, tachypnea was persisting, oxygen requirements was almost same. CRP a little bit low, blood culture by the time was sterile. Repeat X-ray show worsening after 72 hours of antibiotics. On day 9, that is the next day, child developed peeling. This typical sheet-like peelings on day 9 of illness. So, along with that, repeat count show raising platelet, CRP was then 10 only. So with these features, a history of diagnosis of incomplete Kawasaki was made. Child was started on IVIG and low dose aspirin. Antibiotics were stopped. 48 hours after completion of IVIG, child was absolutely okay, no irritability, first time maintaining saturation at room air, no respiratory distress, platelet become 10 lakhs, CRP decreased, X-ray show marked improvement after 48 hours of IVIG and stopping of antibiotics. So 4 weeks echo initial and through 4 weeks were normal. So learning point in this case is some features of the Kawasaki disease may evolve with time. So if the pneumonia even is not responding to antibiotics, we should think for Kawasaki disease. Case 2 is the 2-month-old female with fever for 6 days, cough and cold for 5 days, loose stool perianal excoriation for 5 days, and respiratory distress for 1 day. On admission, that is day 6 of fever, high-grade temperature, tachycardia, tachypnea, subcostal intercostal retraction, bilateral crepitation, and 4 centimeter hepatomegaly. Hemoglobin was 7.1 only. With hepatomegaly, tachycardia, tachypnea, so X-ray was done, that is at admission which showed right upper lobe pneumonia. Child was admitted in PICU, started on broad spectrum antibiotic nebulization therapy, 1 PRBC transfusion was given and put on oxygen. On day 8, that is 48 hours after antibiotic, fever still persisting, respiratory status almost same, X-ray show marked deterioration. Bilateral patchy opacities worsening was there. So antibiotic was upgraded. And oseltamivir was also added empirically. LP was done as a part of sepsis screen, CSF study was normal. That day evening in round, child developed this rash on trunk. Repeat count that day show increasing neutrophil count with platelet become 10 lakhs over almost 24 hours. Platelet become 10 lakh and CRP also raised. These changes was almost over 24 hours. So then we went to the history again and asked mother specifically for this sign, whether there was a redness. The mother said there was mild redness of the single eye and lips for initial 2 days of illness, and there was swelling for 1 day on day 4, which she did not tell previously, and nobody asked for that also. So here it was a complete Kawasaki disease. IVIG started with low dose aspirin, antibiotic was stopped. That day only, the BCG card changes occurred. There was scalloping, almost crusting at the BCG site. So after 48 hours of IVIG, child became afebrile, oxygen requirement, there is no oxygen requirement, CRP decreases, and this is the X-ray 48 hours after completion of IVIG. Echo initial and through 6 weeks was normal. The highlight of the cases, both were infant, presented with features of pneumonia, treated with multiple antibiotics before diagnosis of KD. They are not responding to broad spectrum antibiotic. Features of KD developed subsequently in the first case, and it was in the history, transient history of some features of KD was there in the second case. There are some literatures which showed definitely KD can be associated with pneumonia-like presentation. Even some infection can followed by KD. So pneumonia in the presentation of KD, or it is a syndrome or sequelae of disease, that is still a question. But in conclusion, KD may mimic pneumonia, hence it should be suspected in pneumonia unresponsive to broad-spectrum antibiotics, especially in association with progressive unexplained thrombocytosis, which was present in both the cases. So again, careful history and monitoring of the patient is very important, because the features of KD may be transient or evolving during the course of the illness. Thank you.
Thank you, Dr. Anindita, for nice presentation and a good take-home message. One case I remember, Dr. Priyankar Pal has published, I think, adenovirus with Kawasaki disease. So in the first case, I would rather ask for the viral panels, whether adenovirus and other panels were done, because that could be responsible for the pneumonic part.
Actually, the child was already on 2 antibiotics, and it happened over 2 days. When the child was admitted, we started antibiotics, 72 hours, child was plus minus improvement. We are thinking of doing that. We're counseling the party because it's an expensive test. But basically the CRP, high CRP count, so everybody was going towards
Could
bacteria.
also be responsible due to the adenovirus.
Yes, 225 count is possible. So
and
we are
after
already
day 3, even if you give antibiotics, it will not respond. Adenovirus will not
maybe
respond.
that time we could have gone for the adenovirus. But child responded so well immediately after starting IVIG, so we did not go for that test.
So I think Dr. Orchon was also telling that even if you suspect Kawasaki disease, even if there is the telltale features of Kawasaki disease, the infection may coexist.
Yes.
Or
yes,
infection may trigger. It
Kawasaki.
might happen that it was initially adenovirus that triggered the KD. So I must opine in this case. Yeah, we
But
have
we
to
treat
treat.
the KD and child responded dramatically
But,
over 24 hours. Yes.
Yes. So, that case, what you have published, adenovirus with that. So, in every case, I think if the patient present like that, so coexistent viral etiology must also be sought for.
Yes.
I think. Priyankarda? Yeah.
IVIG.
Thank you. One important information in our institute, Diamond Harbour Government Medical College, we have VRDL lab where free of cost 5 viral panels are being done, including adenovirus. Okay. So now these are done in the government sectors also. Also in North Bengal. Thank you. So, yeah, common viral panels like influenza, adeno, rhino, and your others? Metapneumo. Yeah, metapneumovirus also. So, thank you, Anindita.
So any specific precaution to send the sample for a distance lab, sir?
Yeah,
These are PCR.
Yeah, that's the difficulty in sending this lab to the labs. But
Practical
now I think the insight. Yeah. No, this is the insight for the PGs also. Yeah. Thank you, Anindita. Thank you, Anindita, for nice presentation. Now the last presentation, I will call the showstopper, Dr. Devashree Guho, Assistant Professor, Bardhaman Medical College.
Okay. First of all, thank you to the organizer for giving me opportunity to present my most difficult KD. And I know all of you are tired, overburdened after 2 days of hectic academic schedule. So I'll not take much time to present my case. So my case is the story of a 10-month-old boy, tiny boy, presented with history of fever for 10 days, which was low-grade intermittent. Along with paleness of the body, mother noticed during this time of this period of illness, no significant past history or family history, no history of any recent travel or any zoonotic exposure. On examination during presentation, child was found to have significant pallor without any organomegaly, no rashes, only bilateral submandibular significant lymphadenopathy was noted with 2 to 2.5 centimeter. Other systems examination did not reveal any remarkable abnormality. Growth of the child was absolutely within normal limit, with both are between 3rd to 50th percentile on age and sex appropriate growth curve. Child was treated outside as a case of UTI with cefixime on basis of few reports available, blood reports showing anemia, that is severe anemia, 6.8 hemoglobin percentage, neutrophilic leukocytosis, raised CRP, and urine routine report showing a parcel of 14 to 16 per high power field. So after admission to our hospital, we started IV ceftriaxone, plan for PRBC transfusion, and investigation reports, detailed investigation report were seen. When the investigation report come, it showed age inappropriate anemia, that is severe anemia with a hemoglobin of 5.4 gram per dl. Leukocytosis is present, platelet is borderline high, 4.3 lakh, RBC count low with reticulocyte index towards the lower range. On detailed investigation of the etiology of this severe anemia, it showed no nutritional deficiency, iron profile was absolutely normal, so as vitamin B12, folic acid level. HPLC of the parents report come to normal, DCT but negative. Peripheral blood smear and RBC indices showed it is a microcytic hyperchronic anemia and no atypical cells on peripheral blood pictures. Investigation blood reports of common topical infection found to be negative, so as urine reports, urine RECS absolutely normal, blood culture and throat swab for common viral organism showed no growth. Only positive findings, positive lab marker findings, we got that CRP, ESR and ferritin, that acute phase reaction, are to some extent elevated. Albumin towards the lower range, 2.9 gram, liver enzyme absolutely normal, renal function, electrolytes absolutely normal. We done chest X-ray, ultrasonography abdomen to detect any occult infection going inside the body. Both did not reveal any abnormality. So what is going on in this child? Presented for 10 days fever with inappropriate anemia, and on investigation report severe anemia with leukocytosis and acute phase reactants high. After admission, the clinical scenario changed dramatically. After 2 days of hospital admission, the condition of the child deteriorated with development of high-grade non-remitting fever, along with some maculopapular rashes developed on neck, trunks and extremities with some erythema of lips. Pallor getting increased and child become more and more irritable. So in spite of pallor, there is some erythema of lips noted. So we are thinking about some possible differential diagnosis at that point of time, whether we are dealing now with a case of drug reaction due to ceftriaxone, where there is, or it is a development of any mucocutaneous syndrome or else like MAS. So we thoroughly again examine the child for any new onset organomegaly, any lymphadenopathy, any signs of mucositis like conjunctival congestion, tongue, oral mucosa changes, desquamation, all was absolutely within normal limit, except the child is irritable, having more pallor, and some rashes appears all over the body, and child is have high-grade fever. So we plan for echocardiography and bone marrow aspiration. Lab parameters initially was done, that repeated again, that the day 1 of admission and day 3 of admission, there is remarkable changes seen on some lab parameters, like hemoglobin percentage, which was 5.4 on day 1, and on day 3, even after 1 unit of PRBC transfusion, it is still 6.1. There is leukocytosis persistence, platelet count remarkably high, 6.8. CRP, ESR got increased, elevated further from previous level. ESR is more or less same, near about previous level. Albumin is near about lower range, 2.8, and ALT liver enzyme, which was normal on the day 1, now get increased. So echocardiography if they done,
It showed mild aneurysm of left anterior descending artery with G-score of 4.6. NT-proBNP level, it showed mild, just mild elevation. So diagnosis of Kawasaki disease established, treatment started with IVIG 2 gram per kg of body weight and high dose aspirin, and dramatic response is seen with defibrillation within 12 hours. Bone marrow aspiration studies showed marked reduction of erythroid progenitor cells with normal leukocyte platelet Picasso and low blood cell. On the basis of this type of bone marrow aspiration report with reduced erythroid progenitor cell along with peripheral blood pictures showing severe anemia, low RBC count and reticulocyte index toward the lower range, we think of the possible etiology, and investigation showed that serum IgM anti-parvoviral B19 antibody is found to be positive. So, why I considered the case to present as a difficult KD? Because difficulty in diagnosis we faced during the course of the disease. So, we all, after the hectic day of Kawasaki day, we all know that the infantile Kawasaki presented with most of the time with incomplete or atypical presentation. Here in my case, during presentation, the child only have fever for last 10 days without any other features of Kawasaki disease. Initial lab parameters that may be suggestive of Kawasaki disease but not so much suggestive for my case. And presence of severe anemia at the time of presentation created again a diagnostic dilemma and dragged us to think some other diagnosis rather than Kawasaki disease. So parvovirus B19 infection as Kawasaki disease, we know various bacteria are viruses are studied as a etiological implication with Kawasaki disease. For my cases, parvoviral infection with Kawasaki disease, whether it is etiology or coexistent, I cannot conclude, but maybe the possibility the initial low-grade fever, but due to parvoviral infection, later it triggered Kawasaki disease that occurred after admission with 2 days, after 2 days of admission with high rise of temperature and some features of mucositis. So there are case reports and literature supporting the etiological association with parvoviral infection and Kawasaki disease. So references, and these are the case reports. So thank you for bearing with me.
Thank you, Dr. Devashree, for wonderful presentation. So, বুঝতে পারছিলাম না কি এটা পারবো কি পারবো না, তা ultimately it came as parvo. So, my question is, before Priyankarda say something, when the patient present with 10 days of fever with so much pallor, why parvo came into mind so late after doing bone marrow?
No. I present that after doing bone marrow, but we have sent the parvovirus antibody initially.
That's all.
Not that I presented that way, but not the blood sent before the thinking of it. Yeah. Exactly.
That's
so
all. That's from my
was
side.
DCT done for this patient? Direct
DCT?
DCT was negative.
DCT done to any autoimmune hemolytic, to rule out any autoimmune hemolytic anemia at initial stage.
No, parvo can have DCT positivity.
Yeah, DCT was
but
negative.
in that case, what DCT was
just
negative.
a couple of days back,
yes,
who had prolonged fever, sudden onset anemia, the hemoglobin dropped down to 3, and DCT was 3+ positive.
Okay.
So it was extremely difficult to transfuse the baby because nothing was matching.
Whatever transfusion is given, it is
So it was again a parvovirus. Mass.
Question from audience.
Mass. Parvo followed by mass.
No, but there was no features of mass.
No features of mass in this case. So only anemia, no leukopenia, no low platelet count, no features of mass. No examination, there was no organomegaly.
Platelet was going up.
Platelet are rather going up rather than thrombocytopenia.
So it was Kawasaki with parvovirus.
Yes.
Parvovirus may trigger or may coexist.
Maybe coexistence or
so
fever.
It was not
I cannot
proven.
conclude.
So any question from audience? The last chance.
all are tired after 2 days.
No, I don't think so. I don't think all are tired because after so 2 days of continuous academics, the hall is almost full. So it's a success of the conference, CME. Thank you all. Thank you, Devashree, for nice presentation. Thanks, organizers, for giving us the scope here to chair the session. Thank you all.
Thank you, thank you.
Some entertainment before we go forward with the most awaited award session. Now we would like to have our quiz session, and for that I would like to call on stage Dr. Paromita.
Okay, so actually this quiz was supposed to happen yesterday, so there are not much questions on KD. Okay, so you have to just scan this QR code. Once you are done, just let me know. QR code, okay, okay. Okay, shall I start now? Okay, we will start now. এখানে এটা দাও কিভাবে Okay, so 44 players have joined. Thank you. We'll start with the question. So, yeah. So you have 40 seconds to answer the question. The faster you answer, more marks. Okay, so which of the following histopathological features is characteristic of PAN in pediatric patients? Questions are easy to moderate, so. Okay, so yeah, most of them have give the correct answer. Moving on to the next question. Oh, sorry. Sorry. There is no Wi-Fi, sadly. That is why. So, which of the following lab findings is highly suggestive of microscopic polyangiitis? Again, an easy question. Okay. Still 18 people have given the wrong answer, ma'am. Anyway, so the correct answer is positive P ANCA. I'll move on to the next question. So after 10 questions, I'll show the leaderboard, right? হ্যাঁ ওটাও দেখাবো স্যার 20. So which of the following is most characteristic clinical feature that differentiates ERA from JIA? Okay. Again, most of you have given the correct answer. That is lower limb, predominantly asymmetric arthritis with fasciitis. So the rest of the features are seen in JIA except this one. So moving on to the next question. So which of the following vascular complications is most commonly associated with pediatric Behçet's? Is it pulmonary embolism, coronary artery aneurysm, DVT, or renal artery stenosis? Okay, so yes, it is DVT. The rest of the things are not usually associated with pediatric Behçet. Moving on to next question. So which of the following cytokines is primarily involved in granuloma formation in pediatric sarcoidosis? Interleukin 1, interleukin 6, TNF alpha, or interferon gamma? Okay. So the correct answer is yes, it's interferon gamma. Moving on to question 6. So which of the following is not part of IgG4 spectrum? Mikulicz syndrome, Riedel thyroiditis, idiopathic retroperitoneal fibrosis, or celiac disease? Again, an easy question. Okay. So celiac disease is the answer. Rest all are as part of the IgG4 spectrum. So moving on to the next question. So what is the typical underlying pathology which is seen in eye involvement of Cogan syndrome? So Cogan syndrome is a vasculitis which involves eyes with Meniere's disease-like features. I said only involve eyes. Okay, so the correct answer is interstitial keratitis. Yeah, this all can be associated with Cogan, even keratoconjunctivitis. So the next question. So which of the following antibodies is most commonly detected in pediatric patients with a positive ANA test who are diagnosed with Sjögren syndrome? Anti-dsDNA, anti-Smith, anti-Rho and anti-Jo1. Okay, so the correct answer, anti-Rho SSA. So question 9. So in terms of inheritance, Blau syndrome is classified as which of the following? Blau syndrome is it's kind of pediatric sarcoidosis. It is also an autoinflammatory disease. So what is the type of inheritance? Autosomal dominant, recessive, X-linked or mitochondrial? So it's an autosomal dominant disease. Okay. So this is question 10. After that, I'll show the leaderboard once and then at the end of the quiz. So what is the typical histopathological finding in bone biopsy of a patient with chronic non-bacterial osteomyelitis? This has been discussed yesterday actually. So is it granulomatous inflammation or is it lymphocytic infiltration with plasma cells or is it fibrous tissue with necrosis or bone marrow fibrosis? Okay, yes, so it's lymphocytic infiltration with plasma cells. Okay. Okay, so after 10 questions, Dr. Ritodip is leading, followed by Shubham Kunti. Okay, I'll move on to question 11. This is just a spot diagnosis. Okay, right. So I think everyone was able to identify Gottron's papules and heliotrope rashes, which I have shown. Moving on to next question. So which genetic factor has been implicated in the increased susceptibility to acute rheumatic fever? HLA DR4, DR3, DR2 or HLA B27? Okay, so the answer is yes, HLA-DR4. Moving on to the next question, question 13. Okay, so which of the following is absent in diagnostic classification of MVK deficiency or mevalonate kinase deficiency? Aphthous stomatitis, painful lymph nodes, chest pain or diarrhea in the diagnostic classification? MVK deficiency is an autoinflammatory disease, usually monogenic. Okay, so yes, chest pain is not, not the one which is in the diagnostic classification, rest all are there. Moving on to question 14. So, all of the following can be diagnosed as familial Mediterranean fever according to Livne criteria except only fever, monoarthritis of knee joint, joint pain alone, or chest pain with favorable response to colchicine. Right, so only joint pain is not, they cannot be diagnosed as FMF as per the criteria. Moving on to question 15. So which genetic mutation is associated with early onset lupus? TNF, RSF1A, TREX1, HLA-B27 or MEFV? Neonatal lupus or early onset lupus? नहीं. Okay, so yes, TREX1 is the one. TNF RSF1 is associated with TRAPS, HLA B27 we all know with ERA, and MEFV with FMF. Moving on to question 16. So which of the following is true regarding PFAPA syndrome? Associated with positive throat culture, responds well to colchicine, follows on irregular pattern of fever, or inherited an autosomal dominant fashion. Which is true regarding PFAPA? Okay, so the correct answer is responds well to colchicine. PFAPA usually responds well. They have a regular pattern of fever, not irregular. And it's not autosomal dominant. It does not have a inheritance pattern, and it may or may not have a positive throat culture. Moving on to question 17. So in Kawasaki disease, which of the following is a predictor of IVIG resistance? I think everyone will answer it correctly. Age below 6 months, early presentation that is less than 5 days, elevated bilirubin, or all of the above. As I said, everyone will answer this correctly. Okay, I'll move on to the next question. So anti-MDA5 antibodies in juvenile dermatomyositis are associated with which of the following? Is it calcinosis, is it severe myositis, is it ILD, or cardiac arrhythmias? Anti-MDA5 antibodies. So yes, the correct answer is ILD. Calcinosis is usually most associated with NXP2 positive and severe myositis with KIF1 gamma. MDA5 usually presents with ILD. Moving on to next question. So which of the following is responsible for autoimmunity in Epstein-Barr virus? Molecular mimicry, polyclonal B cell activation, upregulation of co-stimulatory molecules, or is it antigen cross-reactivity? Okay, yes. So the correct answer is polyclonal B cell activation. Last question of today. So which of the following antibodies correlates with psychosis in systemic lupus erythematosus? Sorry, the question is not complete here. Is it anti-dsDNA, ANA, anti-LA, SSB, or anti-ribosomal P? Which correlates with psychosis in SLE, systemic lupus erythematosus? Okay, yes, the correct answer is anti-ribosomal P. So let's check the leaderboard. Okay, congratulations, Ritadi. Second is Shubham Kunti. And third is Oishik Mukherjee. Okay, thank you everyone for staying back so long, and we will move forward for the award
Section. Before we end, thank you everyone for staying back for such a long day. We will move on to the award section and quiz winners, please wait. Photographer?
So I think we had an enormous number of abstracts this time. So considering a state conference, I think we had almost 55 abstracts together for the Kawasaki and the Rheumatology days. And since Kawasaki, we had 12 abstracts, so we made all them oral. But the Rheumatology, we sent them to blinded abstracts to 3 pediatric rheumatologists all over India. 2 from CMC Vellore and 1 from Avinash, his DM Pediatric Rheumatology in Shimla. He's in Dharamshala, yes. Huh? So on the basis of that, on the basis of the markings, so we decided to select for the oral and the poster presentations. And finally, I think the results are out. Jigna, can you announce the results? And we had 2 separate sections for the case presentations and the original research.
We'll start off with the e-poster.
E-poster.
E-poster, original research in the rheumatology, which was conducted yesterday. Third prize, Dr. Riju Bhattacharya. Which college? Wait. I'm not. Which college?
ITGM.
Second prize, Dr. Reshmi Malik.
From which college? IPGM. Oh, very good.
First prize, Dr. Riaz.
So what was Ria's paper?
So my poster was a retrospective study that we have done in SGI patients. It was done over 1.5 years. 52 patients of SGI were diagnosed, and we saw that 3 patients of SGI had pericardial effusion. And all these patients actually had a very difficult course, all required intensive treatment, and conclusion was that we are not sure yet, but is pericardial effusion a marker, like prognostic marker, bad prognostic marker in SGI? And if it is so, if we diagnose pericardial effusion early, so can we add biologics early in the treatment of SGI? Thank you.
So next is e-poster clinical cases. Third prize, Dr. Madhura Mukherjee. Suparna ma'am. second prize, Dr. Ujan Basu. Which college? The first prize, Dr. Shukalpa Sarkar. Shukalpo Sarkar.
Here, the RAG1 mutation in SCID with autoimmune hemolytic anemia.
So we now move on to all the oral papers. So there were 4 slots of oral paper presentations: rheumatology, original research and cases; Kawasaki disease, original research and cases. So I'll start off with the original research, rheumatology section. We are giving first and second in that. So second prize, Dr. Shantanu Jana. Second was actually tied, so other second was Dr. Rifa Khan. First prize, Dr. Natasha.
That was an energetic presentation.
Next, we'll go on to the original research of KD Day. So second prize, Dr. Shaini Pan. First prize, Dr. Oishik Mukherjee. So next is the award paper presentation, clinical cases, rheumatology. Second prize, Dr. Maria. She's from Apollo. First prize, Dr. Shubham Kunti.
I take the honor of giving to Shubham.
Award paper presentation in clinical cases, Kawasaki disease. Second prize, Shomo Shubro. And first prize is Snigdha Moral. he just completed her rheumatology rotation. नहीं बेटा तो কুইজের সার্টিফিকেট কোথায় রাখলাম नहीं ये छोड़ो बाहर से दे देंगे बोल ओके आई डोंट रिमेम्बर एक्चुअली কারা কারা ছিল না থার্ড দিয়ে শুরু কর কৌশিক দেবাশিস দে তো কুইজ কুইজ থার্ড से शुरू करो সার্টিফিকেট একটু পরে দিচ্ছি খুঁজে পাচ্ছি না হ্যাঁ मैं लेके आई थी सेकंड प्राइज who was it Dr. Shubham Kunti quiz how to make না ওই ঋতুদীপ First prize, Dr. Ishik Mukherjee. Oh, sorry. Dr.
You give. You go. So now for group photo, please, everyone come.